I think, Jain sir, we are live on YouTube now.
Yeah, now I think we can start. Okay. Very warm good morning
We
to
can start now,
everybody.
sir.
Yeah,
Yeah.
yes. Very warm good morning. Just good morning to everybody, all participants, renowned speakers, and experts. Who, um, my voice is audible, isn't it?
Yes.
Okay. Okay. So that today is the third day of this telemedicine webinar. First talk will be on clinical application of telemedicine by Dr. N.K. Agrawal. The second will be blockchain in healthcare by Dr. Bhagwat Singh. And third talk will be Mr. Mayank Agrawal on telemedicine, what really works. And fourth will be Mr. Satish, televital journey and the latest trends in telemedicine. Telemedicine and privacy will be delivered by Bhag Mrs. Chapuhan, Rabat. And the last session will be concluding session with panel discussion by the experts. So I request all the participants, please join till last. That will be very much interesting and you will have a lot of information about this. I am V.K. Jain, of Chairman Broadcast Engineer Society of Ahmedabad chapter, and I have about 36 years experience in ISRO space application, heading the many divisions. And also I am actually hardware developer. So I have delivered many hardware for INSAT and GSAT series of satellites. So those are in the space. I first speaker is Dr. N.K. Agrawal from BHU Varanasi University. Dr. Agrawal is the MD in this. Is a MD in endocrinology. So I request Mr. Mathur to introduce him, please. Mathur, you are going to introduce?
Okay. Yeah, thank you, Jain sir, for giving me an opportunity to introduce Dr. N.K. Agarwal, who is from uh, BHU, Varanasi. And let me first thank Dr. Agarwal sir for accepting our request to be with us and deliver a talk in spite of having his busy schedule at the institute. Dr. Agarwal has done his MBBS and MD in medicine and DM in endocrinology. So he is a expert, as we have in Ahmedabad, Dr. Parag Shah. This,
Yes.
Yeah.
so,
He's in our
because
panel, ISRO panel, Dr.
yeah,
Paraksha.
2 days back only I met Dr. Parag Shah, so I know that same field. So currently he is Associate Dean Research at Institute of Medical Sciences, Banaras Hindu University, and Professor in Department of Endocrinology and Metabolism. He is also a nodal officer of Regional Resource Center and that too of Eastern Region, Telemedicine at IMS BHU. Dr. Agarwal, I think he is very much interested in a lot of research and he has done a large number of publications, more than 105 in national and international journals he has published. More than 1200 citations are there and in various books also he has written. I think 3 books which he has referred, 3 books he has written related with the subjects and presently he is examiner for DM and DNB in endocrinology. So other than practicing doctor or a practicer telemedicine expert, he is having a lot of interest in academics also. And he has got a lot of interest in research also in the field of diabetes, thyroid, reproductive endocrinology sector. So with this, I'll hand over to Mr. V.K. Jain.
Thank you, Mathur Saab, for introducing Dr. Agrawal. So, doctor is a renowned doctor from the BHU, and he has vast research experience. So he's having telemedicine exposures also. So I think this talk will be very much useful to the audience. And kindly, I request him to deliver the talk, and also request participant you can interact after the talk and have your questions. Please, I welcome again Dr. Agrawal for the today's first talk. Please.
Thank you, Jain sir and Mathur sir for inviting me and introducing me to this august audience. Can I share my slides?
Sure, sure, sure. You have got?
You can do it, sir, now.
You can do it.
So at the outset,
Sir, you can make full screen, sir.
Yeah.
Okay, now for perfect.
Yeah.
Visible. Thank you.
So as we know that the communication between two people is nowadays very much possible at a very close quarters, and it has now been electronically shortened, and we are just talking to each other. So healthcare communication also has been possible from time immemorial, and to the extent that we can use the communication for exchange of views in medicine also. So we call it as a telemedicine. So it improves the quality of healthcare in patients. It builds a virtual community of physicians and increases the convenience, efficacy, and decreases the medical cost. The American Academy of Family Physicians, they take two concepts like telemedicine and telehealth. Telemedicine is basically a use for the particular patient, and telehealth is a wider service from a distance. So AAFP supports the expanded use of telemedicine as an appropriate and efficient method of improving the health when conducted within the context of appropriate standards of care. So that's following the standards of care is very important. So how it helps us, it evens out the reach. It many people who are in the remote and rural areas, they have a struggle to access the timely and good quality specialty medical care. So the residents of these areas can have standard access to the specialty healthcare, like they can contact endocrinologist just by mentioning the glucose values. So there could be decision support, there could be education, there could be clinical trial virtual visits. I will elaborate on it. And there could be researches based on telemedicine. So the forms of telemedicine could be in interactions between the doctors to the paramedics, doctors to patient, and doctors to the patient group, or paramedic to the patient. Doctor to doctor communication could be related to a case, and they present the case. Like we have the curriculum in PG and post doctoral, so they can have case presentation as a part of the education or as a part of the CME programs. Then journals can be discussed, opinions on the controversial areas can be made out, the stalwarts can be approached for their expert opinion, workshops can be organized, or live surgeries may be done, like armed forces can use them at the battlefield and battle casualties can be minimized. Recently, for the COVID-19, we in UP developed the facility of hub spoke model, where the VHU was an advanced hub for giving the consultations to a second hub, that is Prayagraj, and Prayagraj was giving the consultations to L1 and L2 government hospitals. So we were running a ECCS facility, and we are still running that facility. So we can give the consultations to various forms like email or consultations received over the phone. Then clinical application can be doctors to the paramedics and paramedics to the patient. Doctors to paramedics, like nursing instructions can be given to the ICU, general nursing care, or instructional teaching to the nursing students and nursing faculties can be done. There could be specialty nursing care involved in a special situations of the patients, and the treating doctors and specialists may suggest some or other nursing care for the patients. Then disaster relief and management can be done through use of proper high uh, speed internets to the areas of disaster where the proper care can be delivered with a easy method. Then there could be nursing call centers where patients may be given a nursing care, like hospice triage, home care triage, ICT devices can be there. There could be nursing facilities for when to get admitted, how they are getting referred, pre-screening for tests and procedures, uh, post-operative procedures calls, follow-ups of the patients. Then new medication or treatment compliance is important. So it can be seen that new medications are properly taken or not. Then complex and chronic case management can be there. Then physician practice triage, like if we want management of the patients who are coming to the facility, and how they are coming, when they are reporting, when should they meet the doctor, all these things can be managed through telemedicine. Disaster relief, ISRO developed the Gramaset network at 8 islands long back with the help, and they involved GB Pant Hospital, INH Dhanvantari, and Bishop Children Hospital at Car Nicobar. So these facilities were being developed by our country long back. Telemonitoring of healthcare facility can be done because they virtually the patients can be seen by the doctors at the other end, and the local physician or the nursing care can assist the doctor in knowing the parameters and implementing the advices. Then paramedic based telemedicine services, they are also important, and they can reduce the burden on the physicians. Many queries can be solved by the paramedics, what the patients want to listen for their queries, they may be given by the paramedics. This improves the quality of care rather than going to a non-trained paramedic. If they go for the paramedic who's been trained, so they may follow the current guidelines, and then this will improve the quality. Then doctor to patient is also being done right now. When the patient is far from hospital and seeks expert medical advice and care, they can connect with the specialist, super specialist doctors through online mode. It saves unnecessary travel time. Many times, only just for a follow up or visual cue to the doctor, they are coming. So this may cut the load on the hospital. And in Corona period, we do not want a large number of patients entering into the hospital premises. So we can reduce the load. And if the physical examination is very necessary, the patient can be called to the hospital. Minor ailments can be handled virtually and treated, advised remotely, and local physicians can be helpful. Then there could be surgeries which can be helped, like telemedicine can play a pivotal role in live surgeries, where specialist doctors can't reach the OT but can give tips to the during the procedure, or can assist the live OTs. We can have robotic surgeries, and the patient can be attended virtually for post-operative follow-ups unless their physical presence is much needed. The ICU care has also been improved with the telemedicine, and we can have the experts giving the various tips and advices during the ICU care of a particular type of patients, or life-saving activities can be telecasted through the net to various places. Lower level hospitals and health centers can be trained for first level health emergency situations. We can have life support workshops for the patients. Then activities of ICUs can be easily monitored. We can create stations and we can monitor various ICUs remotely. The gynecology and obstetrics are very important that we are being monitoring, and then the particular field can use well women visits, preventive care, pre-conception counseling, family planning, including contraception, medical abortion, infertility workup, teleradiology, cervical cancer screening and colposcopy, mental health, telesurgery can be done again in any ECGs, telecardiology. This can be transported by the ICT methods, and blood pressure monitoring system and ambulatory blood pressure monitoring system is applicable. Then they can transmit their data, and the doctors can assist that when there is a masked hypertension. We can say masked hypertension when the patients do not become hypertensive during the clinic visits, but they become hypertensive in the house. So home BP monitoring can also be effectively implementing the prognosis of the patient. Other branches like my branch can utilize for glucose monitoring, thyroxine management, like changes in the dose. We can just hormonal testing and hormonal monitoring and adjustments can be done. Similarly, gastro, nephro, pathology, radiology, these are all branches, all can use telemedicine. Doctors can also address to the patient group. I'm an endocrinologist. We can address the group of patients of a particular, like diabetes, thyroid, and we can give advices what to do or what not to do and how to do it. Special instructions to a particular patient can be given. Then they can have patient self-help groups, and this all improves the quality care. So all information transmitted and patient is at their convenience. So quality care can be given. We have been doing telemedicine in this COVID era, and we have supported 52,000 teleconsultations, and we have been given ISRO Televital, and this has been through the efforts of the central government that the two pilgrimage sites were identified, like Kashi Vishwanath temple and Vindhyachal Mandir. So for the Kashi Vishwanath, they have given it to the divisional hospital, and Vindhyachal Mandir has a CSC nearby. So they have been given ISRO Televital system, and we are using it. Once we of dermatology, endocrinology, medicine, orthopedics, pediatrics, cardiology, and post-surgery follow-ups, etc., through Televital and telemedicine. And we have been finding possibilities to train medical professionals linked to RRC and to handle emergency conditions, conducting various virtual sessions of life-saving demonstrations. And this is a hub for providing teleconsultation to health and wellness centers of UP through Sanjeevani. I was discussing the drug trials and use of telemedicine. So we sometimes plan a phone visits in the whole methodology of conduction of drug trial. So this virtual visits can be through telemedicine or through video conferencing. So patient visits, data collection, serious and non-serious adverse study monitoring or independent data monitoring, these all can be done through telemedicine and through dedicated software. The telehealth benefits have been immense. Like McKinsey said, over $250 billion of current US healthcare spend could potentially move to virtual providers over the next years. There is access to care for the patient and becomes the faster access to regular checkups. Like you may not go to a doctor for glucose checkup every now and then, or you may not want to pay for the consultations every fortnightly, but these virtual visits may be used, and they can have a regular checkup. The service cost could be teleconsultation is less for $38 versus $114 for a face-to-face meeting. Then IoT sensors and remote healthcare applications can be devised like Zoom telehealth services. They can care for the particular type of diseases like cardiac diseases they can have. The telemedicine applications could be like you can get a second or third opinion of a from anywhere in the world. Virtual exercise rehabilitation assistant can be provided, so we can someone is doing physiotherapy, and are they doing the physiotherapy in a correct way, or their movements are made to the extent it should have been. So these are all can be governed and assisted. Radiology, cardiology departments could fully rely on artificial intelligence for analyzing test results, X-rays, CT scans, and other diagnostic tasks. We can have watch ECGs. Apple Watch has to say for atrial fibrillation. We can have fundus photography. We can send it to the ophthalmologist for expert opinion. All said and done, there are some barriers and challenges to the telemedicine facilities and its applications. Like their doctors are not very legally protected till the.
I think your PPT is not visible now, sir. Please take care. Dr. Agwal, are you able to listen me?
I think, sir, he has lost his internet connection, so maybe he'll be joining.
Yes, because his email was frozen. So, Mathur, can we call him? Or some participant who is nearby him can inform him.
No, I'll call him. Just wait for a few minutes. He may join also.
Okay. Some network problem probably. He needs to be re-entered probably.
वो हमको देख पा रहे हैं. He says, I am able to see you all.
but we are not listening his voice and
हाँ, मैंने कहा वॉइस भी नहीं आ रही, प्रेजेंटेशन भी नहीं आ रहा है, तो
फिर से
ये
ज्वाइन करवाओ ना, नहीं तो फिर
दोबारा
से
ज्वाइन कर लेंगे।
हाँ और तो कोई है नहीं। व्हाट मे बी द प्रॉब्लम चिंतामणि?
Maybe I don't know, sir. Maybe some.
He's able to see us. Yeah, I was seeing his image was frozen totally.
Correct.
This,
Maybe there is some uploading rate, downloading rate is different. Internet.
okay, so bandwidth may be the issue at least.
Yes.
Dear participants, please bear. Dr. Agarwal is again joining us. He was discussing about the barriers and challenges in telemedicine. A few slides we lost him.
आप दोबारा से ज्वाइन करके देखिएगा एक बार। हाँ हाँ, अगर नहीं हो पा रहा ना तो आप एक बार मोबाइल से ज्वाइन करके देखिए। मोबाइल से ज्वाइन हो सकते हैं ना, तो आप मोबाइल से बोलिए, मैं आपका पीपीटी यहाँ से दिखा दूंगा।
We can show your PPT, sir.
माथुर एंड जैन साहब, थोड़ा सा पीपीटी लगा के हमको पढ़ने दीजिए।
बैरियर नहीं, मगर उनकी आवाज भी तो नहीं आ रही ना सर।
ठीक है, दैट इज इन
वो दोबारा से ट्राई कर रहे हैं ज्वाइन करने की, नहीं तो मोबाइल पे आ जाएंगे और मैं उनका पीपीटी दिखा दूंगा। चिंतामणि, कैन यू गिव मी परमिशन टू लोड?
ओपन करके बैरियर एंड challenges.
Yes, sir. Already there is a permission allotted.
Allotted. Okay,
Yes,
so
yes,
I will
sir.
try to
Share screen.
share.
Thank you, Javis. Sir, you had good suggestion yesterday. Also,
always you should have an emergency preparedness plan, no?
yes, certainly.
These days we have the telephone to computer transition hiccups. ये तो बढ़िया है सब। Thank you very much.
Yeah, can you see the presentation now?
Yes, yes. Make it
Yeah,
fully.
yeah.
Go to barriers and challenges.
Yes, sir.
Right.
Okay, I'll change it.
That is, participant will be engaged. Next.
Anyone of you can read out if it is required. Otherwise, you can read ourselves.
No, let he should speak.
Tell me where to stop.
I will tell you. Hey, go ahead.
Okay? No?
Yes, go ahead. Go ahead. अभी और आगे जाइए। हाँ, इसके बाद yes, go ahead. Go ahead. Go ahead. Go ahead. Go ahead.
खत्म नहीं हो जाए प्रेजेंटेशन?
नहीं चाहिए फंड, ये तो वो बोल चुके हैं।
हाँ।
Other, go ahead, please. Yes.
Yes.
Okay.
No, we can read it ourselves. No.
Yeah, we can read it, but
I'll tell him he can join on mobile.
Yeah, बोल दो कि पीपीटी के लिए ट्राई, मतलब वो नहीं करें, डायरेक्टली ही कैन जॉइन इट।
Legally protected.
As explaining, directors are not legally protected. Situation is really, मतलब
very important.
Yeah. बट इन्होंने एक सर की बताया कि कहीं कहीं और टेली कंसल्टेशन का चार्जेस कम होता है, बट दिस इज मतलब reimbursed by the concerned department and honored by insurance company. Tele consultation, anybody can tell?
The guidelines give that insurance companies
आप
are
मोबाइल से ज्वाइन करके बोल दीजिएगा कि मैंने आपका प्रेजेंटेशन लगा दिया।
So guideline
मोबाइल से ज्वाइन करके
guidelines
आप
of given by the government on March 2020 say that insurance companies should support telemedicine.
नहीं, बट सब वो अभी तक मतलब हुआ है,
मतलब मोबाइल से ज्वाइन कर रहे हैं।
They've given the guidelines that insurance companies should support this.
if the cases are being followed, then it is very good, because people are concerned about their money. They should be reimbursed, or that
Reimbursement is must. The government has given the approval. March 2020 guidelines
very good.
released by the government of India, no, March 25th.
Chintamani, can you check up? He must have joined through his mobile.
Yes, sir. He has joined.
Okay.
I have already admitted him. It just takes some time. Come in the main meeting room.
No, is it possible to have a circular issued by Ministry of Health Services that all the doctors utilizing the telemedicine
The business.
medium should be made legal? Like if a circular is given, so the doctors will feel comfortable, and also the professional bodies also can take up the issue of popularizing it. That would be a very simple action that can be taken.
I see a advertisement on TV, the Star Insurance Company. They clearly say that you can consult on telemedicine also.
Okay, that's great. That's great. Good observation.
Yeah, the guidelines say that you can consult and it's legal. Only thing is patients consent and the doctors, they have to identify each other.
Achha, achha. And is there any registration for the telemedicine service to be provided?
No, it is basically if you're a doctor, you will have a registration number, no? That is sufficient. It is recognized by the Indian Medical Council. So that registration, but teleconsultations have to be within India, not outside India. This doesn't cover outside India. If you were doing
But the doctor has to get registered for telemedicine's license.
no separate registration.
No separate registration.
Okay.
Because only
So you can speak. I've already put your
But
PPT.
only applicable in
Yes,
India,
yes.
not outside India.
Okay.
Teleconsultations outside India are not covered.
I think he is joined now. He'll take over.
Foreign countries' fees are very high.
Yeah.
Yeah.
Yes, Agarwal sahab, you can continue.
Yeah.
एक डिवाइस आप बंद कर दीजिए अग्रवाल जी.
Yeah. So I was to challenges. So these challenges of internet connectivity are there, and there are software glitches also. We recently had it. The doctor-patient ratio is still a challenge. Many doctors are not there for particular specialty, so patients have to contact them. Then established clinical protocols, training, and global compatibility of equipments must be developed so that what we see and what we get and what we interconnect is important. Next. So this was my presentation. Thank you for patient listening. I'm very much sorry that it had last moment had a glitches.
Thank you, Dr. Agarwal. Actually, the challenges has already been proven about this connectivity issue, related issues.
I think technical people, those who are attending this particular webinar now, they should note these type of points. Suppose if a doctor is doing a operation and things are being transmitted to some other place, how can he control if these things fail?
Yeah,
It means the system is not reliable. Telemedicine system is not reliable.
I think
In
that
normal consultation it is okay, but if some important event is going on or he is guiding some operation, so he'll be in problem. Finally, patient will be in problem.
like first S.K. Mishra told he needs higher bandwidth for the tele-robotics application, etc. So such things should be, I think technology should look into this thing. Now I invite the question, sir. Yeah, JV, you posted.
I want to thank Agarwal ji. इतना अच्छा आपने हमारे लिए वो अंडमान निकोबार and for Northeast. We did not know this. It's highly educating. Many thanks for that. और मेरा एक सुझाव है. I hope I'm comfortable to talk in Hindi.
Yeah.
Okay. Why to take the London Telephone Exchange? I thought. Okay. देखिए डॉक्टर अग्रवाल जी, मेरा learning ये है from this problem we faced just now. Virtually you were replaced by Mathur Saab because he posted the PPTs and we could discuss over it, especially the issue of barriers. And my question is this, sir. I remember one incident quickly. I'll take about 30 seconds to say that. When I was traveling from Mumbai to Paris, when Malhotra ji, the pilot, allowed me to visit the cockpit. And you know what they do? These people, there will be a maintenance engineer always with the pilots. He'll be sitting 90 degrees to the pilots. He'll be having manuals. He'll be looking into all the manuals each time, because every time they cannot go to Boeing or Airbus. So what I want to infer from this is, Agarwal ji apne तौर पर एक manual बनाने से step by step, the paramedical staff will not be so much skilled, and also the nursing staff will not be so much skilled, but a manual will be very handy, a very simple manual. See, those days we used to have the computer manual when the computer was introduced. आजकल तो online learning हो रहा है. मेरा बच्चों लोग इतना जानते हैं, we struggle, me and my wife, when we do online classes and things like that. So reference and request is to prepare a manual, very simple manual. Even the nursing staff, paramedical staff can refer it whenever required. इतना बेहतर होगा. In fact, the doctor will be virtually giving them all the confidence. ये तो confidence है ना, ये बहुत फर्क हो जाएगा. Thank you, sir. Kind of you.
Thank you, sir, for your suggestion.
Yeah. Agarwal sir, you want to comment? So it's okay. I think he has already replied. Acha, sir, Dr. John and Mr. Mehta, Sanjeev Mehta, doctor have already replied. I'm again putting the same question to you. With your challenge, this thing. You told that $38 for consultation fees against $145. So these things are honored by the insurance companies, and those where it is reimbursed, or it needs any additional approval. They have replied, I want your opinion. And any cases are there pending, or a dispute or quarrel? Cases are not, your case is not.
I'm not aware of the insurance companies, but once I see in our own institution, yes, the teleconsultations are not being honored for reimbursements.
Oh,
They want a handwritten by the doctor. They want the cash memo. They want whole bunch of papers. Still, they are saying ERP will be doing. So we are not very, and accounts will not forward your bill without it is physically there.
No, but those papers can be generated by doctors and those things. Those papers can.
So this we have to yet to develop the whole system scenario where the consultation prescription is all
honored.
Consultation and videos, consultations and papers and prescription are formatted in a way it should be, because we are not getting the prescription in a specific format.
Okay, thank you.
Dr. Agrawal, can I intervene here?
Yes, sir. Yes, sir.
Dr. Agrawal, just when the COVID started, Government of India has notified the TPG, called Telemedicine Practice Guidelines, for all the disciplines of medicine. One is the allopathy, another is homeopathy, Ayurveda, and neuro, all those, psychiatry and other things. Wonderful compliance. Especially, I'll draw your attention to allopathy part of it. All the required format of e-prescription, consultation protocols, each and everything has been detailed there, including the issuance of receipts. Okay, though yes, that was required in the case of COVID, but that if TPG, which you can use as a doctor legally now, since April 2020, yes, you can. And we are fighting, the government of India fighting for working on the insurance part of it. But however, some countries, I don't know, others may know, the issue of telemedicine, teleconsultation by insurance companies is also being actively taken up. Dr. Atta is there, he is more familiar with all these aspects.
Yes, Sangal Sahab, good morning to all of you. There are a couple of comments that I wanted to make. One, the telemedicine practice guidelines, which were released by the Ministry of Health and legalized through the National Medical Commission, through the Professional Conduct, Etiquette and Ethics Regulation of 2002, which has been amended, and that has legalized telemedicine. Now, in that, what they have left open, and have not said yes or have not said no, is cross-border consultation, number one. Number two, very clearly they have left out the telementoring for surgery from distant places. It is not yet official, it is not yet legal to do that kind of practice. One, as Dr. Mishra earlier said, you need a greater bandwidth, which the country is not yet ready. And two, it's not yet legal. But that was version 1. In the version 2 of the TPG, there is every possibility that all these little hurdles that we are experiencing will be overcome. Now, the third hurdle is the prescription drugs. Prescription, as Sangal Sahib said, is possible to write, but what you can write are limited. Every specialty in this country is not covered. There are some just basic drugs over the counter and few emergency drugs. So that list is also going to be under revision over this next year or so. Now, lastly, if you come to the point of the fee part of it, there are the only Star Health and Bajaj Allianz are the two insurance companies that reimburse for telemedicine. And the doctor, when he gives his prescription on the telemedicine portal, is also expected to collect his fee and give a receipt for the same. So it is all there officially. And only these two insurance companies are accepting. The government insurance companies, National Insurance, Oriental, United, and a dozen other private have not yet got into it. I'm sure that this is the right time and this is the right approach through this medium that the Insurance Regulatory Development Agency authority has to be informed that since it is legal, telemedicine is legal, all insurance companies must reimburse teleconsultations. And I think that will solve the problem.
Doctor,
To add one more point, sir, to what you said. Actually, the other one they left out is emergency. In case of emergency, you can give only first aid.
Correct.
Should not be treated. Emergency cases should not be treated by tele.
Those have to be teletriage.
Yeah, teletriage.
Correct. Dr. Ratha, I was talking about one more thing. See, you were talking about cross-border telemedicine. Are you talking about the cross-international telemedicine or cross-state telemedicine? I think cross-state is allowed, is it?
See,
within the country?
See, the thing is that we are running a Pan-African program, telemedicine program, which means the government is already doing allowing teleconsultation from whole of Africa to via Pan-African network. Then we have the SARC network. Then we have the BRICS network. That means all these countries are already doing teleconsultations with Indian doctors. Also, CME from India is being relayed to all the countries within this network. Now, it's just a matter of time. As I said, the TPG, this was the first version. Because of COVID, it was necessary, social distancing, not wanting to go to the hospital. Some modality had to be provided by the government. And as you know, Sangal Sahib, PSI has been working for last decade trying to bring a telehealth act through a bill. But then the government was more smarter than us that to legalize it, they found a route via Ministry of Health and National Medical Commission, which was an excellent, brilliant thought from Niti Aayog. And I think we must congratulate them to have got this thing started, even though we are a decade late compared to the rest of the world.
Yeah, in emergency use, I think COVID has taught a lot of lessons to us. One is you can use the medicine, you can use the wax without waiting for final approval under emergency conditions, but you continue to use it. That's one thing. Second thing is you start using telemedicine under the emergency conditions. The notification has been made by Government of India under the emergencies, and it's being used now very regularly. So I think emergency is required in the country. Okay.
You see, the armed forces are using it from Siachen glaciers down to Himalayas and in Uttarakhand and Himachal, etc. So when there's an emergency, only the telemedicine is definitely required. So if you have doctor at the two ends, it makes life easier in an emergency. If it's only a patient calling in an emergency, then you have to try it. But on the opposite end, if you have a doctor with you, then emergency telemedicine is legal. That's not an issue.
Sangal Saab, one small counter to your joke. When National Disaster Management Act was revoked, emergency has been in position. And the pandemic rule of 1 century old has been updated so much, you have now leapfrogging effect. In the name of National Disaster Act, you can do anything and everything beneficial to the health of people.
I think that's
emergency is already there. I'm just making a small rejoinder to your joke. The emergency is already there.
No, it's good. Emergency, wonderfully. COVID has taught us a lot of lessons,
Yes.
But anyway,
any other participant?
I'd like to add one more. See, what he had said, he had not mentioned much about ophthalmology. Ophthalmology is image-based diagnosis of many of the conditions, especially diabetic retinopathy. All over the world, diabetic retinopathy is done through telemedicine because it's just image-based. So many of the ophthalmic conditions, I'm from Shankar Nethralaya, I'm an ophthalmologist. We used Indian Space Organization satellite dish only, and we had mobile vans right from 2003. It's only by 2011 we started using a little bit of internet connectivity. Whether it's satellite or internet, the connectivity problems always existed, which is technical. But for diabetic retinopathy, it has been very, very useful. Telemedicine has been very useful, especially in ophthalmology. And it's used world over. When they go to a diabetic clinic to image the eye, a fundus photograph is taken and imaged.
Madam, thanks for educating. I have one small request in this session to all the distinguished professionals. We lack basically documentation. So there's a 2-page best practices documentation by UN. Just 2-page, 10 fields. See, the moment we document, for example, in this session, I have put my email. If you kindly share your emails, see, it will help a big way in networking each other and knowing what each is doing. Kindly do share your emails and your affiliations. Thank you very much.
Now let's stop this.
I have one question, Agarwal साहब से.
Yes.
अग्रवाल साहब, ये जानना है आपका जो टेलीमेडिसिन सिस्टम है BHU में, who is taking care of its maintenance part of it?
Maintenance is we had government grant in aid.
UP government is giving you grant or ISRO is giving you grant?
ISRO is maintaining Televital.
Okay.
Then from Ahmedabad itself, it is being managed, and we have a whole RRC is managed through the Government of India Ministry of Health, and we have NHM UP giving us for 5 medical officers. And we are conducting their virtual e-Sanjeevani OPD and hub and spoke model health wellness centers. So we are doing all these things.
Okay, thank you, sir.
Thank you, Dr. Agarwal. You have elaborately explained everything about the various fields of the medical science which can be used by the telemedicines like gynecology, ophthalmology, and your own subject of endocrinology. With this, many fields can be used, can have telemedicine easily, except in where the telesurgery is required for the high bandwidth and those things for a critical area. And I'm happy that you have done about more than 52,000 teleconsultation And also you are using ISRO platform, ISRO Televital platform for your application. We are extremely glad and proud to know that ISRO is helping to user in this extent. Now, thank you very much once again. And now I invite the next speaker. So next talk is on this thing is a blockchain in healthcare. This will be delivered by Dr. Bhagwant Singh Rata. I request Weber Rao to introduce about Dr. Bhagwant Singh. Please come.
Okay, thank you, sir. Am I audible?
Yes, yes. थोड़ा सा voice थोड़ा ऐसा ही है, but it's okay. Not a powerful.
Dr. Ratta have joined.
Yeah, he was discussing. Yeah.
Okay, okay. Thanks. Oh, sorry. Sir is there. Okay. Good. Right. Okay. So thank you, Mathu sir and Jain sir, for giving me this pleasant duty to introduce Dr. Bhagwant Singh Ratta. It is indeed a great pleasure to introduce the speaker of the morning session, Dr. Ratta. He is a pediatric surgeon trained at the Great Ormond Street Children's Hospital and the Institute of Child Health, London. He has an extensive experience, which is more than 30 years in pediatric surgery, urology, including complex pediatric urological problems. Intensive care management of newborns, including parenteral nutrition, ventilation, pediatric endoscopy, and minimal invasive surgery in children. His special interest include antenatal diagnosis of congenital malformations in the fetus and management of congenital malformations of the urinary tract. He has co-founded a wellness company in 2012 that has conducted health risk assessment of over 10,000 subjects on site. He was the president of the Telemedicine Society of India with 13 plus years of experience in telemedicine, including organizing multiple TSI conferences. He played an important role in creating the course content of a telemedicine certificate course for D.Y. Patil Medical College and University of Pune. He was instrumental in designing the children's wing of Royal Hospital, Muscat Sultanate of Oman, a neonatal wing of Great Ormond Street Hospital, London, the new building of Ruby Herbal Clinic, and the pediatric floor at Sahyadri Hospital, Deccan at Pune. He played a key role in setup of pediatric surgical services in Oman, along with Mr. R.D. Spicer in 1985, and pediatric surgical services in Ruby Hall Clinic, Pune in 1990. He has successfully built and managed a leading pediatric care clinic in Pune. He is experienced in running clinical trials and he is a certified robotic surgeon. Today, Dr. Ratta will talk on a very interesting topic of blockchain in healthcare. The blockchain technology having a huge potential to transform the various sectors. His viewpoints in its role in healthcare must be worth noting. With this, I invite Dr. Ratta to deliver his today's address, and we are eager to hear you, sir.
Thank you. Thank you, Vaibhav. Thank you very much for this wonderful introduction, which I don't deserve. Thank you. Let me share my screen with you. So, are you able to see it?
Yes, but you can make full screen, sir. You can start if it's not possible to make because
Yeah. Yes,
control health also.
Yeah.
Okay, so I'm basically based out of Pune from Ruby Hall Clinic. I've been a past president of TSI many years ago. And before we start something new to discuss like blockchain in healthcare, let me quote our ex-president, our ex-late president, Dr. APJ Abdul Kalam. The science that we work for today must have the innovativeness, foresight, and the vision for it to be the center of technology that will develop tomorrow. In whatever field we work, we have to remain in the service of the common man, whose well-being is central to all human knowledge and endeavors. With these few words, I'm going to cover the topic of blockchain in healthcare by introducing what is blockchain, what are blockchain technology, what are how blockchain is used in healthcare, what are the use cases, how transaction is done, what are the benefits, drawbacks, challenges, and the way forward. So let's look at during this COVID pandemic, what has happened is that COVID-19 has put global economy into a tailspin. There is a big shift taking place in the healthcare industry. Blockchain can create massive social impact in crises like COVID pandemic, with remote access and telehealth services being sought after. That to tackle issues such as hospital overcrowding, social distancing, accessibility to digital solution is more important than ever. However, teleconsultations not only require remote access, but a secure way of transferring information from patient to doctor and doctor to patient. This, coupled with the growing usage of mobile health and remote monitoring devices, presents an opportunity to leverage blockchain technology. Cost and quality are the bane of healthcare industry, putting great pressure on regulation along with market disruptive technologies that are competitive and futuristic. Blockchain is evolving and has breakthrough capacity to resolve many healthcare industry woes. The healthcare ecosystem in India is disjointed, complex, care-oriented, with least GDP spent amongst emerging markets on infrastructure, wide gap in rural-urban manpower, and non-participatory approach to healthcare delivery. There is always a question, WIIIFM, YFM, what is in it for me? Till then, I'm not ready to move. So patient-centric, we talk about patient-centric approach. That's very true, but I feel the wheel needs to move from this jargon to patient, provider, payer-centric. They are all important in the value chain and how this can be achieved. If the patient-centric approach is provided by the doctor through a coordinated care and is transparent with the payer, it has a great potential to reduce cost and improve quality of care. Hospital information systems world over have consumed millions of dollars, but has yet to resolve security, robustness, and seamless integration of multitude of participating organizations across different parts of the globe geography, partly due to ever-changing requirements and government regulations, laws from time to time. So instead of designing a centralized repository, if focus is shifted now to distributed, personalized storage model with patient controlling and authorizing her data, security will be enhanced, hacking will be difficult, and it will prove to be a game changer. That's where blockchain technology can provide the foundation stone for global interoperability. We've been talking about interoperability for such a long time. Here is an opportunity to us right now. So what is blockchain? It's a system of recording information in a way that makes it difficult or impossible to change, hack, or cheat the system. A blockchain is essentially a digital ledger of transactions that is duplicated and distributed across the entire network of computer systems, which may also be called as nodes on the network of blockchain. You can see here on the diagram, the blockchain transactions take place and how these blocks then form a chain, and then it moves from peer to peer network to ensure data security. You can also look at how these transactions are recording, writing on a ledger, because in blockchain, you can write infinite number of blocks. There is no limit to the blocks. And it
kindly move the slides, sir. Are you able to move the slides?
The slide is not there.
Let me see.
Yeah. Only the blockchain first slide is being displayed all along.
Yeah, just one second.
So maybe you can, are you sharing a PowerPoint presentation or a browser?
PowerPoint.
So you can stop sharing your presentation and then you just share the PowerPoint presentation or your entire screen.
Otherwise,
I think the only browser window is shared right
now. I am here with you all.
Right. We can hear you clearly, sir. Only your presentation is not visible to us.
I see. Just give me a minute.
Yeah.
Mathur, are you listening me?
I am seeing only the blockchain slide.
Yeah.
Yes, I too. Everybody is seeing blockchain. The first slide, blue. No.
नहीं आपके पास यदि presentation है
अभी आया.
Yeah, now it has changed. Second slide has come.
I don't know, but it will.
Go ahead, Dr. Atta.
Okay, sir.
Okay, you just run 2-3 slides, then we'll see whether it's moving or not. Manually, I think you have to do probably.
Are you able to see now?
Yeah, we are able to.
Yeah. Go ahead, Dr.
Yes,
Atta. It's okay. It's perfect now. You are on contents now.
Yeah.
You can move the slide.
So we talked about that.
Introduction. What's blockchain? Yeah.
Now, can I?
Yeah, you are scrolling. The what is blockchain and
Yes, slide number 6 is there right now.
Are you able to see that now?
Yes.
Okay, so basically, blockchain is a kind of a database that provides you a list of records, transactions like a ledger, and that keeps growing as more entries are added. Are you with me? Can you all?
Yes,
sir. You can go ahead. Yeah.
And,
so this blockchain gets distributed because how it happens is that it makes copies of the entire database and it's stored on multiple computers or multiple nodes on a network, which is syncing within minutes or seconds. Adjustably, it's transparent because records are stored in the database. They may be made visible to relevant stakeholders without risk of alteration. It's highly secure because any hacker or malicious actor can no longer just attack one computer, one node, and change it. He will need to change on hundreds of nodes, which is impossible. And it's immutable because it has a mathematical algorithm which make it impossible to change or delete any data once it's recorded and accepted. Anyone trying to make a change will be visible to everyone. That's why it also becomes auditable. So what is blockchain in short? It is at its core an infinite and immutable data ledger. The data on a blockchain is stored and repeated onto different unrelated nodes, creating a decentralized database that cannot be altered or controlled from any one node. So it's a strict record-keeping technology that provides transparency and auditability by design. It adds more levels of oversight where issues can be quickly flagged. Imagine a patient record in a hospital or a clinic, which is written by an indelible ink and is password protected. It will record names of everyone who has opened, edited that file, and information is available anywhere, anytime, any place. It can also integrate data from all types of healthcare services and thousands of healthcare ecosystems working in silos like doctors, hospitals, clinics in compliance with strict data privacy and regulations, of which we've been harping about since so many years. In short, it is cryptographic or encoded ledger comprising a digital log of transactions which can be shared on a private or a public network. These are the types of blockchain networks that you can do. So what does it do? As peer-to-peer network is combined with a distributed time stamping server, the blockchain databases can be managed autonomously. There's no separate administrator required to sit there and manage all this. In fact, the users are the administrators and they are the owners of their own data in a blockchain. So blockchain recently developed a bad reputation. You must have all heard about the cryptocurrencies, the crypto bubble. That's how an average person thinks of blockchain as something vague, puzzling concept that doesn't have much of an impact on his life. In reality, this technology will soon play an interesting role in keeping their electronic health record accurate and safe and will be interoperable. This is what we have been looking for so many years. It is safe, but it is very safe, and there'll be seamless switching of patients between providers. And it will also enhance the use of augmented reality, virtual reality in healthcare education, which we need to impart, especially when we are dealing with shortage of manpower. From 2009 to 2017, almost 176 million data breaches have occurred in the healthcare records. This will be very enhanced data secure technology. It can trace, it can secure medical supplies, health insurance claims, and should also be in a position to do consent management, building patient trust. It has the potential to alleviate one of the major challenges of healthcare industry, the transmission of patient data across the globe without compromising its privacy and security. This application of blockchain can have a major positive impact on member health management and provide a critical link in support of medical tourism, which can bring in billions of dollars to the country. Healthcare industry is under pressure to regulate cost and provide higher quality of care to patients. This competitive technology can be disruptive It's a relatively new technology, but together with other technologies such as big data analytics, Internet of Medical Things, 5G, which is in the offing, machine learning, artificial intelligence, it can help healthcare improve its traditional approach to health data handling and supply chain transparency. If you now look at how the patient-doctor-centric journey begins, it is full of trust, and it gives empowerment, ownership, and rights to the patient for her data. It's totally transparent, so you can audit the trail from where if anything has gone wrong. The transaction takes place instantly. It is very safe, tamper-proof, and that's the future blockchain technology, which has already been used in our country, but in a very limited space. And I'm glad that Niti Aayog, Aadhaar, GST, etc., have all been built on this technology. And that's why we are enjoying the fruits of Aadhaar and the GST and the others. For some reason, my slides have gone off.
Maybe so you can reload your page.
Okay, if you'll just give me a minute.
I think we have lost connection with Dr. Atta. Mathur sir?
Yeah. Let us wait for a few minutes.
Okay.
He may rejoin.
इनका PPT नहीं है अपने पास?
नहीं.
Okay, otherwise we could have.
I think उन्होंने PT भेजा नहीं है. मैंने आपको मार्क किया, उसमें नहीं था ना कुछ?
मैं फिर से फाइल खोल लेता हूँ.
Sir, he has rejoined.
Rejoined. Okay.
Okay. Sir, please unmute your mic. Dr. Atta.
आवाज नहीं आ रही.
Please unmute.
You are muted. You are muted. Dr. Atta, you are muted. यहाँ administrator has muted everybody, I think, including him.
No. You are audible, Sangal. How we can mute you?
सर वो म्यूट करके भी आपकी आवाज आती है.
Collective people करते हो भैया. जैन साहब हमेशा आवाज आती है. जैन साहब की, माथुर साहब की आती है.
Sir, Dr. Rata, if you are not comfortable, you can mail us your PPTs and we'll run from here.
That might just take a time.
Yeah, I think now it's clearly
It's
visible.
coming. It's coming.
But your system appears to be slow, sir.
Yeah, that's right.
You are the memory issues. I don't know, sir.
Okay, we discussed this.
Yeah.
So basically what I want to tell here is that blockchain is not a single cryptocurrency. You can have hundreds of cryptocurrencies on it. It is not an enterprise database. It is not totally private. Individuals are anonymous, but transactions are visible to all. It's always public. It's distributed, visible, open, transparent. You have a consensus, and only then you can add. You cannot change anything.
Bengal sir, please mute. Yeah, thank you. Thank you. Sir. Thank you. You have already muted.
Am I audible?
Yes, yes. Yes, sir. You are audible.
All right. All right. So let's back to the same problem.
Sir, please share your PPT, sir. It will save a lot of time and it will be very useful for us to learn.
All right.
Please email, it takes minutes.
1 second. Can you give me your?
माथुर साहब का email है ना आपका पास? भेज दीजिए.
Yeah, you can note down mathur@gmail.com.
It will be done in 30 seconds.
Yeah, I agree my email ID in that WhatsApp group also.
Yeah, 1 second. I will forward. AC Mathur at
No, not AC Mathur, Mathur only, MATHUR.
Yes.
ISRO, continuous.
Okay.
I have written in chat box also, chat box I have mentioned.
It's a very big file, probably that's why it's not.
Or maybe just try if it comes on email, we can.
No, you please make it into a PDF because it's a 59 PPTs file. It will be very enormous.
Yes.
Please make it into PDF and send it. It will come quickly and you can wait for it. And your slide we are reading. We are also engaged.
No problem. We have got enough time for your talk.
Yeah, you can, meanwhile, till he loads the file, you can describe something. You can, orally, you can speak, sir.
First, let him send the file.
You send the mail. Meanwhile, Mr. Mathur will load. Okay.
In the meantime, you can have some other discussion. You can take comments.
No, I would like to initiate a small brainstorming till our speaker comes over. This is like this blockchain technology. It seems to be very decentralized database. And who will be having the protocol? I mean, who will be the custodian of it? That is one issue I wanted to just know.
Okay, in any case, I mean, besides the blockchain technology part of it, which you can see is basically they are blocks. We create blocks, and these, if you are in the same transaction, same consultation with the same person, it forms another block, and it continues as a chain. But since patient controls his block and he is the administrator, he may want a second opinion, and he can very easily give the key to a new doctor saying, look, I consulted Dr. Ratta and I am unhappy. I want a certain clarification, or I want a second opinion. Am I on the right track? So a Dr. Ratta can do nothing about it, but the patient can and has the right and is the owner of his data, and he can do that. Similarly, if, for example, I have diabetes, I have taken 3 months recording of my diabetes. Now, why do I have to go to a hospital to show my findings when telemedicine is available, and I can, on this platform of blockchain or any other, get the doctor who is available to me at his time, at his convenience? I have booked an appointment. So he's very much able to see me, see my records, and continue giving me advice over the phone. Now, there can be many live use cases that we can do. So, for example, now many of us were hospitalized during COVID times, and there were issues going on with insurance, paying, not paying. Sometimes it's taking 15 days, sometimes it's taking 2 weeks, 4 months, 2 months because you have sent a paper details to them.
Yeah.
So the amount of time the claims are taking to be settled on medical insurances that people have had, it's a big disaster. And how can an electronic claim take 14 days? Why can't it be done in 2 days or 3, 1 minute? Today in bank, you can transfer amount from any account to any account in minutes and seconds. So why should insurance claims take so much time? That is where the blockchain brings in what is called as a smart contract. And in this smart contract, it will contain a logic that will represent payer, that will represent the payer, provider, contract terms.
Yes, sorry for the interruption. I have got the file in the email through the link.
Okay.
Yeah, can somebody tell me how to download it from the link? I have opened the file. I have to download and then only share.
Sir, yes. Dr. Ratta can just click on this resume slideshow. Maybe it may work. We can just start. There's a small window on the top left corner.
Yeah. Okay, for on this screen.
On his screen.
On his screen.
Yeah, there is a resume slideshow option.
Yes, I did that. It says pause.
Okay. All right. So you just click on the link.
I have clicked on the link. A file is open. I can see the slides, but I'll have to download, no, to share.
Yes, you will have to download.
So there is an option usually on the top drop down arrow.
That I'm not seeing. Blockchain is more export. Export is okay. I think maybe export or rename.
I think it's now became a full screen for. Are you able to change?
Okay, what I will do, I will share my screen.
Yes, sir. Please.
Then it will come.
Yeah.
That way I'll do. Okay. First, you'll have to be out from the. Yes.
If I pause my share, you can show it?
Yes, you'll have to pause. You'll have to come out from that share screen option. Then only I can share my screen.
All right.
Chintamani, also you can enable multiple share. Yeah.
I have stopped share.
I've already done that, Vaibhav.
Okay, I am trying to share the screen. Is it coming?
Yes.
स्क्रीन तो आ रहा है. फुल स्क्रीन करके देखो माथुर.
हाँ, अभी फुल स्क्रीन का ऑप्शन इसमें नहीं है, because it is a PDF file.
कंट्रोल L करो ना प्रेस.
कंट्रोल L.
हाँ, कंट्रोल L में PDF से फुल स्क्रीन करेगा. यदि मेमोरी शॉर्ट है.
No, control L is not working here.
Okay, चलो फिर जो भी दिखा रहे हो.
Okay, which slide number, sir? Should I go 10, 11?
Yeah.
Blockchain. Should I go further?
Yes, you can go further. We have discussed this, yes. Now, this blockchain in healthcare, you see how the entire value chain is being shown. Now, in the value chain, you have pharmacy, you have insurance, you have hospitals, you have doctors, you have clinics, and you have your own patient who is with a key in his hand. You can see that, right? Now, we were discussing further beyond. Next slide.
Okay. And also slide also is not being. Last slide has come. Oh.
So if you can go up.
Yes.
Yeah. You can go up still. Yeah, go up. Go up. Yeah, go up. Yes, you can stay there. Now you can move to the next slide. Yes.
Should I move to next one?
See, I was talking about smart contracts. We talked about the problems with electronic claim and the paper claim, which takes a lot of time. Now, in the smart contract, what happens is that you put in a logic that will represent the payer and the provider contract terms. And as soon as claim is submitted, this claim is processed in real time and the payment is transmitted to provider. This automation improves efficiency, brings in transparency and autonomy that blockchain technology can provide. So this can lead to disruption in the way business is conducted compared to what happens today. I am discharged by my doctor in the morning at 10 o'clock. By the time file goes through the hospital network and insurance, and by the time I'm given a green signal, it's evening 7 o'clock. So I was discharged at breakfast and I reach home at dinner. And 8 hours, 10 hours. So all that can definitely be brought to rest using blockchain technology between payer provider so that the patient gets empowered every time and his privacy is secure. Next slide. Now you see in medical insurance, it's a sizable market in India. Very high fraction of funds is lost to fraud and inefficiency. The Indian insurance market is over 84 billion US dollar. As soon as I'm just lost 1 second. You see, in the medical insurance sector, it's very important that we understand what are the current problems. In spite of its size, growth, importance, the market suffers from very old archaeological system and broken processes that are opportunistically exploited by few parties involved. Now you will understand when I say insurees make multiple claims from different insurers for a single loss. This is practical what we have seen. Insurees withhold information from insurers that may affect their premiums. Insurance brokers will pocket the money which is not meant for them, the premiums. Insurers request for compensation for services which are never submitted and or upcode services which are rendered into higher prices. Suppose you are getting a fee of 10,000, you will upgrade the code so that you get paid 15,000. Now, these kind of exploitation goes on. So it is difficult for a stakeholder coordination. Multiple parties are involved. There are consumers, there are brokers, insurers, reinsurers, with complex interactions, lack of interoperability across databases, and lack of socio-political will to collaborate, because it's fear of free riders and unequal benefits from the collaboration. Next slide. It's very slow process. It's a manual process many a time. Even if after the requisite data is shared across the party, claims need to be settled and payments need to be made. This takes time as money changes hands using banking systems which are separate from the insurance information system. They don't talk to each other. And that's where the delay comes. And that's where frustration comes in. And each party must then manually update their system once funds are available. there is a strong financial incentive to exploit the system vulnerabilities. There is a lack of system to discover fraud in real time. Now you see in Ayushman Bharat, the government has already built in to discover fraud from hospitals that are not recognized or recognized but not providing service, charging the government for services not provided. So that kind of fraud system can be introduced through blockchain in the insurance, and then it will be real time and all parties can be held accountable. We are talking about billions of dollars in insurance premiums. Insurance systems need a reform. First, we need to digitize and securely share claims data and other associate data like the health records for health insurance. There are so many times patients come back for follow-up and we ask them, where are your records? Sir, sorry, we don't have the records. Insurance people have taken away all my records and I don't even have duplicate. Secondly, we need to codify the business rules. Once you codify the business rules, automate the claims processing such that payments are automatically and quickly transferred when claims are verified. So if we understand all these causes of the problem, blockchain can be a big help in the healthcare sector. Now you can also look at another sector, such as the drug supply chain. We can go to the next slide, please. Look at the drug supply chain. Next slide. Next slide. So insurance sector, you understood, right? How blockchain can help. Now, similarly, you look at the drug supply chain. Somebody is manufacturing, from the manufacturing point, it has to go to the formulation section, from API to formulation, then to the wholesaler or the person who is sitting outside the city octroi limits, having huge godowns to store these drugs. They are called the forwarding agents. Then from there it comes to the wholesaler, then it comes to the retailer and to the patient. So there's a big supply chain. Now anybody can alter in this supply chain and they can add counterfeit drugs, they can add spurious drugs into this supply chain. So the National Informatics Center has designed and implemented drug authentication and verification application called DAVA. This is based on GSI 1 standard for drug tracking and traceability system. This is based on Global Trade Item Number, GTIN, and serial numbers provided by manufacturers for identifying various hierarchy levels for product packaging. The aim is to improve India's image as a world leader in production of same pharma products by providing real-time visibility of drugs manufactured and exported out of India. What happens is the entire DAVA system rollout will include more than 2,000 manufacturers of pharmaceutical companies. So barcoding at primary level is optional, but barcoding at secondary and tertiary level will be compulsory. So while DAVA provides for information about products at manufacturing level, which can be verified by other stakeholders, however, it was found that it may not encompass the full functionality that blockchain can do it for you. For example, it does not ensure visibility of each transaction to all the stakeholders in the value chain. And that is of immense importance when we are dealing with multi-stakeholders. We are talking about multi-location, shifting of drugs from manufacturer to different cities, multi-location, and each drug company may have multiple products. So in such a scenario, even DAVA developed by NIC is not going to meet the target as what blockchain technology can do in this supply chain process of the drugs. Next slide, please. Now you see that what are the problems? Can you go to this screen on your right hand side lower down and enlarge it? Is that possible?
You want enlargement of the figure?
Well, if for you all to read, I don't know if you all can read anything about it.
I don't know. There is no option.
So on the right bottom corner,
where it says 45%.
55, you
just,
to
just
55, 65, something of that
just
sort.
beside plus sign.
Next, yes, next to plus sign.
Yes.
Up. Right, up.
More chat. No, I'm not finding anything like that.
So
anyway, what I'm trying to say is that
actually that first of all the file is to be downloaded. I think then only it will come. Now I have opened it through the link only.
So you have the time, you can do it while I'm talking and explaining this slide. You can download.
No, download also you have to give permission. Usually the person who is sending through the link, no, he has to give permission for others to download.
I see. Okay.
Then only I can download it.
All right. So anyway, basically the API manufacturers, they have to generate a unique code for the API. Then only the information can be stored on the blockchain. Otherwise, it will pass away. And the formulation manufacturers, what they have to do is to verify the API that it has originated from the API. They kind of generate a formulation code. Once it generates the formulation code which is linked to the API, that information is again stored on the blockchain. Then the forwarding agent and the wholesaler, they will verify the origin of the formulation. And that information is again stocked on the blockchain. And nobody can change all this. These are all immutable transactions, blocks. Which
I could get, yeah, something is there.
Yeah, this is the one. Go ahead. You can increase from 70% to 80%. Yes, one more. 90. I think this is okay. Fine.
Yeah, okay. So you should be able to just next.
Is it okay?
Roll down.
Yeah, you
next.
You can.
Okay.
Yeah, so you can see how the information gets stored on the. No, you don't see the full screen, Mathur sir. Next to the plus sign, there is a box there.
There is a box.
You click that.
Yeah.
It should open up.
No, it has become down now. After pressing that, now I will increase again.
Yes.
No, it goes up.
And then click that.
Then I increase karo ke puri slide
no, after clicking that box, now again it becomes to original position.
Yeah.
So there's one more option I see on the top beside share option. There is the play button, orange play button on the left side. Yeah, just
yes.
Maybe
I press this.
Yeah, just try.
Share go.
Yeah.
Perfect.
This is okay.
Perfect. All right.
Yeah, this is okay.
This is okay.
So you can see how the pharmacy chain, how the blockchain is going to create blocks, and all that information cannot be changed. When it comes to the patient can verify the origin of the formulation, information that is stored on the blockchain, and this kind of technology can prevent drug repackaging, substitution with fake drugs. The document, location, and temperature from Internet of Things devices is attached to these packages so that you know exactly whether a particular drug was transported at a certain temperature or not. This is very useful when it comes to the vaccine part of it. So let's see the vaccine part of it. Next slide, please.
Sputnik especially.
Now you see in vaccine logistics, how from the manufacturer, it goes to the national store, then to the state, then to division, then to district, then to PHC or community health centers. Now, what happens there are the major challenges. For example, if you look at the next slide, implementing and immunizing, go on to the next slide.
Now, please.
When we implement this kind of a massive vaccination program, like we have done in the past for polio, now we are trying to do it for the COVID. And similarly, we can be ready for any eventuality in the future if we can get this whole system right. So Niti Aayog tried to form this use case as an example, but there were certain challenges with the provisional original logistics which they had. So the accuracy, reliability, real-time data, vaccine supply chain. Now, when we are talking of accuracy, reliable and real-time data, there has to be constant monitoring on the state of vaccine coverage and consumption at multiple levels in order to facilitate the planning of how many vaccines are needed, where they are needed, who is to be responsible for accepting it. Then you look at the vaccine supply chain, whether this can only save life if they remain cold at a certain temperature. If their temperature is changed, then the entire vaccine is of no use. So how do you take care of that? So through Internet of Things, you can attach the thermometers to this supply chain. And when it reaches a final destination, you know exactly at what temperature you have received using blockchain. Similarly, you have a network of health workers and incentive system to motivate them, to hold them accountable. So blockchain can be a very useful technology there. Similarly, when there is data incompleteness and tardiness, it doesn't work. So health workers in the field and at health clinics, they forget to enter the patient data. Simple thing. They forget to enter Aadhaar number while vaccinating an individual, or they enter it incorrectly, one digit goes wrong, then entire bad name comes to COVID or to the PS entire system. So this is also true for cold chain workers. So some kind of an incentive system can work beautifully for this via the blockchain. Also, you have fragmented data and lack of interoperability across database throughout the nation. So there's no way to reconcile immunization coverage data from the supply chain. So the manufacturer says, I have supplied 10 crore. Government says we have vaccinated 8 crore. There is a gap there. There's no way to reconcile. How you reconcile your bank statement once every month? Okay, I have spent here. This is not what I have spent. So you can reconcile here with immunization utilization. Well,
वो पावर गया लगता है वहाँ का।
rejoin again.
उनका मुझे लगता है पावर फेलियर हो गया है उनके यहाँ।
कहाँ से? पूना से बोल रहे थे ना?
हाँ, पूना से बोल रहे हैं। सडनली सब चला गया सिग्नल।
मोबाइल चार्ज नहीं होगा शायद, मोबाइल से इंटर
नहीं, मोबाइल से नहीं, शायद लैपटॉप से बात कर रहे थे।
तो पे पूछ लीजिए. If it's a serious problem, then we can take some next.
We can take others, no problem. But he can wind up also. It's a very good lecture, and just doing question answers, he could explain.
So telephone पे I think he can explain the things.
Yeah. No, telephonic otherwise interaction time also winding up panel discussion time.
I think Mr. Mayank Agrawal, I think you are available. Sir?
Yes, sir, I am available.
Okay, then be ready. We'll call you if you're having.
Sure.
क्या आवाज आ रही है?
Sir, he has rejoined. Sir has rejoined.
Okay, please.
So there is a power failure at his end. He is trying on his backup supply.
I think I'm back on with my supply.
Yeah, you are here.
So anyway, if you can get back to the.
We are seeing current challenges, sir.
Yeah, current challenges. Basically, we are looking at fragmented data and lack of interoperability across the databases. There is no way to reconcile immunization coverage data from the supply chain with immunization utilization data. Supply data is different, utilization data is different, and what was manufactured is different. So all these are definite challenges which everyone is seeing across in day to day. In our hospital, we experience that on a regular basis. So even though we have a vaccine intelligence network called as eWIN system, the utilization data recorded by health workers in written onto the system like mother and child tracking system, which is part of the Government of India system, and health management information system. All these 3-4 systems of the government, they are not interoperable. If they were put onto the blockchain, they will all become interoperable. We will have so much less fragmented data business going on. And even the data inconsistencies and corruption that happens. Now, certain amount of the vaccine volume is left behind, and another healthcare worker connects, brings his friend, "Arey, tere liye rakha hai, tu le le." Now, at the ground level, we see all this kind of data inconsistency, corruptions, which can be totally eliminated, leveraging the blockchain technology for a unified data system. Next slide, please. So in this unified data system, you can go to the next slide. The cold chain management, ensuring timely vaccination, alerting the parents, incentivizing parents and health officers. So all this unification of the data system can be very easily provided, ensured, give alerts, incentivize. All that can be done on the blockchain infrastructure, and it will improve real-time visibility of the immunization while transfer, delivery, while creating a foundation for future. Next slide, please. Now, you can see that India's digital foundation infrastructures, Aadhaar, world's largest identity database with more than 1.2 billion biometric identities. Now, more than 25 million authentications occur per day. That's blockchain for you. Unified Payment Interface, UPI, world's most sophisticated digital payment system. 1.3 billion transactions processed in December 19, built on blockchain. Goods and services tax network, more than 400 million returns filed, more than 800 million invoices uploaded. Prime Minister PMJ Healthcare, world's largest healthcare initiative, Ayushman Bharat, 500 million beneficiaries covered, 119 million e-cards issued so far, 8 million hospital admissions built on blockchain, including the fraud system. So if we can do it here, it's time that before the financial sectors and the insurance and everywhere else, healthcare needs to move on to blockchain technology. For all the things that we've been asking for in the past are now available through blockchain. Next slide, please. Another use case, I will say, this is recently launched in India for the first time, a blockchain in healthcare. It's a global telehealth exchange. You all have heard of the olden days when we used to have telephone exchange. You call the operator and he would take out a cable from a slot, put it to another slot, and you kind of had an exchange. Now we can have a global telehealth exchange, which is available in India through SolveCare company. It is simple scheduling experience for a doctor. Doctor can choose the time. Monday, I'm available from 2 to 3. Tuesday, I'm available 3 to 5. Friday, I'm available whole day. Saturday, I'm not available. Sunday, for emergency. So you can have a very simple scheduling system laid out on this SolveCare platform. He can have a very high quality video calls. He can give e-prescriptions. He can do easy referrals. He can, entire record sharing is secure. Next slide, please. Next slide, please. You can decide your own rates. A doctor or a hospital who is charging can decide what is the rate. Is it $5, $10, this, or you can put it in rupees. They are trying to bring in a UPI Razorpay so that it is Indian currency which you will be putting in the patient's wallet, and from that wallet patient will be making payments as tokens. Say I buy 50 tokens and put it in my wallet, and when I consult a Dr. Mathur, after finishing the consultation, Dr. Mathur gets 2 tokens through the SolveCare instantly. He doesn't have to raise a bill. He doesn't have to call me, sir, you have not made my payment. This is my bank account. This is my IFSC code, blah, blah, blah. All that is totally redundant. And you have a complete control on your schedule. No minimum time commitments. You have no monthly fees on this platform. Next. Everything is automated. Then billing is automated, payments automated. There's no paperwork involved. All the appointments are automated. No additional equipment is required. Bring this equipment, add this equipment. Nothing is needed. No extra staff is needed. No registration or monthly fees that you have to pay towards using this kind of a blockchain. Next slide. Next slide, please. So the top 5 reasons why doctors should join the Global Telehealth Exchange. They can see patients from across the world. So as and when TPG becomes little more clear that you can or you can't, till the time you can, because it doesn't say you can't. And as it is the SARC network, the BRIC network, the Pan-African network, we discussed in the previous speaker's discussion time. So you can, patients from across the globe or Indian patients who have gone abroad and want to consult you, they can see you on this platform and make the necessary appointment, pay the fees instantly. So no billing, no instant digital payments are done. Automated appointments for the doctors, zero paperwork, unprecedented levels of information security, free to join are the major reasons. Next use case. So this is the patient end. You see a care wallet which has your personal healthcare concierge. You go to a hotel and you deposit your bag. You ask the concierge to order a cab for you. Here you can order an Ola Uber to take you to the hospital. You can ask the app to buy the medicine from a pharmacy and deliver it to you. So this care wallet is for your lifetime. All your data belongs only to you. You have the key, you are the administrator. No third person, no platform. Platform doesn't own anything. Doctor doesn't have any ownership of your data. So you decide who sees, what sees, when he has to see, and for how long. Yes, Care Wallet uses blockchain to protect you. Next slide, please. So we have seen use cases in drug supply chain, in immunization. You have seen it in healthcare. So the trust and security, which are the new concern in business related to any data and client information. Health industry has been showing a huge growth with technology implementation. From history till date, records of patient and more, blockchain took over all the tedious, time-consuming tasks into a systematic way. The trust issue is on high dip due to the open access and entering information, especially into healthcare industry. Inconsistency came when same data is accessed from multiple places, and blockchain helps in preventing the access to the unauthorized user. Blockchain is like a blessing for the healthcare industry and a big answer to hackers. Next slide, please. Benefits of blockchain in healthcare. You can see by now and understand that it is fully organized to get rid of clumsy work. The whole process is organized into step-by-step manner with the help of electronic health records. Records are not openly shared. The security aspect is much increased in terms of crucial data. Monitoring, patients can authorize any individual to access their medical information. They can form circles of friends, family who should know about their condition. So it's called a care circle. You can easily document this transaction in a proper format using blockchain technology. It saves time, it saves efforts, it saves cost. Next slide, please. Data protection, one of the best solutions in terms of technology, worth investing and implementing. It's a blessing for industry that works as a safeguard for important documents and information. Also helps in preventing unauthorized users to access information and data. It simplifies the process. A complex process is simplified, and all unnecessary transactions can be eliminated. Third party can be eliminated, acting on behalf of other entities, etc. So no power of attorney, whether if you're using this in land records. For example, Chandigarh has done a very beautiful implementation of blockchain technology as far as land records are concerned. And I'm sure Sangal Saab must be aware since he recently moved to Chandigarh. So you see, any major process, blockchain technology is showing a great reliability. Next. Next slide, please. Healthcare transactions in blockchain. Now we've discussed this. When a child is getting vaccinated, so it forms a block. And the child presents to a doctor, doctor vaccinates a child. Now that's a block. So this electronic medical record as a block. Then the details of the doctor's visit are recorded in the child's electronic health record, which are owned by the family. This becomes a block in the blockchain. So the information can be accessed by others in the network who are approved by the family. Family may say, I want another Dr. B to see or Dr. X to see. So they can share that with another doctor. It can also include the child's school. The school principal may say to the parents, we need to know the status of your child's vaccination. So they can be given access to that. Insurance company can be given access to the child's vaccination or any other medical provider. Next slide, please. What are the drawbacks? Basically, it is in its nascent stage, it's new. Even very large corporations are struggling to integrate it into their own core system. It's matter of time. Today, institutes in Hyderabad, Chennai, IIT are imparting courses on blockchain for students. And only unfortunate thing, they're not allowing distance learning, though I would be very happy to join one of those courses, except it's an in-house course. So there are many younger students who've gone to these places are learning, and I don't think it will be new anymore in the next few years. It's misunderstood, mainly because of the bad reputation created by a cryptocurrency, Bitcoin. Though they were the first to use blockchain technology. It was Turner and Lee Keynes in one of their masterpiece writing discussed how safe it is to transact and transfer without banks overlooking, without governments overlooking. But when they start misusing, the government thinks otherwise, RBI thinks otherwise, and therefore very soon we will have regulation on the blockchain also. And it requires collaboration. Yes, initially it's high, very high cost. Now one healthcare application on blockchain to be developed can cost something to a tune of about $20 to $30 million. So it's not everybody's cup of tea to tomorrow come out with something like Practo, DocSat, Doctor Online. All those are not on blockchain, and they are just somehow only for the purpose of scheduling an appointment. Then they don't have interoperability. Then they don't talk. There's a lot of hacking of data from those things by sending a small snail or a little jug, pull out all the data. So doctors are also not very happy using those. But I think it's a great chance in the country for us to talk more about blockchain and to get more familiarized and start using it in the healthcare sector. Next slide. Next slide, please.
Mathur, next slide.
So the challenges for us are the awareness. The more awareness we can bring about, like we did for telemedicine 20 years back, we will now have to bring awareness of blockchain in healthcare to all the medical community, medical colleges, students across, including pharmacy and the supply chain. There is lack of adoption at the moment, but as soon as the trust among users increases, I think it will no more be a challenge. Financial resources, yes, it is costly, it is efficient, but it also requires huge amount of financial resources to build that. Blockchain is interoperable, and that's what we've been looking for. Security, privacy, regulation and governance will come as soon as the government gets its act together on the cryptocurrency. So similarly, Niti Aayog has definitely going to come up with their second paper on blockchain. It's not yet published, but I presume that will be in the offing very soon. And that should help us all work towards blockchain in healthcare. Thank you. Thank you very much. Yes, sir.
Yes. Can I have a question, please?
Yes, please.
Thank you, Dr. Rata, for elaborately discussing about the blockchains. I think in the future, this technology will definitely be adopted, provided we improve the things, security, privacy, and government forms some regulations, and the trust develops among the doctors also. So I'm really thankful to you for deliberating, giving us such a nice
So
talk.
government is very much in favor of blockchain. You have seen all the major things where government is already using.
Yes,
Now, Ayushman Bharat is using blockchain technology.
But it requires resources, sir.
It's the private sector that is lagging behind in catching up with this technology in the healthcare.
You also told it requires a lot of resources, funds also, isn't it?
Yes. So but currently, like the Solvecare has already launched their product in India. So if it's available free of cost, why do you bother to develop, spend another few millions? Let us use what is available and see the benefits or the harms or the challenges, and then think of developing an Indian blockchain in healthcare.
Okay, thank
We
you.
have something available already.
Dr. Rata, I have a question. Can I ask him?
Sure, sir.
Yes, please.
Dr. Rata, one thing, see, the problem in India is, though the technology of blockchain and interoperability is very good, but the doctors or the hospitals do not want to share the patient data among them, among the various hospitals, precisely probably because of commercial reasons. Until unless that is solved, I think these good technologies will not evolve. Second thing, see, you were talking about interoperability, okay, about the data. Now, insurance sectors and others probably are not now in India, must be aware of the HIPAA standards, which allow interoperability of EHR among various nodes. If that is so, it's good, because we had been, right from the very beginning of launch of telemedicine, we had been insisting of HIPAA and HL7 standards and so on and so forth. HL7 has though come up, but not the HIPAA standard. Can you tell me how?
Yes.
HIPAA now in the
I
country?
showed you a use case of blockchain in healthcare by HealthLink and Solvecare are the two companies joined together, US-based company joined together with an Indian company, HealthLink, and they are promoting blockchain in healthcare, which is HIPAA compliant, which is interoperable. If you use blockchain, then it will. Now, for example, patient is the owner of his data, whether it is he's admitted in a hospital or he visits you in a clinic. Once he is in the hospital, patient can demand for his data to be given to him. The hospital cannot refuse his data. Now, your point can be looked at it from another angle. Let's say an institution in Jaipur, in Chandigarh, in Pune, in Delhi, a private institution, let's say Apollo, Max, Fortis, adopts this and says, okay, we are partnered with Solvecare. So all the transaction will happen with the hospital, and hospital will lay out a scheduler. Somebody calls from US or UK or Singapore or Dubai or from Bombay to Delhi and says, I want to meet a liver specialist in Apollo. His schedule will be seen, his payments will be made, and he can instantly speak to the liver specialist. So the hospital will direct that call to his liver specialist or to the neurosurgeon or to the orthopedic surgeon or to a kidney specialist. So all these hospitals are going to get involved in this as time goes ahead. This is a new baby on the block, on the horizon. It needs a lot of marketing and a lot of awareness to be brought in, but it's the future. If somebody can foresee this as a vision, this is what India needs, and this is what we have been looking for.
Yeah, I'm talking another thing. See, the patient is the owner of his data, data, medical records. Okay. Now I contact a doctor. He asked me the data. I ask him to go to cloud through my password or whatever it is, and he has access to my medical data. I am not
for that limited time that you permit him.
Okay, now
I
correct. I go to other doctor, my data is available on cloud. How do I know the relevancy of doctor? Because I am a patient. I don't know X-ray, mera radiology chahiyega usko, cardiology chahiye, whatever it is. So he can access all my data. How do I restrict that data?
Sir, when you first consulted one doctor, you formed a block. Now this block of chain, you are owning it. Now from this block, already the copies have been made. It's there on the entire network. Unless you put the key there and allow, that data will not open for the new doctor. And if the new doctor sees the data, you can restrict him to see only the family history, your social history, or you may say only see my ultrasound. You can see only my CT. You can see only ECG. You have the key to it.
Individual data cell.
It's your data. You decide.
Yeah, whatever you want. I think this is very good technology, and future, of course, we will any government will try to implement it, but it is having a lot of issues, which the things improves. Probably those things will resolve it. Now, any other participant?
Venkat Ramaya sir has raised a hand.
Sir, let me thank you for a very innovative technological. It's actually social engineering, according to me, in healthcare. One simple question is about two cases. One Panbida Wala at Mysore, Shurampet Road. He has been charged 16 lakhs for COVID care, Columbia, Asia. For 6 lakhs, he has got the receipts. For 10 lakhs, there is no, and his body is also not available for his relatives. The case is closed. One case. Second is one of my software colleague. He is in a hospital. Instead of 14 days, he stays a week, and he is spared with 30,000 rupees expense to his budget pocket, and 70,000 taken away by insurance companies. My question is very simple. In fact, last week I raised this issue in WHO meeting, in the infodemic meeting where I go every week. Sir, a patient should be, as of now, should be accessible to the various. See, generally we get a signature of the people who are attending, family members and all, for an operational, surgical procedure and things like that. And another case I must tell you, extreme. A patient goes in Chamrajnagar, a government hospital. The nurse snatches away the mobile and he's cut off. And his body also will not be given. It will be packed and his organs are removed suspectedly. So what I want to say in conclusion is this. As on date, all these technologies are very good, very good, very good. It should become operational. What Niti Ayog should do, according to me, Dr. Paul and others should do is make a policy.
Sir,
make a policy. That is there has to be a transparency from point 1 to point 2, which involves the health care of the patient and the anxiety of the relatives and the system which is responding to the person, because public health architecture has deteriorated so much. It requires really a Bhagirath or some great Krishna Paramatma to come and solve this problem. Please.
You're very right, sir. Your observations are perfect. And we see this, we hear this in our medical community every now and then. And there are some people who are unethical, some people who have always the habit of cutting corners and cheating as much as they can to earn out of it from poor patients. We see that. And you see, today Niti Ayog is fully aware of the healthcare system. Unless they increase the GDP spend, the infrastructure will not improve. Ultimately, it is you and me as human beings. If we are corrupt in ourselves, how can any system
Nobody can help.
work? Nobody can.
Nobody
So each of us needs to contribute rather than saying what nation will do for us. Let us say we will contribute our honesty. We will be ethical in our practice. We will not do unethical work, and help the government when they are now bringing this blockchain in healthcare as a discussion paper. Means they have already thought about it from last 1 or 2 years. So we must compliment them, and it's open for people to make comments currently. They have come out with version 1, paper 1. They're also going to come up with version 2, in which other use cases will come. I only elaborated on, say, the supply chain, land records, immunization, healthcare. But there are so many other sectors where this will be a big boom. So it's time for us to look at it positively rather than look at it negatively or with a fear or with kind of doubt. Otherwise, another 10 years will go before blockchain comes on. And it took us 10, 20 years to bring telemedicine to the
present
into
state.
the open. So let's not waste another 20 years. I would say each one of you in your capacity who can push matters should speak to the government in whatever capacity and try and get blockchain for the nation. Whether it is in private sector, public sector, doesn't matter. It's important because it will root out a lot of corruption. A lot of things will be sorted out.
No, thank you very much. Thank you very much. You were very enlightened speak. But one truth is there. The community is living through whatever we say.
Yes.
Whatever big things we say, because America gave $80 billion after the COVID for healthcare. We should not forget it. And we should think of having our own indigenous partners more and more. Thank you.
Yes. Yes.
Thank you very much, Dr. Rath.
Yes, ma'am, you can ask a question.
Yeah, somebody wants to. You can see
You're not
that
audible. Can you unmute yourself?
She's on mute.
Yeah. About the security concerns in blockchain, how are they? That's one question I have to take it up.
It is absolutely 100% secure, Sheila, because it's a block. Block is locked. There is a key. I showed you a slide. Each block is which is totally secure and it has its own key. You cannot open that block unless you give permission. There cannot be anything more secure than blockchain today. I'm not saying tomorrow we will not have a hacker who will manage to do this also. I can't promise that. But as of today, this technology world over has been accepted. Now imagine a country like Estonia, which got freedom from Russia way back in 1991, and where everything, all government records, land records, legal records, currency, everything is on blockchain. Imagine one country can do that. It's a lesson to be learned from.
Yes. Sir, I have one question since you are a robotic surgeon.
Yes.
The machines are going to do a surgery, and now we have to control the machine so that nobody can hack into it and nobody can control it. So how this can revolutionize the robotic surgery in future?
See, in robotic surgery, what happens is that I am in the same theater. Only my console is about 20 feet away. I'm sitting inside a console and operating my instruments only using my fingers and my feet. Like you're driving a car, so you're controlling the leverage, left, right signal or the wiper and pressing on the brake. Similarly, on this robotic control, everything is so precise. Imagine that if you have a grape, I can peel off the skin of the grape, keeping the rest of the pulp intact without a puncture mark there, or a tomato. So I'm so precise when I'm handling, using robot in children, reconstructing their urinary tract for various defects. I mean, it gives me a three-dimensional view. It gives me, if I want to put one instrument at a particular place and go somewhere else and want to come back, it's just a touch of a button and the instrument which moved away comes back to its exact original place. So I can have 2 arms, I can have 3 arms, which I can use, and the precision. Now, only thing is, when it was first started, somebody from US had a patient in Europe. And because there's a time lag between Europe and US, so it was not possible to do it at long distance. But within the country, where our time zone is the same, it should be the next step forward. So sitting in Pune, I should be able to operate somebody in Lucknow, somebody in Delhi. It should be possible.
Wonderful.
One more question. Where tele-education is concerned, simulation is coming in, I mean, of course, virtual reality, augmented reality, but simulation is coming in a very big way because all your procedures can be simulated, and it's changing the scenario of medical education where it is.
Combining augmented reality, virtual reality, and simulation with blockchain, you have solved practically every problem. Every student, what he needs to learn inside a hospital physically, can learn inside the lab how to intubate somebody while giving anesthesia, how to take an intravenous line, how to put a central line, how to do a tracheostomy, how to open an abdomen, how to open the chest. All these can be simulated and taught to the students in a lab if you combine all three. And that's what we are looking at. We already have AR, VR in many of the centers. You add blockchain to it and you see the wonders in healthcare education happening.
Yeah. Earlier we were doing cataract surgery on cow's eyes. Now we are doing it on simulation. We have a machine which shows the cataract simulation, and they can even do 50 cases in a day. Cow's eyes means once they puncture, only once or twice they can do. After that, the whole pulp comes out.
It's like, when I was training on robotic, I had to sacrifice a pig for it because the pig was anesthetized, and I learned 10 different procedures, how to do them, how to dock the machine, how to handle my instruments, how much time gap I have, etc., etc. So it's a learning way. In future, I'm sure even the robotic surgery will come to the lab for training.
Yes. Medical education is, medicine as well as education is changing in many, many ways. Yeah. 5 years from now, it would have totally changed from what was 10 years ago.
Right. Absolutely.
So, Mr. Vaibhav, any other question from YouTube? Yes. Also, we are monitoring.
As such, I don't think there are. Let me just check once.
Because
so there are no questions from the YouTube. Chintamani, you have a question?
Yeah.
Yes.
Sir, since we are discussing about robotic surgery, so are there any, since we are talking about over a distance robotic surgery, so in what way the direct SATCOM network, internet network will be useful as compared to the ground network, or are there any existing protocols which actually mention that there has to be, the lag has to be minimum this much milliseconds or anything in that sort?
As of today, there is no such example anywhere in the world or in the country. It was the beginning that it was attempted like that. But now, as we are seeing that SATCOM can help your ISDN lines, the lag has to be less than millisecond. So if I'm moving my arm, the same action must happen on the patient instantly. There cannot be a lag at that end. So whether ISDN, SATCOM, optical fibers, what will provide that will only lead the robotic surgery to be done from one city to another. Till that time, it is not possible, it is not happening, and will not happen, cannot happen. It's question of life and death. In a millisecond, I can just cut, this is an artery, just nicked. Before I can do anything, I have millisecond to control. If there's a lag going on, it's life and death. That won't be possible. So we need to move ahead in technology to bridge this gap of time lag. Then we can think about it.
Okay. Thank you. Thank you, doctor.
Thank you, sir. Thank you, Dr. Ratta, for a wonderful viewpoint on the blockchain and its prospects that it holds in the medical industry. And I think this will definitely lead us to think in different ideas and bring us something new to the table.
That was the idea, to sow a seed so that you guys fruitify it.
Correct. So it's really a nice viewpoint that you have shared with us. Thank you for your wonderful talk, sir. Over to Jain sir, we can.
Thank you.
Thank you, Dr. Rata, for a nice lecture. Though in the beginning we have some problem, I think that problem was resolved. Maybe the technological aspect, as you pointed out, that tele-robotic surgery will definitely require some issue to be resolved. So definitely our bandwidth and memory or capacity, etc., will increase it. Speed also increases. In future, I think from satellite is free space optical communication is also possible.
Plus 5G is coming anyway.
Yeah, 5G is coming for this thing. But for a space technology, if some links are established with gigabits of speeds and terabits of data, then probably such problems can be solved and the latency can be reduced. That will be helpful in near future. Thank you very much for a wonderful talk and enlightening all participants. Now, thank you very much, sir. Okay, now the next talk is, sir, on this thing by Mr. Mayank Agrawal, and he's delivering the talk on telemedicine, what really works. So Mr. Mayank Agrawal is the former of CEO of Messrs. Smart Square Technology Noida, actively associated with Indian healthcare industries. Now I invite Chintamani Pai to introduce him. Please, Chintamani.
Thank you, sir. I'm Chintamani Pai. I'm a co-founder of Space Geeks. We are a young startup in space and allied areas, and it is always always great to be a part of this event. I thank.
The next talk is.
I thank AC Mathur sir to invite us to be a part of this event. And am I audible properly?
Mr. Mayank Agrawal is the former of.
Am I audible properly?
Yes, yes. Good.
Okay,
You're
okay.
audible, but there is some noise in the background.
Two devices
Okay,
are.
okay. Yeah.
If somebody is using two devices, kindly mute one.
So it is always great to be a part of these events organized by Mathur sir, and I thank Mathur sir and Jain sir to allow us to be a part of this event. And it is also great to be a part of this telemedicine workshop, which I'm sure with all these distinguished experts, viewers must be getting highly benefited. So with that, I'll give introduction to our current session speaker, Mr. Mayank Agarwal. So Mr. Mayank is an alumnus of Indian School of Business and Delhi College of Engineering, now known as Delhi Technological University. He is a technology entrepreneur with over 13 years of experience. He has filed patents and authored research papers in diverse technologies. He has built telemedicine platforms that have served over 1 million remote consultations. He is the founder of VClinic, a mobile phone-based telemedicine solution for helping doctors and to carry out their practices. So with that, I invite Mr. Mayank Agarwal. Over to you, sir.
Thank you, Chintamani. Again, thanks everyone for having me here. I'm just going to talk about our experience delivering telemedicine consultations over the last few years to people all across the country and around the world. And I would be happy to.
Mayank, your voice is low, probably.
My voice is low?
Now it is okay. When you are away from that mic, probably.
Oh, okay. Is this fine, right?
This is fine.
Yeah, this is fine.
Okay. So, as I was saying, I'm going to try to condense our learnings in general with respect to the last 3 or 4 years where we've served 1 million consultations in India and around the world. And I would also take you guys through a small piece where I can take you through how you can set up your own telemedicine practice. So without any further delay, the promise of telemedicine has always been that we can get improved patient outcomes, we can have a better patient experience, there can be a better physician experience, and I'm sorry, there's a better physician experience, we can reduce expenditure, right? But over the last 10, 12 years, we realized that telemedicine implementation, realization of benefits has a lot more to do with how it's implemented, how change management is implemented, how the physicians, etc., are co-opted into it, how the patients are co-opted, as opposed to with technology. Because technology has been there for a while, but the implementation hasn't. Now, the key thing that telemedicine is always supposed to be helping us in is diagnosis of common medical problems. It's cough, cold, fever, sore throat, indigestion, aches and pains, etc. Right? Not complex medical problems. Then people can inquire about various medical issues for home treatments. If there are simple home remedies that are available that can alleviate symptoms, then telemedicine is an ideal solution. Once a patient has already been treated for something, post-op care, chronic care, post checkups, etc., that's also something that is very apt for telemedicine. Then one thing that telemedicine has been used for extensively in India is faster refills for short-term medical prescriptions. This is something that a lot of the online pharmacies are actively doing. They use telemedicine to provide refills to people who require it for themselves. Then, of course, we know that anywhere when patient is physically unable to be present for the patient, with the doctor, the holiday, or if the doctor is just not available at that time, those are times when telemedicine is really useful. But it has taken off, right? Pre-COVID, what really happened was it was very difficult to justify investment in technology. Physicians didn't think it was very useful. Patients didn't think it was great. Hospitals didn't think it was useful because everybody would think that a physical consultation with the physician would be the best, and business models, incentives, etc., were always aligned with respect to a physical in-person consultation. Turns out, telemedicine was a great technology, but it was always falling by the wayside in healthcare. What happened with COVID is suddenly a lot of very cost-effective or free technology solutions became available. Government of India released the telemedicine practice guidelines. And because of distancing requirements, because of this fear of COVID spreading, it really did become the primary means for initial and follow-up consultations for a large variety of issues. Suddenly, we started seeing patients, physicians, hospitals, because of lack of an alternative, all accepting, practicing telemedicine and deriving benefits from it. Turns out telemedicine suddenly was at the front and center of giving care. And this is what we've learned as people in the healthcare industry in the last 1.5 years. Something we've learned over the last 4 or 5 years is that if telemedicine is your primary way of giving care, it's always difficult to maintain a work-life balance because you don't always have a separate space where you go to, where you're providing these consultations and then you come back. Physicians tend to be less confident when they're making a diagnosis using telemedicine alone because they want to assess more parameters which may not be available over the call. If we augment these telemedicine consultations with lab tests, then definitely that leads to significantly higher confidence. Another very interesting thing is that telemedicine consultations happen to be significantly shorter than in-person consultations. The median time for telemedicine consultation is about 5 minutes, with even 10 minutes being an outlier. So you end up with most of your consultations around the 5-minute mark. So you'll get through patients in a much faster clip. The other piece is patients, right? Patient satisfaction in general with telemedicine consultations is high because they feel that it allows care to be facilitated earlier. It reduces significantly the time and cost of travel. And in general, physicians, the way they ask their questions, the way they interact with the patient, the way they are able to offer the explanations of the treatment, their patients are usually satisfied. Another interesting thing that we noted is that it's also about the price, right? If you're offering a telemedicine consultation and a physical consultation at the same price, all other things remaining the same, patients prefer an in-person consultation. However, the moment you lower the price of the telemedicine consultation by 30% as compared to your in-person consultation, people generally pick telemedicine. So these were our key learnings from this. Now I want to just talk to you about how you can set up your own telemedicine practice without having to spend a fortune. Because a lot of these technologies are available today, which are available free of charge. You are used to using them, and it shouldn't be a pain anymore to set up your own telemedicine practice. Of course, you need to make sure that you're complying with the telemedicine practice guidelines. You're following the same professional ethical norms and standards as an in-person consultation. You have to always act in the best interest of the patient. Of course, this goes without saying. And as I was saying, technology and platforms are not a barrier. There are tools that you are familiar with, that you're using in your everyday life, that can be used to provide telemedicine consultations, which comply with the telemedicine practice guidelines as long as you follow standard procedures. Finally, key thing that COVID has done is that patients today are willing and happy to pay for telemedicine consultations to doctors. Now, before we move on to actually setting up your system, I'd like to just take a very quick practical summary of the telemedicine practice guidelines. First, no anonymity. Second, make sure you're maintaining all your records. Third, you cannot have a prescription that does not mention diagnosis or provisional diagnosis. So absolutely required to mention the diagnosis or the provisional diagnosis on the prescription. You can write a prescription on paper, sign it, take a photograph of it or scan it and send it across to the patient. It's completely legal, it's allowed. If you want to make an e-prescription, which means you don't want to manually sign a document, then you need to have a digital signature. This is different from a face-assembly signature or a photograph of your signature. Finally, sending the invoice to the patient is mandatory if you have charged for the consultation. Now I'll come to the aspect where you can leverage technology to really set up your own practice. And as I said, tools that we use every day are the tools that are going to be required and going to enable you to set up your own practice. And that's the first point in the slide. WhatsApp works. If you take nothing else away from this tech, then you know that WhatsApp is the one thing that absolutely works for delivering telemedicine. What you need to do is save your message templates, which have your identification, your credentials, your pricing details. Make sure you're requesting for, you have templates for requesting for patient details, and make sure that you have consent request templates. And we'll delve into these later. Make sure you're not deleting any messages because you need to save all the data. Make sure you're backing up all your data. And WhatsApp even allows you to accept payments. So, that's also something you can just do on WhatsApp. So if you don't use any other software, if you don't want to use any other software, that's absolutely perfectly fine. WhatsApp is completely legit way of providing telemedicine. And it's in line with the telemedicine practice guidelines. Also make sure that you're sending an invoice to the patient after your consultation. You could optionally, if you want to level up, you could make sure that all your records are stored in a Google Drive or on your computer. You have to maintain a log of all encounters with every patient. You can do this as a physical log, you can do this as calendar appointments, it doesn't matter, but some sort of log has to always be maintained. You could, instead of using WhatsApp, you could use payment gateways for collecting payments. This looks more professional. You can also give your patients the option of accepting credit, debit cards, wallets, bank transfers, UPI, etc. You can store hard copies of all, you need to rather, store hard copies of all your prescriptions and invoices. This ensures that if ever there is a requirement, then you have all these ready and available for you. If you choose to provide e-prescriptions, as I said, please do that with digital signatures and not photographs of your signature. Finally, make sure that this is SOP where you're maintaining the log, where you're requesting patients for all their permissions, etc., and providing them the right consultations with the parameters of what is best for them is always followed for every patient. As I mentioned, if you want to offer something apart from WhatsApp for accepting payments, you can use payment gateways. Here, my recommendation would be to pick a modern payment gateway. Dr. Atta in the previous conversation mentioned Razorpay. I also think that's one of the best payment gateways out there. Instamojo is another one that's a modern payment gateway, fairly easy to use. You can set up a payment gateway for yourself within 30 minutes these days. For your KYC, the only things that are required is address proof, ID proof, and bank account proof. So address proof is typically your Aadhaar, ID proof is typically your PAN, and bank account proof is typically either a cancelled check or a bank account statement. You create the account, you upload these documents, and you can start accepting payments. Within 1 week, they will approve your account, and these payments will start reflecting on your bank account statement. Doing this and accepting payments is as simple as creating a link and then sending it over to the patient so that he can make the payment and it can reflect in your. That's it. One bonus that you get with payment gateways is that they record all transactions and they give you free invoices. So they will actually generate invoices for every transaction, and you can just use those invoices and send them out to the patients. Now, with all this background knowledge, we finally come to setting up your virtual practice using WhatsApp. First and foremost, please enable backups of your phone on your Google Drive or your iCloud Drive, depending on whether using an Android phone or an iPhone. Please ensure that WhatsApp and your image gallery are being backed up properly. Set up your payment gateway, enable payments on WhatsApp, Google Pay, Paytm, whatever you like, and create these message templates. Identify yourself, and ask for your patient's identity. If you need them to submit an age proof, then please do that. Then there has to be a consent for mode of consultation. And finally, a consent for actual telemedicine consultation and requesting for payment. This can be clubbed usually. So if they've paid, that means that they've implicitly given you consent. Sorry. And as a best practice, I would recommend that you have a separate phone for consultations so that your personal data and your data from your practice do never mix. And it's easy for you to separate. Finally, the process of telemedicine. It's pretty straightforward. Once you get a request for an appointment, you send your ID message and request for patient identification.
Move a little forward for good quality of voice. A little forward.
So could you repeat that, please?
आप थोड़ा आगे आइए ना mic के पास.
Is this better?
Yeah, this is better. Okay.
Okay, so I'll try to do this. As I said, the process of telemedicine, once you get a request for an appointment, you need to send an identification message and you need to request for patient identification. Then both of you need to agree on a mode of consultation. Once that's done, then you send a consent request and a payment link. As I said, they can be clubbed, and once the patient has paid, that can be taken to be implicit consent. Finally, you can begin your WhatsApp consultation over voice, video, or chat. Of course, I use WhatsApp as a placeholder and as a fact that it's one of the most commonly available softwares. You could use Zoom, you could use Teams, you could use Google Meet, you could use whatever other tool you feel like using. Just make sure it is end-to-end encrypted so that your security and safety parameters are taken care of. Once the consultation is completed, you just need to create a physical prescription detailing everything that happened on the call don't forget to put in the diagnosis or the provisional diagnosis, otherwise the prescription will be considered invalid. Sign it, scan it, or take a photo of it, and you can just send it over WhatsApp. The patient can get the prescription. That prescription is legal, it's valid, it can be used for the patient to get medicines in a pharmacy. Then you could go to the payment gateway, download the invoice from there, or just like you created a physical prescription, just create an invoice. Again, sign it, scan it, send it over, and you're done. As of course, you need to keep a log of all conversations that you've done. If you are using a calendar to manage all your appointments, just make sure you're not deleting them, and you're good. You don't need to do a lot more than that. So finally, if you want to remain compliant with the telemedicine practice guidelines, you need to identify yourself, your patient. You need to provide consent for pricing and for mode of consultation. And when you provide the consultation, you need to record and save everything. You need to provide the prescription and make sure the payment gateway is operational so that you can collect money and you can send an invoice against it. Thank you, and I'm open to questions. Happy to answer any questions anybody may have.
Thank you very much.
Thank you very much, sir. So,
Yeah.
Yeah. So
yeah, Mayank, one general comment from my side. Usually we don't get such a soft-spoken person in the what do you call it, the corporates. Mayank is a very soft-spoken person, it seems.
I've been told I can be loud.
Mayank, you don't have to be loud. Only thing is, I request as past president of Telemedicine Society of India, A.K. Sangar, that you become our corporate member, because we have already 7 or 8 corporate members, and you will be member of EC Executive Committee as a corporate member, and so many other things. Okay, you are a young budding fellow, and I just browsed through when Mathu wanted contacts. Just browse through my TSI list, and I found it. You are the near. He said, I want somebody from Gurgaon or somewhere. I said, okay. So I gave your name. Good. Your presentation was good. It's in a line. Thank you.
Thank you, sir.
Okay.
Thanks, Sangal sir. Because of you only, I could catch Mayank Agarwal.
Thanks. Thank you.
So I'll start the question and answer session with my own question first. Sir, as you were explaining about these procedures over a WhatsApp, let's say if patient is forwarding MRI image or X-ray image, because in the industry there are standard DICOM image protocols. So are there any guidelines in that regard in the context of telemedicine?
See, in the context of telemedicine, there are no guidelines on that regard, right? Simple thing that I would say here is, if the doctor can, if you can send it in a way that the doctor can see it and he can make he can form an opinion about it and help you, that works. Having said that, of course, WhatsApp, of course, Zoom, of course, Google Meet, and all these are not EHR softwares or HMIS softwares. You know, they are not built to be medical softwares. So it is a stretch to expect that they will follow the EHR standards of India, or they will follow any medical standards for that matter, right? It just so happens that the telemedicine practice guidelines, the way they are framed in a manner to facilitate telemedicine as opposed to make it difficult. So they have removed the requirement of a lot of these things to be part of the software with which doctors can conduct telemedicine.
Okay.
So you don't have to worry about the DICOM standard specifically. As long as you can send the data to the doctor can see it, he can reasonably and confidently form an opinion about it. Okay. It's all good.
Okay. And what about like typical the telemedicine network through a SATCOM? I mean, then in that perspective, how will you answer the same question? So are there any systems which allow for, let's say, if there is a critical case and there has to be a real-time transfer of the image from person using the SATCOM network from one place to another place. So in that case, how does it work?
See, I have limited experience with SATCOM networks. What I do know for sure is that the army is using it, right? Of course, ISRO has been a torchbearer with the SATCOM networks. My general sense, and I could be wrong here, is that SATCOM networks aren't the fastest bandwidth networks, right? Typically, if you are sitting in a metro city, then from my house to maybe I am sitting in Delhi. So from Delhi to, if I want to transmit a large file to Bangalore, I would be better off using a fiber line internet as opposed to a SATCOM network to transmit the data. Right? Also, SATCOM networks, because typically they're satellite-based communication networks, they will always have a latency lag, which will be larger than a fiber line network lag. Right? So SATCOM networks are, again, happy to be. Please call me out wherever I'm incorrect technically, because I'm not an expert on SATCOM networks. This is from whatever I remember with respect to my reading long time ago. SATCOM networks are amazing where normal connectivity is not available. Right? SATCOM networks have been used very efficiently, very well in non-real-time scenarios for providing care in thousands and thousands of cases. Right? I would be a little wary in using SATCOM networks for real-time case management, because whatever I know tells me that SATCOM networks have smaller bandwidth, and they tend to sometimes also not be as real-time as one would like for these scenarios. So if real-time is necessary, I would say put a fiber line if it's possible.
Yes. Any other questions, or maybe other distinguished experts would like to comment? Those are welcome.
No, actually, SATCOM communication now is costlier than the cellular now. In fact, with the proposed introduction of 5G in cellular, even operation intervention, surgery intervention, all other things will become much easier. Even in medical sciences, when the corpus or body is to be shown to the students, each and every part has to be shown, then 5G will be most effective, and also for robotic surgeries. I think we are at right side, no problem. Satellite com has its own applications, but nothing was there. And in fact, for GIS application and other applications, like for example, somebody was telling, Dr. Rata was telling in Punjab, the land records here, the present government was trying to digitize all the land records, and here in land record, due to MSP, they say MSP will be given as per the acreage, okay? Because there were false claims and other things. They have, using the drone and others, they have digitized all the land of Punjab, agricultural land, and accordingly MSP, the based payment is done. It has its own applications, even in disease surveillance, let us say in telemedicine, disease surveillance, it is still being used in satellite. Especially mosquito breeding takes place where temperatures are high. So through satellite, you can find out where the temperature variance and differential is there. And accordingly, models can be generated. It has its own application. Telemedicine was first started through satellite. And each and every state was given free satellite nodes, free bandwidth, which is not possible through any other means. Government has supported this, and now it has spread to every PSC level and others, like even using eSanjeevani. eSanjeevani is a good application now. But since it is a government-owned application, government didn't want to take any risk, and they didn't want to tie up with a private firm, because that would show a favoritism to anybody. They had a very good platform like eSanjeevani. They had a net of 2.4 lakhs of CSC, common services centers in the country. They had the infrastructure. They had the emergency requirement during the COVID, and they launched it, and they are successful. I think it's a time.
Thank you, Mr. Mangal. Now there is a question from chat box. Mr. Deepak Mishra, you are here. You want to ask yourself, or can I read it? subject. Deepak
Yeah.
Mishra?
Okay, sir. Thank you very much for the presentation. I just have a question on the security of this medical data, because we are using this, WhatsApp or any other media for showing, let's say, X-ray reports and any other sensitive data to the patient, which is, I think, very secure, has to be secure. So how in telemedicine, we can ensure such aspect, because it may be, as a point of view for a patient, it need not to be revealed to anybody else in other thing. So that aspect I just want to have your thoughts on that.
So, Mr. Mishra, this is a really, really good question. It's a very important and a very pertinent question today, right? Something that people are concerned about. And in the context of the presentation I have provided, the way I would think about this is first that the data is either going to be insecure at the patient's end, in which case you don't have to worry about it as a doctor, or it is going to be insecure at the doctor's end after it's transmitted and it's on the doctor's device. Because WhatsApp and most other such applications these days are end-to-end encrypted, you don't have to worry too much about losing the data in transit unless somebody is pulling a fairly sophisticated attack, right? Now, once the data is on your device, then it is, of course, your responsibility to make sure that you are keeping it secure. And usually on Android, of course, you have these hidden spaces and password protected areas and, and encryption that you can use to protect protect data. You can do the same thing on your desktops. You can do the same thing on any digital device that you may have. But what you should definitely not do is, store it on the cloud without any encryption with open access. That would be very unfortunate. But if you are just going to be, let's say, letting all the data rest on your phone and making sure everything that is backed up is encrypted before it's backed up, you'll be fine. So that's how I would think about it in the context of the presentation. In the larger context, I would say that this is a massive problem because there are a lot of, I would not say unscrupulous, but a lot of conflicting interests with respect to that data, that this medical data, because people think they can make a lot of money of it. I am yet to come across a case where somebody has become a billionaire by using medical data, to be honest, right? This telemedicine medical data. But people think that they can someday become billionaires by using data. So we have to be careful, and it is incumbent on us, both as patients and as doctors, to actually read privacy policies, understand what data is going to be, what at least the company is saying on the face of it, what they'll use the data for, right? At the bare minimum, understand the intentions of the organizations where you are saving the data and seeing what they are saying they will use it for, what they are saying they will not use it for, and then make a decision as to whether you are comfortable with the data being used in that manner, and understanding whether you have the right to allow the data to be used in that manner, because with the new privacy law that is, of course, it's delayed, but with the new privacy PDP bill that is going to come in, there is going to be a lot more regulatory burdens, you can say, on people who are data fiduciaries, or people who are storing data for other people, or doctors, for example, who are storing data of patients, or third-party organizations which are storing data on behalf of doctors for patients, right? So it's going to be really, really, this thing is going to blow up, I feel. It's going to be really, really important to for all of us to become more aware, to read these 2-3 page privacy policies to understand what the data is going to be used for.
Thank you,
I hope that answers the question.
Yeah, right. And I think previous speaker, Dr. Rata, has also applied in the blockchain contest, similar thing of the data privacy. So, Chintamani, any question in YouTube?
Wait, I'm checking, sir. No, sir, there are no questions in YouTube.
Okay. So now we'll go to the next. Thank you, Mr. Mayank Agrawal, for elaborating, explaining about your work contribution. And we congratulated you have done a simulation of the millions remote consultant. You have done this thing, work on millions of the remote consultation. It's a really admirable thing for us utilizing the telemedicine potential. Thank you very much, sir.
Very
Thank
good.
you very much.
Thank you.
Thank you very much, sir. It's a pleasure to have you.
Next talk is on televital journey and the latest trends in telemedicine technology. So Mr. Satish Bhatt will be delivering this talk. Mr. Satish Bhatt is from Televital India Private Limited. He is associated with the development of mobile application for telemedicine application. So I request Chinta Manipai to introduce him, please.
You want to finish this talk now, sir? Because I think scheduled at 2 o'clock.
I think we can start now. Once started, I think after this we can have a break.
Okay.
That's what my proposal depends upon organizers. Otherwise,
okay, no problem.
I think Mathur is right. I think we should start. Otherwise, somebody.
No, we can finish now. He will not take much time. That's what he said. I think we can go
Mahesh,
ahead now.
will not take
One 45 minutes. Easily we can give.
20 minutes is enough for me.
But sir, absolutely no problem. You can go ahead now. We have got enough time.
Good, Mahesh.
A lot of people know.
Okay, what about
Can I start? Yeah. I'm starting with my introduction. It's great to have Mr. Satish Bhatt here, who will be talking about the latest trends in telemedicine aspects. And so let me introduce Mr. Satish Bhatt. He's from Bangalore, and he's working as solution architect in Televital Private Limited, based in Bangalore. He's working in the field of telemedicine technology for last 8 years. His major contributions to telemedicine through Televital are telemedicine product development for ISRO telemedicine projects, telemedicine product development for Pan Africa e-network, telemedicine software development in USA and Mexico, cloud-hosted telemedicine platforms for hospitals in India, Mauritius, and Africa, and then cloud-hosted telemedicine platform for state government projects like Uttar Pradesh, Tripura, and Karnataka. And he is also associated for developing telemedicine mobile applications for India, USA, Africa, and Mauritius. Thank you so much, sir, for joining us today. And over to you, sir.
I'm sorry, Mr. Bhatt, I have preponed your talk for this session.
No problem, sir. No problem. It's okay. Yeah. Thanks, everybody. It's nice to connect with you all after a long time because ISRO and space has been our foundation, and I would say we have been thriving on ISRO's projects from the beginning, and now after that we have moved on to various other projects. But initially it was all through ISRO. Thanks,
yes,
once again.
there's some problem with voice. I also noticed there's an echo, and your face is dark in the sense light conditions. Yeah, that's good. And you should be at one position also. If you move back and forth, your voice also gets loud or low, something of that sort.
Yeah, you should not move you keep it straight to the possible extent, please, and close to the mic. And if any other device is using,
no. Yeah, it's our office fiber network.
It's slightly.
Is it okay?
Now it's okay. Level is okay. Okay, you go ahead.
1 second. Give me change my. Give me a minute.
But sir, are you facing any problem? Should I make a presentation? Should I open your file?
No, no, sir. It's okay. How
Okay,
is it now, sir?
your voice is clear now.
Okay, sir. Let's
Good.
continue, sir. Okay. So I just changed the network. So let's try this.
Okay, okay.
Okay. Yeah. Yeah. So thanks again. And as I said, ISRO has been one of the main, I would say, foundation for televital, and we have been working with them for last 18 years. And so let me just share our journey, because telemetry, I would say, is kind of grandfather in the private sector who have tried a lot of things on the field, and maybe a lot of new entrepreneurs can get a lot of experience from our journey. So that is the intention, and I just want to share what is the latest trends that is happening. So let's go ahead. So regarding our journey, Televital actually experimented a lot, and they did a lot of projects in the initial days from 2002. We did NASA, we worked with ISRO, we worked with TCL for African projects. We did a lot of private projects. Those were the days when internet was not so good. System, meaning computers, we had to use computers, big computers, and we had to use fixed telemedicine rooms. So there were a lot of challenges, but we have implemented, and at that time, whatever the stages, we have crossed all those things, and now we have come a long way. And so this is what it is. We have worked with the great organizations of that time, including ISRO, TCL, and big private hospitals. So these are all our one. So ISRO, I just want to thank ISRO, because with them, we did the Army Telemedicine Network. With them, we went to the islands, Andaman Nicobar Islands, the Lakshadweep Islands. Then Northeastern Telemedicine was another big experience. If you say, these are all tough terrains, and with ISRO, it gave us a lot of experience of how to really implement things. Those were the initial days of telemedicine. And the Cancer Telemedicine Network, which was exclusively for cancer, and the mobile ambulance, and where ISRO tracking antenna were put up. That was also one of the first. And telemedicine during the tsunami was another great experience. Sangal sir would know, like how after the tsunami in the Andaman Nicobar, how ISRO and Televital together implemented.
But your port Nicobar, Nicobar Island, that location telemedicine room is gone, swept away during tsunami.
Correct. So I think those were the days when engineers had to sleep on the beach and get it up and running. That was
correct.
Level of commitment of ISRO, and we gave our contribution, whatever we could. We supported them, and that is how, with that foundation, I think telemedicine has now been built on those foundations of and experiments of those times. And statewide telemedicine of Karnataka, Chhattisgarh, Kerala. This was also like there used to be statewide district level hospitals used to be connected, and that was also a very good experience. And pilgrimage centers, yes, this is also one of the great experiences, like the Anantnag and Kumbh Mela and such events, Shabarimala, Pampa. And if you see, these are all really required places where ISRO has really thought through and took us along and implemented. Those were the real pain points at that time, and they were given the first priority. And that is where everything started. Even before coming to the mainstream, the tackling of the problems where it was really required, these are the places I think no other private sector, I'm sure, private sector on its own will never go to these places. It is only with people like ISRO and such and government who will fund and get it going. So I just want to thank ISRO for that. So these were some of the photos of the gallery of that. So inaugurations, all those good times of the initial telemedicine days. And then Africa is another thing. So again, thanks to TCL and MEA, again, based on the ISRO's success, TCL and MEA took up the great Pan-African project where 44 countries of Pan-Africa were connected to 12 hospitals in India. This was also on satellite and the undersea cable, and we implemented the telemedicine software services and support. So this ran for almost 7 years. And this was also one of the great experiences. And a lot of challenges did come, of course, with respect to language, time, and so many other societal barriers. But a lot of our Indian partners, if you consider Nanavati and all, they even took translators to give telemedicine consultation to African countries. And the time duration, they had to work at night, almost our evenings. And so a lot of consultations used to happen at evenings. So such kind of activities did happen, and we are proud and we are happy to say that we were given the opportunity and we did our bit, whatever possible. And again, we were awarded the Telemedicine Company of the Year in 2009. So that is one thing I wanted to share. And other models which I wanted to share is the telemedicine in the residential schools of Tamil Nadu and Karnataka, because that was also another required areas where in the schools they need healthcare. So that was also one example and implementation. And Karnataka prison is another good example, and we got a lot of experience in that prison telemedicine also. And mobile vehicles, where vehicle moves from town to town, we implemented many mobile vehicles in and around Karnataka. So that is another thing. We did experiment
we are not able to listen you. Satish? Then Chitamari, check.
Remote ICU monitoring with
your voice. His network is down.
Okay.
Now he's back. Yeah.
Please.
It was a brief disconnect. Sorry for that. Yeah, so what I wanted to say is the PPP model, where we are working with Uttar Pradesh government. We have provided our technology to one of the service providers. Here, the interesting thing is the private party has to bring in all the specialist doctors, place them in a command center, and invest in all the remote centers, like the 130 remote centers which Uttar Pradesh government started in northeast Uttar Pradesh in this belt. So 130 centers, the private party had to invest all the equipment and even put one person there to operate from 9 to 4, and the doctors also were there from 9 to 4, and almost 13 specialties have been identified and they have been working. It has been 2 years now, and 275,000 consultations have been done in the last two years in the PPP model. This is one of the flagship projects, and Uttar Pradesh government is very happy to have this, and this will run for another 4 years. So this is one of the PPP models, and I think a lot of a lot of states will replicate this, I'm sure. So this is one experience which I wanted to share. This is the trend which is happening. And another trend which I wanted to share is this is the dashboard, and we wanted to show that how UP government is adopting a lot of technologies, and even the chief minister integrating with the chief minister dashboard and such things have been done. So it is a full-time activity of telemedicine which has gone. It's a big leap in the government telemedicine, I should say. And another is the direct to home. I think most of you know about the latest trend in this, where patient is at home, doctor is at home or in his clinic, and they do telemedicine consultation using the apps and the cloud. And this has been the latest trend. I think a lot of companies have come into the app space now. A lot of services are available, and this space obviously is a very big space, and one or two companies cannot is not sufficient. A lot of companies will come and will support the whole private sector. And as you know, since we have been in this field, we have also started supporting the direct to home concept, where doctor and patient can do on a payment basis. This is another very good model, and patients are getting real benefit out of these models. And coming to the latest trend, since I have been in this field for 18 years, I will focus on those areas which I feel will feed into the next generation of telemedicine technology. So as you all know, and as you all pointed out, 5G mobile network is surely going to feed. It's an ecosystem happening thing which will surely feed and help telemedicine to go in a very big way. So surely 5G will help, and Bluetooth and IoT devices are coming a long way. And nowadays we are working with some IoT devices which are so simple that patients don't even need an app nowadays. They just have to take the reading and it goes to their cloud. Everything is mapped directly, and it simplifies so much. And it is coming the other way around. From nowadays, doctors will provide packages where they will be calling. So whether it is COVID or lifestyle disease management, nowadays it is all package based. That is also coming. I'll just talk about that. And labs and pharmacies are supporting in a big way, because they are also wanting to do sample collection from home and home delivery of medicines. So they are again feeding this telemedicine, because patient anyway is at home, and they want to, after the consultation, they want support for all these lab and pharmacy related things. So that is another major feeding thing, the ecosystem thing, which is supporting, and that will push telemedicine to the next level. And nowadays you must have seen the payment mechanisms have simplified so much. There are a lot of payment gateways available with very simplified methods. So between patient and doctor, there can be very good payment mechanisms, which is leading to commercial telemedicine. Because if you see the initial first 10 to 15 years, we used to have a lot of problems in commercializing telemedicine. It used to be more of a technical projects. Now it has become a real commercial activity, and I think now it can sustain on its own. It will surely grow. That is the thing. And advanced security systems, encryptions and blockchain, all those things are coming, which will surely give support to this telemedicine, because when we have all these things in place and patients know that their data is secure, they will not have any issue with using online platforms. They will not have any issue in keeping their records on the cloud. But uh, now TSI has given the guidelines, and I think all those encryption and audit related things are some things which will have to come, and I think they'll surely come up with all the audit related things for all the companies, so that we can give a lot of what do you call encouragement, as well as patients can have all that confidence to use the telemedicine. So analytics and AI has to come in, because these days nothing works without analytics and AI. Now, if you see every center in the remote, there is a requirement for people, a nurse or somebody, and there are a lot of chances of mistakes happening, referring to wrong doctors. So for all those things, now analytics and AI is helping a lot. So referral support and collecting a lot of data based on the symptoms. Like when a patient gives us symptoms, asking for little more questions at the nurse level itself, so that doctor has enough information. While they, by the time they come for consultation, giving enough information is the responsibility of the other ecosystem people, because doctor's time is very important. They're already busy during their regular activity. So such support, and also helping them track the traffic and all this one, when they are going to get what the periods when there might be more traffic. These are all the AI related predictions that we have to do and support the doctors. And for patient support, using the chatbots and such activities, so that they don't get lost. Patients need a lot of support, and bots are really required to help and do the support. And diabetes management packages are coming up, where coaching and helping the diabetes people to manage, because most of the patients are at loss as to how much insulin to take, how much exercise to do, how much food to take. So for all these things nowadays, AI and analytics is helping, like triggering or predicting and telling them, okay, how should they change their exercise, how should they change their food habits, and all these things in real time. And this is individualized analytics. So this is coming in a big way, and a lot of doctors are going to get on to this package and coaching based on the support given by the technology and AI. This is something which is happening, which will happen. And the weight management is also something which is coming up in a big way, and a lot of analytics. This, again, individual patient analytics will go in, and prediction and what they should do, and coaching. So all these things are the next trend. A lot of you already know that nowadays software can interpret radiology images or the retina images. All those things are surely going to happen, and the specialist need not spend a lot of time on the images that are coming in. The software would have done enough interpretation, and they just have to verify and give the treatment. So telemedicine also can, with such tools and software, doctors can support more patients, and a lot of patients can benefit from telemedicine. And nowadays, heart sounds and lung sounds also can be interpreted from software. All these things will feed in. This will feed into the doctors, and they can take better judgment, better service to the patient. The patient is already remote; they don't have access to them. Along with that, if they have enough data, at least they can feel confident that their judgment is good. They can have that satisfaction that they have taken good judgment based on good data. So these are some of the things which AI and analytics will surely help. I think most of them vouch for it. So coming to the summary, telemedicine, I think, will surely become more and more cost effective. That will be one of the major things. And I'm sure in coming days, patients will surely adopt telemedicine first. When I say telemedicine first, meaning they'll do a first consultation with telemedicine and then go to the doctor, so that they already have established the relationship. So telemedicine first is something that will surely happen. So doctors will surely take up more and more telemedicine patients. And now, because of COVID, there is a paradigm shift, and a lot of doctors have now started accepting and taking it up. What we could not do in the first 15 years, now suddenly due to COVID, everything has turned around, and telemedicine is surely taking up. And now is the time for all the technology companies to jump in and feed the healthcare segment, so that telemedicine grows multifold. And chronic care and geriatric care surely become very much telemedicine intensive, because it is not an emergency. There is surely, based on coaching and all, they can surely get care at home. So I think this will surely go a very long way. So these were my thoughts, and thank you for giving me the opportunity. And with whatever our 18 years of experience, and I urge all the healthcare faculties and the technology companies to go to the next level with AI and support the telemedicine field and take it to the next level. Thank you. Any questions, please?
Thank you so much, sir, for such an enlightening talk. And the platform is now open for question and answer session.
I have a question. Mahesh?
Satish, sir.
Satish. Oh, Satish, sorry. Satish,
yes, sir.
I have a question. See, how many nodes you have in UP in total?
This is on the PPP, it is 130, sir.
130. They are located at district level or private hospital or government hospital?
They are CHCs, community health centers. They're slightly above the taluk.
Up to taluk. Okay. Now, there is also, it must have definitely been useful during COVID, right?
Yes, sir.
Okay, then if that is so, have you ever tried the interoperability of the most used platform eSanjeevani app with your televital software? Did you ever try, or if you tried, there were some problems?
In UP, since it is driven by the government, they didn't insist, but Tripura government has taken it up, and they are using eSanjeevani in their statewide telemedicine. And since we are doing teleophthalmology, their work is going on, sir.
No, I'm talking the different platforms interoperable among themselves, especially for some of the vital data transfer, or let us say, some of the places eSanjeevani as also a televital system is maybe available, and are they integrated? Government has not decided for integrating them, or there are some problems?
No, sir, it has not yet come up, meaning they have not asked the vendors to do any such activity right now. But one integration that has happened in Uttar Pradesh is there is a central patient portal. Okay, that is a third party. All the patient records from a lot of projects are coming and accommodating there. So we are also pushing our patient records to that system. So something which has happened.
So total you have how many? 700, eh?
This is 130, sir. In
130, okay. Plan to expand it further there in the state?
Yes, sir. So they have totally another 800 in plan, but that is going to happen.
Okay, okay, fine. And they are working with at CSC, with CSC?
Yes, sir. CHC.
Common Services Center?
Yeah, common health.
Okay, fine, fine, fine.
Health
You
center,
didn't have any
community
problem
health center.
because most of the yeah?
Community health center.
Most of the platforms, they don't have any problems in the sense in terms of connectivity through this cellular. You are connecting to cellular or what?
Yeah, cellular, sir. So
Cellular.
place it is all Airtel or Jio. So that is sufficient, and we have been working with that.
You have been working. You have been
both.
assigned. You have been assigned some this thing. Address.
No, sir. This is working on the internet platform.
Achha, it's working on internet platform. You are not assigned a different address, independent address, huh?
No, sir. It is all PPP. So we have invested, and we are only operating. And they gave a list of mighty empaneled cloud providers. Like government has empaneled some 8 cloud service providers. We have to take only from them. That is the only.
Fine. Okay, fine. Good. How many consultations you have done till date?
It is currently 2,75,000, sir, as of now.
2,75,000 consultations during the last 2 years?
2 years, sir. Yes.
2 years on what? All aspects, pulmonary.
Yes, sir. So, yeah, there are 13 specialties. General medicine, pediatric, gynec, orthopedic, then nephrology, urology, this one rehabilitation, cardiology, oncology. So 13, total 13. Sir.
Okay, fine. That's good. Achha, can you send me the detail about this activity of UP, wherever you have installation, at my email, you know my email, sangal80.
Yes.
You talk to
Yes,
Mahesh
sir,
also. I want this information, okay?
Yes,
okay.
sir. I have a write-up. I'll send you, sir. I have a white paper on this.
Okay. I have this. You have my mail, sangal80?
Yes, sir, I have.
Okay, send me. Thank you.
Okay, sir.
Thank you, Sangal Sahab and Mr. Bhatt. Any other question, Chintamani, from you two?
I have two things to ask to Mr. Bhatt.
Yes, sir.
Yeah, but sir, one thing is now actually presently we are doing all webinars. Later on, suppose if we do a conference in an old-fashioned way, and we ask you to demonstrate one of the systems of telemedicine, is it possible for your company to show a system? Because when these young college engineering students, medical students are there, and they would like to have a sort of system or demo of that. Is it possible?
Sure, sir. Yeah, we'll do, sir. Not a problem.
It is possible. And
Yes,
point number 2, our future activity is that we want to have a telemedicine and health seminar in all the states, one by one. Okay, state-wise, like Karnataka state, Gujarat state, Tamil Nadu, like that. So we can involve more and more doctors of that particular state and their state health department and have more talks. Okay. So what way your company will be helpful to us?
Since we are in Karnataka, we can look at whatever we can do in Karnataka. Since we are in Bangalore, so we can say as a team we can discuss and
basically when we do this type of webinars, so we basically 3 types of problem. The first problem is of the speakers. That is not very big. With the help and contacts of others, we can get the speakers, and we have got good people. No, so far nobody has asked to charge a single paisa fee for delivering a talk. So all are delivering honorary.
You're talking
And
about sponsorship.
yeah, number two is when we do a webinar, my expenditure for this event is around 25,000 rupees, not much. And that basically where I spend, that I'll tell you. Basically, for we use a party for 2 or 3 days for the Zoom network, let us say, per day charges, plus some clerical charges for a person who takes care of the emails and brochure designing and other things, our what you call poster making and all that kind of thing. Purpose is our purpose is not to earn money. Basically, we are all ISRO retired scientists, and we are all working like Najansa, myself, BD Mehta. We are all working last 2 years or so. We have done a lot of activities. Okay. And nobody is asking for any money. All are giving their good services. Even people are readily agreeing for giving talks on different topics.
Yeah, that's good, sir.
So,
Mahesh,
yeah.
You can talk to Mahesh, but you can talk to Mahesh. I think it's a good proposal. See, your work he is doing, okay? Propagating your things, okay? In the process, he is training the budding people, medical colleges, let us say, schools and colleges, the awareness of telemedicine, how it has helped in COVID. You know, I think there is no harm. You should support him.
Okay. Now, point number three is now we have got good speakers. We have planned the total program and the audience participants. Now, how to do the publicity? Because this time, especially, I face this problem because I don't have any contracts in the hospital and medical colleges. If you talk about engineering colleges, I have got very good data. I know all over the country, many people. I can contact them, mechanical, electrical, or any branch of engineering. Absolutely no problem. But as far as now this telemedicine is and healthcare is concerned, we are dependent on our friends who are having medical background. So I was this time I was mostly depending upon Medical Council of India. I written to them also. Then like Ahmedabad Medical Association, I have written to them. Then TSI, like Telemedicine Society of India, at least I think 4 or 5 ex-presidents of TSI are attending this particular webinar. They have delivered the talk. Many people are associated with TSI, and I was also mostly depending upon them that they will help at least as far as participants and audience are concerned. But when I see finally the total thing, it is not that good. Now I know on YouTube yesterday they were around 240 or so, but I was expecting more than that. In my other webinars, what I have arranged, it reaches even more than 1,000. Okay, so because this is a very popular topic and the need of the hour. So if we do after 2 years a webinar on telemedicine, it may not be of any use. Now this is the COVID time and people should get that knowledge, and people are working in the medical field, technical field. We should try to have more webinars in shortest possible time so that message is conveyed to the society. And people know, your patient knows, normal public knows, doctors also knows, the young doctors who are coming, okay, what are the advantages, and the technical team also knows about that. So we need everybody's help here, for these 3 problems. And hope Bhatt you and your team, Rakesh and others, they will definitely help me.
Yeah, sure, sir. We are always there. We have been there with TSI also. So we participate in the other conference also. So we are there, sir.
Yeah. Thank you very much, sir.
I have a question for you.
Yes, Chintamani, please go ahead.
I have one question for you. You said many specialties are being done there. I wanted to know, when you are using mobile phones, are you using images also, like X-rays, fundus images and all that? Or it's just texting, or EMR, a basic thing when you consult?
Yeah,
this is common service centers, no, by the government, or it is PHCs?
Community health centers. It is almost near the taluk, what we call the above the PHC, above the taluk, near the taluk level.
Okay, bigger, more than a village. What you're saying, more than
a village. It is not a village.
What you said, they are using only mobile phones. That's what.
Not only mobile phones. There is we have provided a PC also. meaning the laptop also. Doctors are using laptop also. And we have given a set of medical equipment which includes parameters like ECG, BP, SpO2 temperature, and the CSA also has a set of equipments.
Because
Whatever
anybody
we
will see there will be only paramedical staff. No? When you want to consult with someone, you need an EMR or something, some basic details you need, no, about the patient. When you want to give
EMR.
EMR is
Correct,
there.
madam. Full-fledged EMR is there. Full-fledged EMR is there, which collects the complaints, symptoms, past medical history, family history, and all the reports.
What
So
about
all
images?
the images also, ma'am. DICOM images are also supported. So DICOM images and DICOM viewer, so that whatever the patient has or gets it done from outside, they bring it in a CD and upload it. Doctor then sees it and
Mobile phone, you know, you said connectivity. Even for the laptop, you need a data card, something, no? For connectivity.
Yeah, they are using dongles for hotspot.
Okay.
You get this Airtel and Jio hotspots, which comes as a device. So we just feed in, we just use the
yeah, we are also doing the same thing for an offline EMR. I'm connecting camps. So I use that whatever hotspot you're saying, the same dongle. We connect 4 computers and share our EMR at the same spot. It's like, it acts like a Wi-Fi sort of thing where 4 computers can be connected and images can be uploaded. But some of the instruments allows image transfer. Some we have to put the USB and then transfer it.
Yeah, those issues are there, but there is a laptop also in the CHC, which we have only supplied as part of the, since it's a PPP model, we only invested and supplied it. So since laptop is a lot of such report handling and all can be easily done.
Okay. This you're doing with the government of India.
Yeah, government. Yeah.
Your company and government of India is floating the thing, providing the technical
tender. It came through a tender and it was a PPP. Even though it was a PPP, there was a tender, and after winning it, we had to.
How are the patients coming during the COVID times?
COVID times, yeah, a lot of patients are coming, but there were 2 issues. One is the CHC also had to handle the COVID emergency center. There were protocols in place. And along with that, we had to do the telemedicine also at the same time. And yeah, it was a bit difficult during those times because mixing the two, sometimes government was preferring to avoid mixing the other specialties. Sometimes some few days they used to plan to, what do you call, do away with OPD. For some days they didn't want to do OPD. So
yeah, it was a difficult time for all specialties. Some we were able to do, some we were not able to implement. Even when doctors are there, some things we were not able to implement, some only we could do because of the COVID government guidelines. No?
Government guidelines, yeah.
We had difficulties.
Yeah, but, so some activities were happening, but again,
my email ID is given in the chat. Can you send me the white document? Second thing, are you screening diabetic patients for the eye, diabetic retinopathy?
Where in your
PHCs?
As a this one, I think in Tripura we are doing
diabetic retinopathy, teleophthalmology Tripura. They were doing it. After that, there was a problem. No, government took off from one company was having it. After that, there was some problem and it was taken from that company. Now you got the tender.
No, madam. Same. This one we are just waiting for restart. So
yeah, they have not restarted. There's some problem there.
Yeah, there is some formalities going on.
Because I've been interested. I know some ophthalmologists in Tripura. Been following it. We wanted to implement diabetic retinopathy screening.
Okay.
Because diabetic patients come in and they become blind. If diabetic, because one eye they can see, other eye only the blindness is there. So patient doesn't realize. It's a silent thief.
Correct.
Very silently, the vision goes off. So we were trying to implement. I would like to do it even in UP, so that the patient who is coming there does not become blind. Everything else is getting checked, but the diabetic retinopathy, you have to see the eye. So
right.
if we could
But as of now, that the 13 specialty is actually decided by the government before the tender. So only specialists that are there. And,
ophthalmology is not one of them.
Yeah, in UP, ophthalmology is not included.
Is included or not included?
No, not included.
No, we can write to the government.
They can any day make
it. Once we see the white paper, we can write to the government and ask them for funds to implement, because it's a blinding disease. No, patient becomes blind means it's an economic burden to the country.
Correct.
They're not going to earn.
Right.
So that's how we see it. Anyway, patient is coming to the hospital. Might as well see him there. When he goes back, we can't do the camps.
Yeah. Actually, footfall is very good in Uttar Pradesh, meaning a lot of people need the service, and these community health centers are crowded like anything. So they need a lot of services in a lot of specialties. But since the government was entering into PPP model, they were not sure to open all the specialties. So they just tried it out and it has been successful. So now I think it's time to add on.
For every diabetic patient, you should screen the retina to see, because it's a very sad thing, because of the two eyes, one eye is good. The other, the patient doesn't realize till he loses completely vision. It is in the best earning years, 45 to 55, when you're just in your prime earning thing. So that should be attended. So maybe when you send my paper, we can put it. Thank you very much. Very nice talk.
Thank you.
Thank you, Dr. Sheila John, for interacting with the certificate. And you have rightly pointed out that the images also should be able to transfer it. And really great boon to the patient if his eyes can be saved. Okay, thank you, Satish. And now, Vintamani, you want to say some announcement or?
So thank you, Mr. Satish Bhatt, for coming here on a virtual platform to share your technology and enlightening us about telemedicine. With that, we take a break for lunch. Jain sir will be joining at 2:30, right?
Yeah, 2:30. You can announce on YouTube also with some message.
Okay. So if there are viewers on YouTube who are watching us, we are taking break and we'll be joining at 2:30 p.m. after lunch. And we will not be shutting off the live stream link. Only thing, we all will be muted during lunch. And then we'll be joining at 2:30 p.m.
Okay, thank you.
Okay, thank you.
Thank you all. Thank you all.
Everybody,
thank you.
We'll try, but please stay with us.
जैन साहब Hello, Chintamani, have you joined?
Yes, sir, I'm here.
Okay. Hello, madam. Welcome.
Hello, sir.
Where are you both based? Which city?
I'm in Delhi.
In Delhi. Okay. In my future plan, as I wrote to you, I am planning a program for the lawyers where one or two lectures will be about the space science and technology, what ISRO is doing and where is India. Then one or two talks related with the space law.
Sure.
Space law is a very upcoming field for the young lawyers, basically, because a lot of countries now they are fighting their cases in international court of law, and we need some good lawyers to fight those cases.
I think Mathur Sahab, can we start now or just wait for
Yes, yes. I think time हो गया है. कितने लोगों ने ज्वाइन कर लिया अपना? चिंतामणि also has joined.
Okay. We are live, sir.
Let me stop sharing. Yeah.
YouTube पे भी आप चालू कर दीजिए.
हाँ, it is live on YouTube. The screen is telling. Screen पे आ रहा है.
Let us confirm whether there is a pass तो नहीं है. Chintamani, it's live.
Yes, sir, it is live. It is live, sir.
Okay. Good afternoon, everybody. All participants and learned speakers and panelists will be participating at 15:30 for the discussions and other experts. So the next talk is on. I want to tell this thing. Those who have not joined the morning section, we have finished one talk of this thing, Vital Journey and the latest trend in telemedicine technology before lunch, which was scheduled at 2 o'clock, 2 p.m. So now we will be starting from the next talk, that is telemedicine and privacy. That is Bagmukshika Puhan will be delivering a talk, and I request Vaibhav Rawat to introduce him, please.
Okay, thank you, sir. Welcome, ma'am. It is great pleasure and it's a pleasant duty to introduce you here in the evening post-lunch session of the workshop. Advocate Bagmishika Puhan is a technology lawyer and a privacy practitioner. Her core areas of expertise include healthcare, data privacy, and ethical, legal, and social aspects of telemedicine. Advocate Bagmishika Puhan is a policy advocate for digital health and has worked with the government in the past and worked closely with the Telemedicine Society of India in matters related to telemedicine. Her primary areas of practices are regulatory advisory and general corporate and commercial and specific emphasis on subject areas such as privacy, healthcare, telecommunication, and space commercials. She has advised clients in creating privacy frameworks and has helped them implement the same at the enterprise level. She has advised and assisted healthcare institutions and associations in government agencies for regulatory and privacy matters. Advocate Bagmishika has spoken at privacy conclaves, healthcare conferences, and has also provided training to the Odisha MSME members on the issue concerning geographical indications. She has worked with Niti Aayog on issues related to healthcare and privacy. She has provided inputs to central and state government agencies on geographical indications, healthcare and pharmaceuticals, telecommunications, broadcasting, privacy, digital gaming, etc. She is a part of Executive Committee, Regulatory Committee, and the Legal Advisors to the Telemedicine Society of India. She is a member of Indian Society for Clinical Research and also actively involved in the work towards law concerning pharmaceuticals. Today, Advocate Bagmishka Puhan will talk on the telemedicines and the privacy. It is great pleasure to have you for the speaker of the session, and I welcome you and invite you to deliver your talk. Thank you.
Thank you, Vaibhav. I think Madam Pohan will be able to resolve many queries raised in the since last 2 days on the legal aspect, and our many doctors are concerned and also participants are concerned whether it's applicable or not, the claims will be reimbursed or not, insurance company will pay the bills or not, and many other aspects have been discussed since last 2 days. I think your talk will resolve some of the queries, and in future, our Telemedicine Society of India will take the matters to the appropriate authority so that this should be implemented as early as possible. Thank you. Please, Madam.
Thank you, sir.
We look forward to your talk.
Thank you, Dr. John. Good to see you here. So I initially I thought I would not do a slide presentation, but I've created a very short slide presentation, but I would rather have more time to interact with all of you. So I'll take about 5 to 7 minutes to first go through the slides, and then we can quickly move on to an interactive discussion if that's okay with everyone. So I'll just start with sharing my screen. Is my screen visible to everyone?
Yeah, you can make full screen. Yes, perfectly.
Yes. Thank you. So without actually taking much of everyone's time, I would want to give a brief introduction about telemedicine and privacy. As known to all, telemedicine has always been legal in the country, but because there was no comprehensive legislation or there was no framework, many doctors and even the users, as in patients, were not very comfortable with actually participating in the digital health ecosystem, and they were shying away from becoming a part of this particular ecosystem. Fortunately or unfortunately, last year with the impetus of the incidence of the COVID-19 pandemic, the impetus was given to bring in the telemedicine practice guidelines, which the society, we all contributed towards, and we see the guidelines to have been promulgated last year, bringing in a more structured, a more formal, and a more comprehensive framework, allowing the practitioners to adopt telemedicine into their daily practice, and also trying to bring in a more trust-based approach, bring in more faith in the end users, that is the patients, to rely upon this practice of telemedicine. Now, privacy plays an important role because there's a lot of exchange of information that's taking place on the internet when there is a telemedicine consult. In the sense that telemedicine is digital, it's not just restricted to the use of normal, internet for connectivity. We also speak about telemedicine when we are talking about audio consultations or satellite communications, which all of them coming together, any form of technology which is when implemented or adopted for the practices of delivery of healthcare will qualify as telemedicine. Privacy plays a vital role because so much of information is being shared on this module, on this platform, and there is no person who is actually, as an end user, I do not see how the data is traveling from my end to the end of the RMP, that is a registered medical practitioner, or to the platform with whom I am interacting to get the healthcare services. Because of this lack of control, privacy has become an extremely focal point of this entire digital health ecosystem. And as it is, the focal point has always been the patient. So patients' rights in terms of determining how their data is being used in case of a telemedicine consult is why we are discussing this particular topic today. I have borrowed this image from the internet, from the web, and it just, this image particularly signifies the kind of information flows or the data flows that are taking place at every single journey of a person's health or medical life cycle in terms of their, it's like how we say it's from the womb to tomb. So from a person, from the point of them being born to the point of them being going into their graves, the entire journey that is traversed in terms of their health information, or in terms of their medical fitness. There is so much of information created at every single stage. So like this image is, the reason I chose this particular image is it's also talking about how a person is going through a laboratory investigation, as simple as getting, there is a microscope here which is being used for furthering research and development. A person is probably being inoculated. There is a fitness tracker. So there is a smart device which is being connected to a person's wrist, which is enabling that person to actually at least track a few vitals on a real-time basis without even having to go to a pharmacy or going to a doctor per se. Now, every single point here, every single activity that is reflected here is generating copious volumes of information. And that is why it is so essential for us to know what are the rights of the patient who is approaching the RMP. And I'll be using RMP through the course of this discussion to refer to a registered medical practitioner. So it is important for the RMP also to understand what are their responsibilities in trying to manage information of the patient. Now, personal data is any identifier which allows a particular body corporate or allows any other entity to identify an individual per se. Within the scope of personal data, there is a higher category, there is a very sensitive category of data or a special category of data known as sensitive personal data. Under the current Indian framework, under the current Indian legal framework, sensitive personal data has been defined to include these particular identifiers that's mentioned within these slides. So basically, any data identifier, any personal data identifier, which has the impetus or which has the possibility of causing significant harm, prejudice, or loss of reputation to the individual in case where the data sets are misappropriated or used in an unauthorized manner, such information typically qualifies to be known as sensitive personal data. The three identifiers that I have highlighted here and like underlined are the ones which will play a significant role in the medical journey of an individual. So in the digital health ecosystem, these three factors, that is a person's physical, physiological and mental health condition, their sexual orientation and their medical records and history, which will be typically consumed by any digital health interaction, any telemedicine interaction. Biometric information also plays a significant role, but that is not something which is typical to healthcare industry. That's the reason why I have not underlined or highlighted it. Now, the reason why it is important to note that health information qualifies as sensitive personal data or sensitive personal information is because these categories of information are supposed to be dealt with a higher level of security, and to it cannot be processed without the explicit and informed consent of the end user from whom you are collecting such information. That is the reason why I have chosen to only use this particular provision to stress on the fact that because health information invariably qualifies as sensitive personal data or information, it's very much important for the platforms, for the physicians, for the RMPs, for the caregivers, for the health workers to note and ensure that the information which when is collected from the end user should be collected with a valid consent, and it should be only used for those purposes which are essentially important or for those purposes for which the patient has come to you to. You cannot repurpose that information for anything beyond that. So within the telemedicine practice guidelines, there is a very interesting framework, or there's a very interesting concept which came up, is known as, it's put in under the bracket of consent, where it's talking about how when a telemedicine consult is initiated by the patient themselves, it is said that there is implicit consent given for originating such a telemedicine consult. So there are two elements here. One, that it's by the patient, that the patient is involved, and the fact is that the patient is the one who is initiating the consult from their end. So the origination of the consult should be from the end of the patient. So in that sense, what happens is you do not need to separately take consent of the patient to proceed with the telemedicine consult. However, whenever there is involvement of a third party, that is, if there is any other referral doctor who is involved, or there is a caregiver, or attendant, or a friend, or any other health worker who is involved, and they are trying to originate a particular telemedicine consult, then in that scenario, you must take explicit consent of the patient to whom such consult is pertaining to. Now, this is with respect to the telemedicine consult per se. However, the telemedicine practice guidelines clearly mention that in case of processing of personal information, you have to take explicit and informed consent of the patient. Now, this is something which is governed under the information technology laws. That is why the telemedicine practice guidelines do not talk greatly about this, or do not deal too much into this, because that's the domain of the IT ministry, and that's more comprehensively taken care of under the Information Technology Act and the Information Technology Rules of 2011. Just to add something here, that there is a personal data protection bill which is pending, and that again also has higher levels of protection warranted within the bill itself. So tomorrow when it becomes the law, the personal data protection bill will become the supreme legislation, and the data privacy guidelines or the mandates that are provided within that particular bill will then have to be complied with by all the stakeholders in the ecosystem, that is being the technology platforms, the cloud service providers, the healthcare workers, the healthcare providers, that is the hospitals, and also the RMPs himself or herself. That's the criteria for now. This is the most important focus when it comes to telemedicine consultation. It is easier when there's a platform involved, because then the meteor chunk of compliance requirements is something that the platform ensures that they're adhering to. However, because, and I'm certain you guys would have also, I mean, most of you would have also heard to the talks of the earlier, healthcare practitioners and technocrats who explained how it is simple to use WhatsApp for initiating a telemedicine consult. It becomes very important for you to then know that as an RMP, what is your responsibility. So while the telemedicine practice guidelines came out last year, they did not substitute the laws of the land that were already there. So record keeping was already a part of the mandate that was there under the Indian Medical Council Act, and specifically the Professional Conducts and Ethics Regulations of 2002. So whatever was already there in the Code of Conduct of 2002 continues to exist. And so in one of those regulations and directions which came out under this particular act is that record should be maintained for inpatient and outpatients for a period of 3 years or more. And in cases of medical legal cases, the storage period is for a period of 10 years or more. The same thing continues to apply to this date. Under privacy obligations, record keeping is also a very serious principle, and complete reliance or strict adherence to the timelines is essential. So when 3 years have expired and there is no reason for you to continue storing that information at your end as an RMP or as a hospital or as a healthcare service provider, you must go ahead and delete such information from your records. You do not need to continue keeping that information for a period longer than it is absolutely necessary. Again, like I said, once the PDP bill comes to place, probably there will be a few changes here, and then in that scenario we will be looking at a new timeline in terms of storage. Now, the telemedicine practice guidelines also understood that since all of this is happening in an online environment or is happening in an environment where a person is not directly looking at the doctor physically, being
your voice is not audible, breaking.
What happens is
Maybe there is some network issue we are facing.
Yeah, we can wait. I think she may be trying.
Yeah.
Usually somewhere power failure, somewhere internet problems. So that way we can't say telemedicine in total is 100% reliable. We can't use because of these technical problems also.
So the SATCOM is the best solution.
SATCOM is really 100% reliable. Of course, those issues can be resolved.
But many SATCOM experts, they have changed to this particular field, like Sangal Saab. His expertise is into telemedicine now.
There is a reason to that. The reason to that is satellite com is okay when you want to teach the people or you want to start a activity, and that too free of cost. Now, when there are number of competitors, number of users, you can't give free. So they have to revert to the normal source of terrestrial mode, which is quite cheap. And so SATCOM is not required, in fact, in telemedicine now. And it had its own problem in the bandwidth management. Bandwidth, you have restricted bandwidth. Satellite bandwidth in the commercial basis is very costly as compared to these fellows, the Geo and others. So people have got back into terrestrial systems. There's no harm. The test will survive.
Yes.
लोगों को सस्ता चाहिए, cheapest चाहिए, और
No. But the satellite has its unique capability of the act of national importance. Now people are thinking of going to moon using the galactic. Okay, so ISRO has a lot of future outside. Telemedicine.
सर आप हमारे यहाँ भी देखिए जैन साहब, I would like to draw your attention also. We are doing all these activities, and in 3 days we are giving on 2 days 10 to 12 talks of all well qualified persons, experienced persons, and that too we are charging 100 rupees. And for trainees and other undergraduate students, we are making it free. So even at 100 rupees, we hardly get 1 or 2 registration.
Excuse me, sir. Sir, honorable speaker has joined again.
Okay.
Can you hear me?
Continue.
Madam, have you rejoined again?
Yeah. Yes, sir.
Okay, go ahead, please.
I'm terribly sorry. So I was at the point of consent. So now what happens is, because all of this is happening in an online environment, and it is important for the doctor or the platform to be able to show that there was consent of the patient before you proceeded with the telemedicine consult. It is important that record is maintained. This is part of the telemedicine practice guidelines as well. And even without the telemedicine practice guidelines, under the IT laws also, a person who is processing information, especially sensitive personal information of a patient or end user, has to ensure that there is an audit trail maintained regarding consent. So that's why it's also the responsibilities. Apart from that, the fact that the data has to be confidential goes without saying, that because there is a fiduciary relationship which is created between a patient and a registered medical practitioner at every given stage. Now, sometimes what happens is, when a treating physician is collecting information of the patient, sometimes they may need to share that information with another consulting doctor, with a specialist doctor, to show, or to actually come back to the patient to treat them better, or to arrive at a full diagnosis. Now, in that scenario, while it could be essential for them to do that, a doctor who is probably already has visibility over a patient's information, and there are pictures which have been shared, cannot freely share that information without the patient's consent. It is important that they use that information in the manner that is expected of them to be used, because all of these is happening on an online environment, and there's a documented trail which is automatically created. Even when I'm sending a patient image to a doctor on WhatsApp, there is some backup which is being created. So to ensure that that information is not misused, data confidentiality is of prime importance. Similarly, data security. This is again when an RMP or a physician is trying to reach out to the patients for telemedicine consults directly without relying upon any other platform. It is then incumbent on the RMP himself or herself to ensure that whatever information that they have about the patient is stored in a safe and secure and in a technologically convenient manner. When I say technologically convenient manner, is to reinforce the idea that the patient always has the right to seek access to the information that is available with the RMP about the patient. So in the event where you are not keeping that information in a technologically convenient manner, it will become difficult for an RMP or a platform to pull out that information every time a request for access is received from the data subject, or that is the patient in this case. So these are basic responsibilities that, you know, anyone who is processing sensitive personal information has to adhere to, has to comply with. Now, I have chosen to keep this more at an individual level because platforms are already aware of this, and platforms have the wherewithal to reach out to law firms or to other lawyers and to fill out the gaps that they think is there in their understanding. However, a physician might not necessarily come to a lawyer and, you know, have these questions addressed and then go back to start with their practice. That's why my focus of this discussion has been how it will be from an RMP's point of view. Now, with that, I would not want to take more time. I would conclude my discussion, but I'm here to have an interaction with anyone who has any questions or whatever has been discussed in the past, like Mr. Jain mentioned some time ago.
Yeah, anybody is having any questions?
Yeah, I have a question. I have a question. Can I?
Yeah, please.
Bhagmeshika, how are you?
I'm good, sir. How are you?
Yeah. So now I have one question on our TPG and thing. See, you just in the last slide you have shown record keeping. Record keeping for by the hospitals or by the law. That is one thing. For inpatient and outpatients, okay, you said 3 years, and for medical legal cases 10 years. Okay. Now suppose I'm an outpatient and I have some problems after 4 years, 3 to 4 years. Okay. Then which category do I fall? I fall in legal cases. Right?
Sir, medical legal cases are not actually legal disputes per se. Medical legal cases are more in the nature of where there has been a crime committed and there's a victim. So in matters of rape, adultery, and where there is a legal provision there, so those cases are treated as medical legal
So
cases.
let us say a doctor performs an operation on XYZ or anybody, any hospital, okay, and later it is found out that my kidney is not there. One of the kidney is missing. It becomes a legal case. Then I find out why through when I go to other doctor, he finds out after 4 years, "Saab kya kar rahe the 1 saal tak, 4 saal tak." Then it becomes a legal case. Then by the time, since I am an outpatient, my records were only for 3 years. I don't have records after that to fight a legal case because it is mandatory to keep only for 3 years for in and outpatient records of the patient. Right?
So that is the minimum timeline. So to be very honest, nobody is going to delete the data after 3 or 4 years. Hospitals have legacy systems and they have records of patients probably who have already died. In my knowledge, in my personal experience, what I have seen. So they have set it at minimum 3 years because, I mean, in the example that you mentioned, I'm not a qualified doctor, so I'm not sure if this is correct, but then if somebody is missing a kidney, I'm certain it will be under 3 years that they will find complications which will force them to go back to the hospital. But medical legal cases per se is because they have started from the point where there is an offense or a criminal matter involved. Even in a case like substance abuse, the mandate has been kept as 10 years because there is a chance of relapse because it's starting as a criminal procedure in itself. So, but hospitals, now, the reason I mentioned that for a doctor, probably the doctor will not have the wherewithal of maintaining records at their own level because there's a cost attached to it. Even if I, let's say, use Google, after a point for, let's say, I see 10 patients a day, after 3,600 patients a year, I will rely upon paying for extra storage, be it to a Google or an Apple or a Microsoft, somebody. So it's because for them, the minimum prescription is 3 years, so that in the event where a doctor wants to purge that information, nobody is going to hold the doctor accountable. Because, as a patient, I am also duty bound to keep records of my health records as a general matter of principle. So that's the reason why the minimum timeline is prescribed. There is no maximum. Right.
Madam, I have a small question.
Hari.
Yeah. Can I ask, sir?
Yeah, sure, Hari. I think you have posted in chat also the detailed question.
No, I am Shaijuman.
Yes, sir. You can go ahead, sir. Dr. Shaijuman.
Yeah. Actually, regarding this telemedicine, if a patient find that his or her data is something like lost, or it is appearing in a social media or somewhere, what kind of legal action that he or she can take? Is it coming under the purview of legal thing? Because most of the time, I have found from the field that some educated patients are actually very much worried about their online consultation and sharing of data. So what are the legal provisions, or where they can approach?
So telemedicine practice guidelines, they have mentioned that in the event where it is, as a RMP, if it is at your fault, I mean, let's say you have chosen to freely share that information on your social media. Let's say somebody performed a surgery and you uploaded it on Twitter, where it was not necessary. It is not even educational. Let's say in that sense, it might qualify to be a matter of professional misconduct. Apart from that, it could be a consumer case that the patient decides to proceed with, or it could be general civil and criminal litigation, depending the extent of it. Like, let's say if somebody, like to give you an
One
example.
concern is there are a lot of, yesterday also one speaker was mentioning about this, lot of platforms are coming, private parties are coming for as an intermediary for registration, or collecting money for consulting a doctor and all. When this situation is there, how we'll approach, how do we know that whose responsibility is that? Maybe because it is losing from an agency, so then it is not responsible with the professional doctor.
In case of a platform, to be very honest, when I was giving that talk, I mentioned that when you are dealing with a platform, it's easier because the meteor chunk is the compliance requirement obligation becomes their duty. As a RMP, you have to take care of that, you use your access login credentials in a safe manner. You do not go about giving people your access to your platform information, password and all. So as long as you are ensuring that whatever you did was in your best efforts, and tomorrow if there is a leakage from the end of the platform, it becomes the responsibility of the platform. But again, when you are entering into a contractual relationship with the platform, you have to ensure that the liability clauses are designed in such manner that they give you basic protection.
Yeah,
So
most
that
of
you
the
will have
time,
to read it.
that when we download an app, they are coming with all these kinds of hundreds of pages, and
I
nobody
draft them, sir,
read
I know.
anything, and then finally we will end up in trouble, right? You can imagine what will happen to these poor people.
I
Yeah.
draft them, sir, I know. So that's why I'm saying no, but sir, to be very honest, it is something, as long as you're giving your best. Like tomorrow, if I give someone incorrect legal advice and that person, ends up in trouble, I will be held responsible for professional misconduct. I can't then blame my firm to do that. So at your own level, if you have complied with everything, that is why record keeping is of the extreme, paramount, because within the TPG also, it's been specifically mentioned that you should carefully maintain a log. They are not saying that record the entire transactions, but they're saying that you mention that the call started at this time. If you think that the patient comes to you inebriated, then please mention that and say, okay, the patient was inebriated and I will not want to proceed with the telemedicine consult because the patient will not give me clear information. But if you choose to go ahead, okay, patient is inebriated, but I'll still try to salvage, and then some problem happens, then in that scenario, of course, the RMP will be liable. So it will happen on a case-to-case basis. So you have to do your best and let the platform also do their best.
Thank you. Thank you.
Yes. Amritanshu have one question.
I have a question.
Oh, sorry.
For you.
Okay, Sheila ma'am, Dr. Sheila.
See, you said about consent, no?
Doctor.
The patient comes to the hospital, we take the patient's signature and the attender's signatures taken, the case sheet or whatever consent they've given. But when we are doing for teleconsultations, usually in the EMR, there's a tick box where most EMRs only give a tick box where we go and tick, saying the patient has given the consent and we have identified, the doctor and the patient have identified. There's no signature. Is that okay? Is what I want to know. Most EMRs only give a tick box.
It's a valid form of taking consent. That's why I also mentioned that there's a recordal of consent. What that tick mark goes as a log entry in the digital platform, and then the back end, it will be marked as a tick that patient has consented. It's creating an audit trail. So not just for telemedicine, when you're downloading an app like even WhatsApp, there is a tick mark that we tick, right? That I'm consenting to whatever information is being exchanged on WhatsApp and what WhatsApp does with my information. So that is valid. A tick mark is a valid form of contract in the country.
tick box is valid, you say?
It's a valid form of giving consent. It constitutes as a valid contract in India.
Because it just says patient has given consent and the doctor and the patient have identified each other. And we
Both happening in tick boxes, huh?
We just tick and go.
That's a valid form. It should not by default be ticked.
Because the other, when they come in person, it's all signatures.
That's what I'm saying, ma'am.
Which we have taken.
Idea is
that is the difference.
The idea is that by default it should be not ticked. A person should go and click on it and then tick it. That conscious difference should be there.
Thank you.
Thank you.
Okay, I have a question. Could you hear me?
Yeah.
Yeah, Hari, go ahead.
Okay, so basically, recently I made an appointment with a hospital in Mumbai, and soon after I get a message from Practo informing me about my name, age, the lab where I'm supposed to go, date, time, and whether if I want to cancel, what do I do? So I don't understand. I made the appointment by calling the hospital's front desk, but then why would Practo be giving me a reply? I mean, I've not consented to give my phone number or name to a corporate company like Practo, right? I'm going for the hospital, and this I've noticed at other places too. So is this a breach of information or is it a correct practice?
So Hari, typically what happens is, I'm not sure what is the, I mean, this would not be a typical chain in Bombay hospital, I'm assuming. But even if it's a small nursing home, most of the systems, I mean, so hospitals are now integrating their health information systems with a Practo or a Librate or a Docs app, depending whichever app they are more conversant with. So in that sense, the app that they would have would be supported. I mean, their service provider would be Practo. So the minute you must have signed, when you are giving your consent at the point of collection of blood sample, you must have signed somewhere. Did you sign any form?
Nothing. I just called to set an appointment on phone.
Okay.
They just had to give me a test.
Then in that scenario, yes, this is definitely a breach. You can reach out to the hospital and say that, you never consented to being approached by Practo, because now tomorrow Practo, I mean, I'm not saying they will do this, but of course they have created a new profile in your name, because if they have this basic information, then they would have created a new profile. So tomorrow for all you know, yeah, you might actually.
What is to stop them from sharing, if I say go for another hospital for some other test, maybe,
yes,
the phone number might be the same. So if they're associated with that, they might create a history of me. So
yeah, that's a so see, this is the reason why privacy, and I was discussing that, it becomes important because your rights are getting violated here. So yeah, you can reach out to the doctor, because this is not reach out to the hospital, because it's not correct practice. I was under the assumption, because I'll tell you what typically happens when a hospital is integrating these systems, and you go to a hospital and you create that UID, right? Every hospital is now giving you a unique health identifier. So when you're doing that, we fill out a form. So usually in those forms, it's mentioned that we rely upon external third-party service providers to give us healthcare information systems, or they manage our softwares, they manage our tools, they manage our EMRs. So in that sense, yes, there is a valid consent which is taken from you, and then this could have happened. But if this has not happened with you and you just made a call over an appointment over a call, then it's a breach of your right.
Understood.
Yeah, Amritanshu ji, you have one question.
Yeah, sure. Am I audible to you all?
Yes.
So, good afternoon, ma'am. So I just wanted to know, because this telemedicine is a growing sector and all those things are there. There are international level players also involved in this sector. So as a telemedicine lawyer, I just wanted to know from you regarding the concept of the parity, because here it requires the payers in one state or at a place to reimburse the doctors and the other providers in the other states or the other places of the approved telemedicine services. Now, it's being as per the different states or the different places are concerned, we can say different places, they don't even have a proper telemedicine parity law, if I am not wrong. And then there are different private players also which then come into way, and then it's being said that if a parity law is being passed, then it's a win-win situation for a telemedicine. Now, when these commercial players, they come into play, and then this telemedicine coverage, it becomes policy dependent. Now, what's your take regarding this entire parity factor?
So first thing, the telemedicine, unlike US, a central legislation here is applicable to everyone. So that's why telemedicine practice guidelines, the first thing that they did was that they have done away with the borders. So a doctor in, say, the Union Territory of Lakshadweep can consult a patient here in Delhi. So that's okay. That's first thing. Second thing is that in terms of payers, the for reimbursement and insurance. It is the IRDAI, that's the Insurance Regulatory Authority of the country, which takes the calls. Now, since forever there was always that difference between insurance service providers to choose between either reimbursing OPD sessions or not. So what IRDAI has done is that all those policies which were giving reimbursing for OPD consults will now have to go ahead and reimburse the telemedicine consults as well, because they have put this at the same pedestal with OPD consultations. Now in that sense, the ones which were favoring you will continue to favor you. But again, these are matters of contractual law, so you cannot force a company to actually create that reimbursement scheme. That will be breaching upon fundamental rights to do business.
Okay, now got the point. So so in that manner, I suppose we can continue to bill with the help of the private players as well. That is, call up and confirm for the eligibility as we are doing for the other insurance purposes.
Yes, they're doing that because to be very honest, like up until the longest time, nobody knew about cybersecurity insurance. Now at least India is doing that. So if you reach out, I mean, if there are 100 players today, and out of them, let's say 60 are giving reimbursing for telemedicine consults, and more people keep moving to these 60 players, then of course the rest 40 will also come up to a point. Probably they might not give you 100% reimbursement for a telemedicine consult, but at least they'll give you 50% reimbursement.
Thank
That
you.
might
Thanks a
still
lot.
help. Yeah. Thank you.
Any other questions, comments?
You can check this YouTube also if anybody.
Yep. So now I have one question regarding this whole debate of WhatsApp and privacy. WhatsApp and this data has become one of the most valuable assets to the advertisements and so on, like various other aspects of using data. So how does if at all the telemedicines or remote medical advices are happening through WhatsApp, because of course the WhatsApp is extensively used for the businesses, how is it going to affect in current scenario?
So the WhatsApp privacy policy is, if you see, not every doctor is using a business account, right? So most of the doctors could be using personal accounts. Even lawyers, some lawyers use a business account. So only when you are chatting with a business account on WhatsApp is when your information will be shared with Facebook group of companies or Instagram and other the entire ecosystem of cohort of Facebook companies. But that is not diluting the protection. They could be using that information for more commercial purposes. Like there could be how I think Hari mentioned that he gave information, some other service provider reached out to him. That could be the chances of that may increase, and I'm just saying may increase, because if let's say the doctor in the back end has made an arrangement with, let's say, a Practo or whoever else it is, not to name Practo personally, but I'm saying if the doctor has made such arrangements in the background, then that information could be shared by the doctor by the virtue of them being a business account. But as an end user, it is not diluting the protection that WhatsApp will give you. So your information, the security levels from a data security point of view will continue to be there. They're not going to dilute that standard. However, where I'm interacting directly with a doctor who does not have a business account, it's a personal account, then there is end-to-end encrypted. That is not changing. So even if you see, recently WhatsApp did mention that they are not going to change their policy till the personal data protection bill is legislated or something happens, because they are seeing that there's so much of backlash. Even they don't want to be experimenting in the in ambiguity. So they are also taking a back seat and they're taking a step back, and they even want to wait till the actual law comes to prevail, so that then they can tell people with actual facts that what they want to do, what they will do, and what they will not do. So as long as the rights of the individuals are not clear, even WhatsApp has decided to step back.
Okay.
So as an end user,
as a supplementary, if I am not wrong, ma'am, then Google is also facing an ire of the people on the breach of the privacy policies at many places in the different nations at present.
Yes,
because the majority of the browsing and all those things, they are happening on the Google search engine. So
yes.
So even that's a bigger danger than WhatsApp, if it has to be.
It has gone between, I mean, its privacy as well as competition issues have been, filed across the world against these major companies. But yeah, again, as an end user, you have to be very careful. I mean, I'll not say that, it's only the responsibility of the platform or the doctor. I, as a patient, if I'm trusting my doctor, when I'm sending information, I should also be careful in sharing information. I should not be bombarding my doctor with 150 images where he or she has asked me only to send him 3 images. Because at the end of the day, I'm only increasing the task of the doctor to then maintain all that information. That's not fair. So we as a society also have to be more evolved and aware. So sirf milna nahi, it's a two-way street, right? It has a give and take. So we have to, if we are willing to, receive services, we should be behaving properly. Yeah.
So, yeah, actually, you have told that the patient can do check box tick, but it's difficult when the patient is sick. He cannot read many things. He will be paining, crying, etc. So it's a very pathetic situation when his data is lost and his health is poor. I don't know. So that there's a doctor should follow the ethics, or those companies who are taking care of such things, they should follow the ethics, personal ethics. Well, patient will be helpless. He will not be able to read even sometimes. And when he is really consulting this thing, for normal thing it's okay, but when seriousness arises, etc. Normally, whenever we go to the doctor, we never read it, whatever it is, 2-3 pages things, we'll just sign it. So I don't know how to take care of situation.
To be very honest, once a consult starts, a patient does not even have to tick. So ticking is one of the forms. Let's say a patient calls, it's an audio call only. The doctor can only ask, okay, fine, are you agreeing to this telemedicine consult, and are you okay to give me the information? That's enough. So the law says that a log has to be maintained. So at the end of the doctor or the platform, they have to just put a tick mark at their own end. Okay, yes, we asked this question, we have received their consent. It becomes more important because I'll tell you why. Because I mean, like, as an IT lawyer, I'm also seeing all these issues. Cyber crimes are not, unknown to India. And when there are minor patients and all involved, and there's so much of sensitive information flowing, so this becomes a very important step. Ethics will always be there, but just to add an additional rider.
Okay. Any further question about?
And just in continuation of what Jain sir is asking, like, are we, because those conditions are so long and people generally just looking at those, people start to avoid reading those long paragraphs. And most of the times when we create an account, we just simply agree with the terms and conditions and just continue with the things. So, I mean, perhaps those companies take advantage of the people's oversight of not reading thoroughly,
Will write in very small letters.
And even WebEx, the font size is also adding a misery to the problem. That is smallest terms and conditions asterisk.
Make it difficult to read.
The law requires that I won't say that that's how I behave, but most of us lawyers are trying to keep these privacy policies in terms of use to be very succinct, because that's what the law says, that it should be clear and should be comprehensible. If I use language, legal jargon, you will not be able to. When a doctor calls and asks me what kind of pain you are facing, I will not be using medical terms to explain it to them. I will tell them ki yahan pe aise dukh raha hai, pain when there's a bruise. I'll probably using everything incorrectly. So it has to be, what the other person understands. So yeah, that's the attempt is moving towards that. Probably once we have the PDP will come into place, the corporates will be more careful. They'll ensure that.
One more thing I want to add it. So whatever the things are favorable to the patient or his privacy, that should be, as a default, should be implemented without asking even the consent also, because we may not be able to reading so many paras and understanding the language because we will be in panic situation. And last month, 2 months back, it happened with me. I have not reading anything, not surveying the hospital, etc. Wherever I got the admission, I got admitted my patient. So such situation may arise everywhere.
Very true, sir. Very, very true, sir. That observation, because when we go in pain to a hospital, if they ask us to read everything, no, nothing. Yeah.
The law should be such that thing, it should benefit the patient, not the doctor. Patient should be treated perfectly by the doctor. So my humble request there, you people should act like this thing. Because as per you will lose the revenue because you will not have the little low cases.
I have a point. Is there a way to purge my data, to remove my data, to make the company remove my data, or request somewhere so that my data could be deleted from any platforms available?
So if you have a platform, like let's say I have a WhatsApp account tomorrow, and tomorrow I can raise a request for delete my account. So they are bound to remove all the information that they have about me, that I have given them, apart from what they have done in the analytics, that they are not duty bound to remove. But every information that I have given them, they are duty bound to remove that. And like I said, under the PDP bill, there will be a proper right to be forgotten. But it will be valid only through a court enforced order. I cannot randomly walk up to a company and tell them to delete everything that they had on me. So
Understood. Okay.
it has to be.
All right.
Okay, if there is no question, we can go ahead further. Okay.
Yes.
You can thank him.
Yes. It was a wonderful session, ma'am. We thoroughly understood and also got an idea about what exactly the privacy and why it matters. Though whether it is in the context of telemedicine or in various other aspects. So this is really useful, and we will be definitely looking forward to understand it more in the legal aspects. Thank you so much for spending your time and giving a wonderful talk. Thanks a lot.
Thank you, everyone.
Thank you, Director.
Thank you.
Madam Pohan and Mr. Vaibhav for a wonderful session and educating us on this very important aspect where anybody can be trapped. So everybody should be careful. The outcome is that everybody should be careful. But I don't know whether it is possible to do all age of person where somebody can delete or purge this data, but people may not be aware also. So I think some improvement perhaps in the favor of the patient or the user should be taken in this thing. So next session, I think this concluding session is the panel discussion after her talk. So Mr. Mathur, are you here? Mathur, are you listening?
All the speakers,
I am listening.
Panelists, they have arrived, sir.
No, so, you told, suggested somebody should give some 5-10 minutes or somebody before the panel.
You can just discuss for 5-10 minutes. It is already 15:23 or so. 3:30 we'll have to start. Most of the people are, I think, they have joined. Let us see if somebody is missing.
No, I have verified, sir, from the list, Mathur sir, and all the honorable esteemed panelists. They are
Mr.
already
Vikram
there.
Desai, has he joined?
Yes, sir.
Okay.
So, but before a panel discussion, Dr. Sheila would like.
During the panel discussion, we will take inputs from all our participants, whatever they want to suggest.
So, Mr.
If all are there, we can start. And I think we like to join panel discussion. You can ask Amritanshu.
Yeah, Amritanshu, you can
carry out further.
Conduct further.
Sure. So thanks a lot for inviting me, and thanks a lot, Jain sir, for taking out this beautiful journey of last 3 days that we have been going through into the different fields of telemedicine and its applications. And also not to forget the main backbone behind this entire organization of the seminar, especially Anil Mathur sir, and the hosting that is beautifully being done by the entire Space Geeks teams that has been led by our esteemed 3-member team from Space Geeks, Vaibhav Rawat sir, whom I can see on the screen, Hari Tejas sir, and also most importantly, Mr. Chintamani Pai sir. So you all have been a real backbone for the last 3 days, because entire part of this online connectivity has really been possible because of the efforts of your technical advice and the timely technical help and the hosting facilities. So I take this opportunity as we move forward from the regular sessions that we have conducted for the last 3 days to this all important concluding session. Without discussion, everything is incomplete. जब तक समुद्र मंथन नहीं होगा, वैचारिक मंथन नहीं होगा, तब तक विचारों का अमृत और ज्ञान का अमृत आपको नहीं मिल सकता। तो अब हम लोग जिस दौर पर पहुंचने जा रहे हैं, वो 2 दिन की जो मेहनत हमारे इंडियन स्पेस इंडस्ट्रीज एग्जीबिटर्स के तत्वाधान में हमारे अतिथि वक्ताओं ने जो अपने उद्बोधन से समय समय पर विभिन्न सत्रों में हम सभी को एक ज्ञान का जो सागर प्रदान किया है, और जिस ज्ञान के सागर में हम सभी लोगों ने दुनिया के कोने कोने से उसमें गोते लगाए हैं, अब वक्त आ गया है कि उस सागर का मंथन करके उसमें से विषय पर चर्चा करते हुए एक अमृत की प्राप्ति की जाए, जिसको पूरे भारत में एक आरोग्य से युक्त भारत और एक आरोग्य युक्त पूरे विश्व के नवनिर्माण के लिए यहाँ से एक नई पहल हो। So I just would like to take you, because there are still 4 minutes with me, to a small journey that we had undertaken in the last 2 days. So the program that began under the mentorship of Indian Space Industries exhibitors was inaugurated by our chief guest, Shri B.S. Bhatia sir, the former director DECU ISRO Ahmedabad, with a keynote address where he gave all important address on the importance of the telemedicine and all the futuristic plans that come perhaps with this entire field of telemedicine. Then we were being taken deep into the field of telemedicine and its applications by special lecture sessions by Mr. A.K. Sangal sir on India's space program and the history of telemedicine in India. And then that was followed by Dr. Ashwini Goel sir's lecture on Telemedicine Society of India, the training activities, relevance of telemedicine in the COVID pandemic. And that was followed by Dr. Professor S.K. Mishra's very, very important lecture on applications in telemedicine in surgical care and skill transfer. And then on the opening day, this entire session, it was being taken on telemedicine, accessible and affordable healthcare by Dr. Sunil Shroff. And then the concluding session on the first day was by Bijoy M.G. sir on the role of video conferencing in the telemedicine. Yesterday, we had a very interesting entire course of discussion and sessions that were taken on telehealth activities during the COVID-19 pandemic, Odisha experience by Dr. B.N. Mohanty sir. And then Dr. T.N. Ravi Shankar sir gave his excellent presentation on merits, demerits, and the problems associated with the telemedicine network and system. And then Dr. Masood Ikram gave applications in the usage of the advanced artificial intelligence technology in healthcare, followed by Dr. Sanjeev Mehta for telemedicine during and after the COVID pandemic. And then we had 3 very important sessions by Dr. Sandeep Mehta on telemedicine and homeopathy by Dr. Bhaskar Bhatt, Navik telemedicine and COVID by Dr. M.R. Sevaraman, and Professor J. Venkatramayya gave lessons from COVID-19 from community enabling to the counter infodemic. I request hosts to kindly mute all the other people who are there because I am finding too much rebound in the voice. So today, on this final day, we had very, you can say, inciting sessions on clinical applications of telemedicine by Dr. N.K. Agrawal and blockchains in healthcare by Dr. Bhagwant Singh Ratta, and telemedicine, how it really works by Mr. Mayank Agrawal, and televital journey and the latest trends in the telemedicine technology by Mr. Satish Bhatt. And last but not least, telemedicine and the privacy that we just have concluded, taken by Ms. Bagmishika Fuhan. So after all this important session, I welcome all the panelists, the entire audience joining us on the different platforms to this very important panel discussion and the concluding session. To inform you all, we have been joined by an esteemed panel of Dr. S.K. Mishra, Shri A.K. Sangal, Shri Vikram Desai, Shri V.K. Jain, and Shri A.C. Mathur sir. And that will be moderated by Dr. S. Velchami sir as the moderator of the session. Now, let me introduce you to the esteemed panelists who are joining us today, and let me welcome all on behalf of the organizers to this digital dais with a digital round of applause. Dr. Mishra, superannuated on June 30th on Sanjay Gandhi Postgraduate Institute of Medical Sciences, SCPGIMS, Lucknow. He was the professor and head of Department of Endocrine Surgery and nodal officer of SGPGI Telemedicine program, and very hard-working person. We have already heard from him, and he believes in contributing to the science and technology, science and society, and is holding the post of ICMR Emeritus Scientist at School of Telemedicine and Biomedical Informatics, SGPGI MS Lucknow. Welcome, Mishra sir, to this digital platform. I also welcome A.K. Sangal sir, who we all have heard already. Sangal sir also a very esteemed, renowned, retired scientist from SAC ISRO Ahmedabad with a working experience of more than 35 years in the field of satellite communication, education, and telemedicine, and of course, a very well-known figure as a founder member of Telemedicine in India and is an ex-president of TSI as well. Welcome, Sangal sir. And we have heard from you, your comments. We have been enlightened for the last 2 days, and we hope that in this concluding session, you will continue to enlighten us with your observations and comments. Welcome, sir. I also take this opportunity to welcome Vikram Desai sir. Vikram Desai sir, as ex-director of SAC DECU ISRO, and he worked for more than 35 years in the field of satellite communication and education at SAC and ISRO, and he retired as the director of DECU ISRO, and he has been a guiding light for Indian space industries exhibitors as part of the different panel sessions. So welcome, Vikram sir. I also welcome the two pioneering people without whom this entire program or the conceptualization of Indian space industries exhibitors is incomplete. Let me welcome at first Shri V.K. Jain sir. We have been hearing his moderation, but now we will be hearing his comments as an expert panelist. He, with a graduation in electronics and communication engineering and experiences of more than 35 years in the field of satellite communication and payload design, and as retired as a SAC ISRO Ahmedabad as head of division, and currently he's the chairman of Broadcast Engineers Society Ahmedabad chapter. Welcome to the panel, Jain sir. And last but importantly, AC Mathur sir. Mathur sir, who did his PG and UG in mechanical engineering as an engineering background personality from IIT Roorkee, a multi-dimensional, multi-talented personality who has been at the helm of the affairs of the popularization of the different fields of science and technology to the young ignited minds of India, who superannuated as the SAC ISRO Ahmedabad Group Director, serving for more than 39 years, and ex-president of Space Society of Mechanical Engineers and fellow of Institutions of Engineers, and currently, as we all know, he is the managing director of Indian Space Industries Exhibitors Ahmedabad. Welcome, Mathur sir. And now I just would like to invite up on the digital platform the most important person of this entire session, Dr. S. Velchamy sir, who is going to moderate this entire panel discussion or the concluding session, as we can say. Velchamy sir did his post-graduation in chemistry from IIT Roorkee and is a doctorate in management from the South Gujarat University. He has more than 35 years of industrial and managerial experience in ONGC and has written 2 books, published numerous papers in national and international conferences. At present, he is the founder of NGO Kirtan Foundation and is very well active at Trichy in Tamil Nadu. His NGO is rendering the service in nursing care at home, predominantly in the city of Trichy. So I take this opportunity to welcome moderator sir, and I hand over the reins to you to conduct the entire panel, sir. Over to the entire panel. Thanks a lot for giving me this opportunity to welcome.
Thank you very much. In fact, it's a very wonderful introduction of the distinguished panel of panelists who is going to bring out the essence of the entire 3 days of discussion. In fact, it's one of the very difficult and very tough session, rather, I would say. After 3 days of hectic session on different topic, and that too in the afternoon session, I wish that most of us are already preparing to bring out the essence of the entire 3 days proceedings. According to the schedule, we have got around 60 minutes of time, almost around 5 speakers are there. We divide them initially, each one of them can summarize from the whole proceedings, maybe around 5 to 6 minutes of it. Then thereafter, exchange of ideas. We'll have another each one of them, maybe around 3, 4, 5 minutes. One session, or one part of it, component, we'll keep it for the participants' comments, so that the entire summary is brought out very well, and so that it is useful and take us to for the further course of action. I think the introduction of the panelists, very distinguished panelists, I'm afraid how much I'm able to resist them, their idea flow of ideas. But still, I would request all of them to bring out the essential part, so that we take this telemedicine forward, the telemedicine forward concept as a forward, and how to take it to the root, the what you call it as the end users. So what is the bottom line of the pyramid of the society? So that's what we will do it. I think now if we can start with Dr. Mishra is there, Dr. S.K. Mishra. Sir, you can go ahead, sir. You can put your views and summarize the whole proceeding, sir. Dr. Mishra.
I'm there. So I just want to check that my audio is okay.
Slightly echo. If some echo is there, Dr. Mishra?
Yeah, is it okay now?
Yeah, it's okay.
Now it's okay.
Yeah, it's okay. Okay, go ahead.
Perfect, sir. Good to go.
It's quite a good experience of 3 days hectic thing. Today I had some work, so I could not take part in the morning program, but I was listening all the proceedings, but I'm not so much deeply engrossed. So my first view is this is the first occasion where we have very good interaction with the engineers, satellite engineers, and the medical professionals. And almost you can say that 50-50 in that capacity. So one of the objective is to get synergy between the technologists and the applicators. So in that aspect, let me tell you, we have got almost 10 out of 10. So that is very, very desired. Now, not only the satellite engineers, we should also get all telecommunication specialists and people from different background like security, law, and everything. Of course, today we had a different law. Many other areas also people should come, cybersecurity, analytics. So it's a divergent scientific streams. They are playing a great role in digital technology for health. Point number 2, I want to tell you all, it is just not only the telemedicine. I mean, today, when we talk about digital technology for health, it covers a gamut of technologies, all for the sake of the health. I mean, there is a very thin margin between telemedicine and other technology. Let me tell you, whatever you are doing, even if we are talking of influence of the environment, climate, and the health, then also you are applying the entire your remote sensing technology or satellite, on these things. You talk of the epidemics, then you talk of the trend of the disease flow and how this thing happens. So I think there is a totally seamless kind of flow of knowledge and process across various scientific disciplines. Point number 3 that I want to again point it out. Today you have seen that some of these things that we thought this is the technology. Without that, we cannot do telemedicine. So all these things have really kind of changed. So that this point I want to emphasize: the technology is never a constant. Technology is ever changing. Science is ever changing, right? So we have also learned from that how the technology is changing and how we should now change ourselves also to adopt technology. And we also need to discuss with our colleagues, like I gave some opinion yesterday about the role of satellite technology currently in telemedicine or digital health. We need to sit together and work it out. Let me tell you, all of you realize today bandwidth is a very, very useful resource. It's just like a gold, that's very careful about that. Just like oxygen. Without network or bandwidth, you cannot do telemedicine. You cannot do exchange anything. You cannot think of a life without internet, can we? We cannot. So just imagine without oxygen, how our life was during COVID times. Just imagine for a second or for a minute, for an hour, we don't have internet, how the life would be. And the next point I would like to inform you that the technologies of telemedicine has been ever simplified. Today, it is a common man's technology. Like whatever many people have been informed also that we need to educate, and Mr. Mathur also wants to spread it across to all across the country through Vigyan Prasar or through NGOs or self-motivated thing. This is the need of the hour to tell people what you can do, even if you had a very low cost mobile phone, unable to make a WhatsApp, exchange of data, we can really reach across. Another point I would like to tell you, there are rule, regulation, law, etc. Let me tell you, who follows law very strictly? It is the US, it's the Europe, let me tell you. All those countries totally relaxed their law and things during COVID times. So what stopped it? They are so much careful about their security and privacy, everything. What happened? Why they completely diluted the HIPAA? Why they completely diluted all those laws of this exchange of the data and everything? Why they did that? Okay, and we should think about that. Our country, see, nobody bothers. For a poor man, who is going to steal the data? What they're going to do? Let them do whatever they like. He wants to talk to a doctor. If he can make in a mechanism, he can talk to a diabetes specialist to treat his parents. If he can talk to somebody to call somebody to give a physiotherapy for parents, these are very important for us. So we should not bother about, okay, we definitely cannot avoid. We must take a cognizance to the development of the world, what is happening to the law, what is cyber security, what is data privacy, all these things are there and there. We should protect to them. So they don't know about that. But at the same time, we should not be very rigid. Had we been really following very strictly the legal things, I don't think telemedicine would have reached at this point of time. These are a couple of my observations from my side. As you discuss more and more, if I get some more ideas, I can also
Right, sir. Right. Very, very wonderful, sir. Very well summarized. In fact, Dr. Mishra is essentially bringing out the synergy. So that's what really is all is thriving about for the future of it. And then technology innovations and then simplifications to be bring it to the reach of the common man. So I think very well said, sir. I think so you ignited the summary part of it. Now, may I request Mr. A.K. Sangal, sir? Please, sir. Please go ahead. 5-6 minutes. Mr. A.K. Sangal, sir?
Sir, thanks a lot. I'm really elated, especially because from the time of inventing the wheel of telemedicine, I have been associated with this activity. It has been a 45 years of journey. I remember somewhere in the year, somewhere 2000 or so, when I used to go to VS Hospital to convince doctors with a laptop, with a desktop, and some software on it with Dynamics tools on it, talk to doctors there in medical colleges. They will come out from their classes. I'll show them. They were not keen. They say, we don't understand computers. What is there? Our profession is to the surgery and patient care. They were really very afraid. And for a decade, nobody wanted to get into the nitty-gritty of computers. Today, I'm surprised. Our doctors know pretty well more than any technocrats. They have devised, they have the wireless devices are available. Remote devices are available. You can send your data anywhere, anybody, anywhere. Dr. Rata, he has set up a EICU in Pune, in Maharashtra. And the lady there, that she takes care of everything, and all during COVID time also, all the good COVID management was done. So we had a long journey in telemedicine, and I have seen the time when we were thinking of just disseminating the healthcare programs to one-way healthcare program by loaning satellites like ATS in somewhere in 1975. Then we went to the first heartbeat transmission during 1978 using the French satellite from Ahmedabad to Sriharikota. That was a great achievement. And then we started thinking of using it really for interaction between the doctors and the patients, that is the telemedicine. Somewhere in 1995, myself, one of my colleagues, Mr. Venugopal, we are discussing about the use of telemedicine in the Jhabua tribal areas of Madhya Pradesh, where we were working, where we were carrying on the pilot project. We got an idea. We got some mobile systems like Inmarsat handheld with vocoder voice of just for 4.8 kilobytes, and then iridium section, which were used to convey the messages from VS Hospital patient room to Mr. Bhatia. That time he was director. He was elated very much. And that was the launch pad. When we saw the people in Jhabua, at PSC level, the deliveries are being done in the sink of the kitchen, which doctor showed me. And there is no anesthesia there. And the patients are treated, just cut and background tribal music so that they don't get stuck in. That was the scenario. Having gone through that one, I'm so happy that now in 2020, and telemedicine we started in 2001 with the efforts of Shankar Narayan Hridayalaya, AIMS and SGPGR. And then there were some people who were very good, like in Odisha, Dr. Mohanty, he was a grassroots level, very good fellow. And he took today to the telemedicine in the block, up to the block level of Odisha. So is true of Rajasthan. Rajasthan is another model of PPE where the ISRO-based telemedicine, I'm from ISRO, okay, I can say, the network was very good. It was located all districts location, but there was no proper coordination from doctors. It is not the fault of doctors. Doctors are busy with their profession, and then they didn't want to distract. There was no manpower to manage, and then the network didn't survive. However, there was an overlay of the network which was provided by Mahatma Gandhi Institute through PPE network. Now that network, telemedicine network, is working up to the block level. So there are various models I can discuss. There are various models. We had good corporates who have provided us the telemedicine systems. And then we have the knowledgeable people, like today, Dr. Rata. He was talking about blockchain. I was surprised how Dr. Rata knows so much about blockchain. Blockchain in my field, a technology field, where the blocks are independent and you have to, the knowledge is, information individual, it has its own entity and information is stored individually, and it's your duty how securely you transfer the information from one another. And that has given. I think at this time we are sitting at a place where sometimes about 15 years back, we were talking about telemedicine platform to be HIPAA standards and DICOM standard compatible. Now, after having learned about blockchain, being used as blockchain, that insurance interaction through HIPAA standard, and also other things is being taken care of. Now we are in the second version of TPG. TPG has already been notified Government of India for allopathy, homeopathy, Ayurveda, and neurology, and so on and so forth. And they are being used. I was wondering, Bhaskar, homeopathy doctor from Ahmedabad, using telemedicine during COVID, using video conferencing to take care of his patients during COVID and treating them very well, extremely well. So that's the diversity we have in the arena of telemedicine. We have now to get into the second version of TPG, which should include the interaction of telemedicine to be provided by Indian doctors to the people abroad. Okay. I tell you, 2 years when I was president TSI, I got a call from Singapore asking them, sir, can I do the telemedicine from Singapore here? I said, no, sir, there is no law as on today, but at your risk, you can do. I don't say anything. Today, we are at that crux. We need to have second version of TPD, and I'm so happy. Mathur, I'm thankful to Mathur. Mathur was after me, and then I had to sit with him. He was crazy to have this telemedicine conference, and it has successfully done it. Lastly, but not the least, the lady Fokan, she had spoken very well on legal issues, and definitely for any medical advice or medical interaction, legality is important, and that is where TPG was stuck up, and it is clear now, and we should aim it for this thing. Mikram, you are here. In the meanwhile, I should say you are a man of telemedicine. You are one of the medium, you can say the hard worker of telemedicine. Now, why TPG has already been notified by Government of India to be used everywhere. Why Government of Department of Space, ISRO cannot use
Can I interrupt?
the telemedicine, at least by AMO? It should be, the AMO should do telemedicine, give set an example, and then the country will start using, at least in government. That is my observation.
That's a good idea, Sangal sir. Definitely, AMO, we should start with the AMOs, and then they can treat the employees using the telemedicine. Yes, it's a good idea.
Yeah, that's good. Thanks a lot.
Thank you, Sangal Saab, for initially summarizing the entire viewpoint. I think what you have brought out is absolving the technology by the users. So that has been the brought out essence. Besides, you feel that there is a limitations which was there existing before, the legal part of it, legal protections or legal components. So I think now there is a Kickstart platform is available for all of us. So that has been dealt by two people, Pukan as well as to Ravi Shankar as well. So I think next we move on to, can we request Mr. Vikram Desai, sir? Please.
Yeah. Good afternoon to all panelists, participants, and the speakers of this telemedicine workshop. I'm very happy to participate in this final panel of telemedicine workshop arranged by Mr. Mathur. I can say that it's a very important and very good initiatives. And I hope the presentation and lectures from Dr. Mishra, Dr. Mohanty, and Mr. Sangal all must have been listened by the participants, and a lot of experience they must have gained out of it. One very important application of the telemedicine was initiated in 2014 by us at DECO. That was the continuous medical education. And we decided to have one session of CME, that is a continuous medical education, per month at the end of the month. And then we used to hold the program from the teaching end, from the studio, which is a full-fledged world-class studio at the DECO. And then the various hospitals were participating. I can see that I was just seeing that history sheet, and I found that once when then Dr. Vikram Shah, who is a knee surgeon, he was brought in and by us to give the lecture and then share his experience. Some 60 different colleges and then hospitals participated. And then each hospital had some 20 to 30 medical, paramedical staff. So you can see that some at once we can have at least 1,200 people can learn, can have better information on that subject. Similarly, when we had a Dr. Triven Marwa, who is a really expert in diabetes and related thing, when he gave the lecture, a huge number of participants listened the program, and they had a good experience. So this is the thing, in addition to what we were doing during telemedicine session, we had enough bandwidth. We had the teaching end at different places. Teaching end means a specialist hand. Around 300 terminals were deployed. We gave the AMC of it that during that time. I don't know afterward what happened. And some 19 transportable vehicles were there with the good tracking antenna on it. And that is really very good tool for villages and the remote places. Now I can see one thing, that if you see the challenges what we were facing that time, and must be now today also it is relevant. The first is the legal issue. I can see that if you see that, I can this my experience, I can tell you. Once I went with the prescription which was given orally to me by some doctors on telemedicine and went to pharmacy, to get the medicine, I was refused. We cannot give because it's sensitive for medicine. We cannot give it to you on this medicine, on this prescription. So these are the issues. The legal, whether telemedicine is fully legal, whether somebody can go to the court and say that I have been treated by so-and-so doctor using telemedicine application. So these are the issues. And one of the reasons why we were not getting good responses, we were behind the state governments to push the thing, and it was very difficult to take the initiative from the state governments to push the telemedicine program in their state. I can tell you, and then if it is there are some egos, because our models, ISRO's model of telemedicine has a doctor, MBBS doctor at patient end and a specialist at the teaching end, and then there is ego issues. Sometime after, when I sent my social study team, they say that the person who is at patient end, the doctor says that usko kya aata hai, hum to sab jante hain. So these are the issues, means there's ego issues. And then the state government, the doctors, they don't work. They are saying this is additional work to us. Why we should take up this thing? This is additional thing. So in my case, I think we should force state government to put some reward on additional work of telemedicine. If they say it's additional, it is not additional work. But if say this is additional, they should be giving some reward, means some additional money at the end of the month. They should be given that type of money. And then another issue, technical issue, the 5G is coming. So it is not a competition, it's a synergy. We should have the satellite bandwidth, which is very costly and difficult to get. We should use the satellite bandwidth in the villages, in the remote places where there is no 5G, no 4G, no 3G. And then 5G, we should have at the urban areas when there is a possibility to get the 5G equipment, 5G mobile sets, and we can transfer the data, high-speed data on that. But in the villages and in the rural area, we should go ahead with our satellite terminals, which is definitely very useful. Apart from civilian work, we are doing for the armies and the air force in the different and very remote locations of the Himachal, in the Kashmir, in the Arunachal Pradesh. That is required. There is no access of any other thing than satellite communication and satellite hope. With this type of telemedicine workshop and seminars, we should propagate the use of telemedicine more and more, and the people should, and our country should get benefit. Thank you and Jai Hind.
Thank you, Vikram Desai. In fact, it's a wonderful way of how the telemedicine's journey has started in our country and how it has progressed and how you all have put in. I could visibly see that you're all very hardcore workers from the early days, you and Mr. Sangal. So that gives a very satisfying moment, at least for both of you, and maybe in the days to come it will give us. So ultimately what it evolves to is what Dr. Mishra said is the synergy which is going to come into this one. So therefore the law protections or how the law supports the whole issues of telemedicines. I think it's a hint for the ISIE for the future. So there can be a good lawyer for the future. So as it is being thought out for the regional state-wise telemedicine chapters, so maybe a lawyer can be brought in or retired judges or something like that. So it's another is a point to be noted for the future. Another very experienced panelist, what we have amongst us is Dr. V.K. Jain. In fact, he's a well-known amongst the 3 days of participants. He has a lot of views, assimilated views of all the speakers, both from the speakers as well as from the audience. I think we are very eager to hear from you, sir. Jain, sir.
Thank you. Good afternoon, everybody. Again, it's my privilege that I have been given a time for this panel discussion. Basically, my field is not telemedicine. I am a satellite communication system designer. But since last 3 days, I have learned so many things. Many ideas came. Right from I got that whatever the experiment जो इसरो ने जो टेलीमेडिसिन के बीज डाले थे उस पे आप लोगों ने सिंचाई की जो भी टेलीमेडिसिन प्रेसिडेंट सोसाइटी के प्रेसिडेंट्स हैं डॉक्टर्स हैं उन्होंने दे हैव यूटिलाइज्ड इट्स फुली और उसको इतना बड़ा बना दिया है कि नाउ इट इज very 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 much useful to the common man but a lot of issues are to be resolved. Since last 2.5 days discussion, I came to know that a lot of issues are there, a lot of clarity is to be taken. Like Dr. S.K. Mishra pointed out that he wants to do tele-robotic surgery. So he needs a bandwidth of a megabits per second kind of thing, megabits per second. Data rate he needs high. But I think in near future, even it is available nowadays. He did some experiment in 500 kbps at the time of a beginning era. So our ISRO has in fact spread the telemedicine all over the country in India in the beginning, of course. Now this whosoever the doctor is attending, witnessing or participating, they should try to utilize this potential to the possible their extent. Yeah, Sangal, you can switch off. Okay. So this is my observation. Is it so? Anything? Why my voice is choking? Okay. So this is my observation. So many people needs improvement. Somebody needs the refinement in legal aspect, and we have to definitely improve the technology. So it should be even a satellite bandwidth should be available at the cheaper cost. The future high throughput satellites are in the orbit. I don't know, but somebody should explore how they can be used for telemedicine in rural area where there is no connectivity and are they in the area of the Kutch, Marusthul, etc. As somebody says, of course, this can utilize at eastern part. So let us. Whosoever panelist, whosoever the doctor has participated in this event, they should try to resolve the issue in the favor of the common man. And it is possible. Technology can be improved and it should be made much more easier. We should try to include the new means blockchain. We should adopt. Dr. Tata gave a nice presentation. We should imply this artificial intelligence, but of course those things are not very easy to grasp the common man. They should be simplified to the possible extent. Legal issues should be simplified. People are afraid. Telemedicine में अब ये नहीं होगा वो नहीं होगा, but they are afraid. Since last 2 days I am listening to the data privacy will be lost. Certainly it is bound to happen. If it's only tick mark kind of thing, there's certainly, because the pupil will be so much frustrated or patient will be frustrated, they will not listen. They will first need the treatment. So everything should be, what I conclude from this discussion, should be simpler and easier to grasp common man and as well as any even educated person also, because somebody should not commit the blunders of using the telemedicine, and also doctor should be comfortable to adopt the telemedicine in favor of the patient. So this is my one suggestion, and lot many things can be used, and I am happy that UP government has also used 130 note this thing, and they have solved 2,75,000 cases in telemedicine consultation. Odisha government had done a lot of work in this field. So really, it's a commendable. Other state is also doing this thing. I think maybe political region or those things might have not come from these seminars because we might have not got the good advisor from that side for health sector to know about the work. But really, people are doing a very good work. Odisha government has done. Today I came to know the UP government has done a lot of things. They have used ISRO technology also, tele-vita application also. So there's many things can be improved or has been improved drastically also. And our doctors should have the easy access to all the latest in communication thing. So the technologists can play the role, and we should be united. Whatever the requirements of the doctor, they should keep in continuously discussing. So such type of seminar where the doctors and engineers, technologists are available, they should, these things can resolve the issue. This is my request. Thank you very much for giving opportunity to speak this thing. The future situation will be definitely will improve, and teleconsultation etc. will be cheaper, and whatever the like Vikram suggested, some issue of ego issue related etc. These things, there's some human tendency. Some doctors definitely, during this COVID phase 2 experience, I found some doctor definitely consulted, and he gave the consultation on at 2 p.m. in the night. At 11 p.m. night, the doctor gave the teleconsultation to me for my grandchildren. But some doctor doesn't open the message also. So maybe the busy. They may be, I consider they may be busy. They may be something. Even the doctor who is attending my family members in the hospital, they are not replying. But by some other means, I'm getting the information, because that time that there certainly situation become very, very, very this thing tense. So situation of this depends on the human tendency also. Government cannot take care of anything. We have to improve ourselves, and such type of confidence conferences will definitely improve the doctors' natures also, and doctors' sympathy, and we also can understand them. Thank you very much, sir.
Thank you, Jain sir. In fact, it's a very first-hand information which you have shared in terms of telemedicine, your own experience. So there is nothing better than your own experience. So that's a wonderful way of putting it. You have put it in a very common man's expectations. So that's what it is being expected, both from the doctors as well as this one. The next, I think, is a very person of eminence who has got a lot of foresights. Because whom I know very closely, today we think, and which he must have thought it for next 10, 15, 20 years. So the man is none other than Mr. A.C. Mathur. Because he has conceived it, who I know it is sometimes almost 1.5 years or 2 years back. He has been persisting, whomsoever he meets, he has been collecting people, talking to people, getting back the feedback. So that's how he must have had a very tough time in coming to these kind of organizations. So what has brought out to this conference is what are the shortcomings, lacuna, both from the user's perspective, from the doctor's perspective, from the ISRO's perspective. I daily on daily basis, as a part of my work, I interact with a lot of doctors on every day. एक डॉक्टर ने मेरे को पूछा था, भाई इसमें इसरे को टेलीमेडिसिन को क्या लेना देना है? So I think you have to clarify with these concepts. But of course, many of us know. But from the doctors, just simply ask me, I said, भाई उसमें क्या ले है? उसमें. So I think that many times I heard it, I know it. Perhaps for the record purpose also, somewhere if you can bring out all those things, from legal protections to the commoners as well as from the doctors also. So those things are also private. Now I hand over this to Dr. Mathur, A.C. Mathur.
Yeah, thank you, Dr. Velchami, for your nice words. Before I say something, I think Dr. S.K. Mishra wants to say something. He has raised his hand.
Oh, sorry, sir. I didn't notice it. I think.
Mishra ji,
please go ahead, sir. Please go ahead, sir. Mishra ji, are you hearing, sir? Dr. Mishra ji?
Chat box mein dekha.
Sir has to unmute himself first.
Okay. Dr. Mishra, can you unmute yourself, sir? Professor Mishra?
So he must have left, I think.
There may be some sort of an issue, sir. You can carry on with the discussion, and later on you can return to Professor Mishra for his speech.
Okay. As and when he comes, you please the anchor people. Professor Mathur.
Okay. A very good afternoon to all of you. In fact, the idea of having a seminar on telemedicine came to my mind in some time in 2018. That time, of course, COVID was not there. And in 2018 end, I went to Dehradun. In 2019 beginning also, I went to Dehradun, discussed with many people there, because we wanted to have a seminar in Dehradun. The reason was because this technology is being used extensively in the hilly areas, and Uttarakhand has taken a lead, and they are doing a lot of good work in telemedicine. Some patient is there in Mussoorie, top of the hill, and doctor is there at the Dehradun base hospital. So from one hill to another hill, they are making use of this technology very well. So I thought, well, let me have a awareness seminar, because there are many organizations who does a lot of activities in telemedicine. They organize many national, international level seminars. My purpose was different. I wanted to reach at the root level. I wanted to have some activity for the government. At least there should be awareness about telemedicine. The young doctors and the public, they should know what is telemedicine and how it is being used. And with that intention, I started, and since then I am in continuously touch with Sangal Saab and Dr. Velchami. Dr. Velchami, I'm in contact because he is in Trichy already running a NGO based on medical related field, and he has got a many good doctors in his contact at Trichy. And Sangal Saab, because he worked a lot in ISRO in this particular project. So I started my homework in 2019, wanted to have some activity in 2020. Of course, I was taking advice from my colleague Vikram Desai, who was retired as DECO director about the subject, and another friend who was in railway, Mr. Arun Saxena. I was discussing with them how to do this activity. So, of course, in last 2 years, we did a lot of other activities other than these awareness activities. So finally, I thought, okay, let me have activity on online, because physical form, it is not being planned. So with the intention, I started, and this particular technology has been used extensively during COVID time. So I was reading in a lot of newspaper, and government also is after this particular topic. And ISRO, of course, has done very good work in that. ISRO has established satellite system and total ground station technology. There are many companies. When I talk to my colleagues in ISRO also, they say there are a number of companies who have developed all this telemedicine system. ISRO has established so many stations in various states, so many nodes, like in Lucknow, Uttar Pradesh, as Mishra ji has explained, in Odisha, and I think in Northeast also, these things have been established. With all this, I started, I think about 2.5 months back to have this awareness seminar, and I think with a short time I could arrange this event successfully with the help of my team and colleagues like Mr. V.K. Jain, who has taken a lot of pains in organizing this and devoted a lot of time, Mr. B.D. Mehta in this, and Sangal Saab, of course. Then I came in contact with, when I was making the draft copy of the brochure I sent to all these people, I came in contact with Dr. Sharaf. Then he suggested me 2-3 more. He says, yes, Mathur, good, you go ahead, and if you have time, I will suggest 2-3 more speakers. So, okay, I agreed for that also. And then my ISRO retired colleague, they came, like Dr. Sivaraman sir. He says, no, I will also give one talk related with that. And then I came in contact with Dr. Mishra. I talked to him. I asked a time from him on WhatsApp. He gave me time in the night time. We talked to him on phone and readily agreed. And then he says, yes, you do this activity, is very good activity. And I am retiring on 30th June from this post. And after that also, I will continue a lot of activities. I want to work for the science and society. And then he only suggested, okay, you talk to Dr. Monty also, he will also give a talk, or rather I will talk to him. I will talk to Dr. Monty and for delivering a talk. So finally, I could have a total 18 talks, 10 talks by all renowned doctors of the country, and other 8 to 9 talks by the technical team, all engineers and people from industry. And finally, they have delivered very good talks. I am basically hardcore mechanical engineer. I was not knowing ABCD of telemedicine even when I was in ISRO, because our work was totally different and telemedicine was totally different. And there were persons, dedicated person like Sangal Saab for doing these type of projects. And during these 3 days, I also could learn a lot of things related with telemedicine. And as our Dr. Mishra said, in last 3 days, we have brought engineers and doctors at one single platform. And I think it is very good that we have come very close to each other. And my now intention is to have similar activity during COVID time. You know, this is a time when we can popularize this telemedicine and we can make use of this technology. Already doctors are using. Still, there are a lot of people who don't know anything about telemedicine. They are worried to do teleconsultation. So we should have activity on each and every state dedicated. So we can have like 7 to 8 doctors from Tamil Nadu and can have a activity there. Similarly, we can have activity in Gujarat, and we can request our local doctors to deliver talks. And of course, there are people like Sangal Saab who can be a common person for all the places. And our Dr. Sanjeev Mehta, he has shown a lot of interest, which he was not knowing when I started this. And he talked to a number of times. He says, yeah, Mathurji, I was involved in the beginning time. It is good that you are taking up this activity and there is a lot of scope. And we will definitely form a chapter in Gujarat. So finally, this event is coming to an end, and I am very happy that I could rope in all very good doctors for this program, and my team, including Space Geeks team who are based at Bombay. Vaibhav Rao, Chintamani Pai and Hari, and they have taken a lot of pains in providing all technical support, designing posters, etc. So I am very thankful to all these people, and hopefully I would be getting good support and advice from all of you for doing future activities. Thank you very much.
Thank you, Mathur Saab. I think you have put the journey, how it has materialized into this kind of webinar. It's wonderful. I think any session, any conference, any webinar, anything you call it, without the feedback from the participants, whether it is through a invitation or through anywhere else or through the YouTube channels, I think we should have the few of the feedback from the participants as a common participants. If I can have maybe from, I do not know who are all there in this one. If I could, if Dr. Shaila John is there from Shankara Netralaya, if she is there, can we have her viewpoint? Ma'am, are you here? Yeah, very good afternoon. Wonderful seeing you. And perhaps Shankara Netralaya is the one of the early stage who has entered into telemedicine. So you have been hand-holding the entire activity. So I think it's very good of you to join us in this today's evening. We would like to hear from you. It's very lovely to hear from you. Please.
Our program was started by our chairman, Dr. S.S. Badrinath. He was very much interested in teleophthalmology. It was started way back in 2003. And we had a mobile van.
Audio a little bit more clear. Can you just speak more clear?
You reduce the distance of the mic, please.
Can you hear me now?
Now it's okay.
Yeah. Please go ahead. Please go ahead.
Our teleophthalmology program was started way back in 2003 by our chairman, Dr. S.S. Badrinath. He was actually the first president of Telemedicine Society of India. He was very much into teleophthalmology, and ISRO was the person who provided us the satellite. We had a mobile van, and the VSAT was mounted on top of the bus. And we had a room, examination room, and it went from village to village, and it was able to. We also did diabetic retinopathy screening. And I would always thank ISRO for that, because Indian Space Organization only helped us. Because way back in 2003, there was no internet connectivity at all in villages. It was only the VSAT connectivity which helped us. And we have been following teleophthalmology through mobile vans only. Our concept is mobile vans, both in Tamil Nadu and as well as in West Bengal. And this 3 days program is very good. There's been many distinguished speakers speaking on the various aspects of telemedicine, as well as the new technologies which can be applied to tele-education and telemedicine. Sunday I couldn't listen because there was no internet connectivity at home, but I enjoyed the other 3 days. It was a very good program and I really enjoyed it.
Thank you.
Thank you.
Thank you, madam. Thank you. So in fact, you are one of the early users of this one. They took real advantage of this ISRO, then VSAT, and all these communications, both in Tamil Nadu as well as in West Bengal. So very good. I think now you look at the journey, almost around in 17 years. So the journey, how we have matured into it. So there's a long way to go, as the proceedings of the 2.5 days conference has shown us. Now, can we have somebody else who is there? I could see Saijumon from IAST. Is he there? Saiju?
Sir, at present, sir, Professor Jagannath has raised his hand.
Okay. In fact, Mr. Mishra has joined back, sir. Mr. Mishra, I'm not able to see.
Professor Mishra has also joined.
Oh, okay. Let Mishra speak. Let Mr. Mishra speak.
I just lost the contact. So what is the question for me? I want to say something. Okay?
Please, sir. Please go ahead, sir. Please go ahead, sir.
Yeah. So just want to re-emphasize the same thing what I have talked yesterday. So this opportunity actually I want to utilize. So I could see some of the representative from the DECU. So I think the time has come. We have to decide what kind of technology required for what purpose. Okay, am I audible, sir?
Yeah. Very clear.
So when I talk about what kind of technology required for what purpose, so as you know that in health care spectrum, the need for the access to the health are different at different levels, right? Rural areas, high-end ICU levels, they're totally different. So we need to design our platform, right? We want to design our interface. Then currently we have to see that which is more affordable, accessible, right? And keeping all the guidelines for security and etc. So if you see the evolution that has happened in last 2 decades, so like in your own area of work, extended C-band, we have come to the K-band, we have come to very low Earth orbits nowadays. Now think of LEO and all these things, and from very restrictive environment, now you are coming to an open environment. So all these things are also happening in the terrestrial level, and all these things happening in the also other segment of the network. The so-called white space explored by the Microsoft, all these things are, you are better engineers, you know about all this. We just keep on reading, that's why you know about it. But one thing that we have at the application level that we realize, we need cheap, and almost free, you can say. Though I'm paying a mobile phone charges and I have data card that access also, I think it is cheap. It is cheap for me, it is essential. So can we think of something and telemedicine application which are conventional, which are 90% times required, accessible to the health, access to the physicians, right? That is all possible through internet-based telemedicine now. That is the bottom line. That internet is coming from satellite, the internet is coming from terrestrial, the internet is coming from whatever source. That the common man doesn't realize. That you people as a policymaker, you are technologists, technical policy makers, you decide and you contribute to the government where you should apply what, right? For example, I say, next conference, Mr. Mathur, we may organize on satellite technology for health. That has a different connotation than satellite for telemedicine. So we as a doctors, we feel that only the telemedicine can only be done with SATCOM, right? So SATCOM telemedicine, as I told you, is so precious. SATCOM network is so precious. Utilize it where it is required, right? Where we required in the sense that you have just said that Mr. Mathur himself said, the hills. Yesterday I also said same thing. go to the areas of the hills and etc. Go to the maritime thing in the Navy. We go to the areas for where there is an accessibility, glaciers and etc. They cannot just travel in there. We have several of them. Northeast, Uttarakhand, J&K. Also there we have total maritime. We have connected all the lands, what do you call, the lighthouses along with that. So we can really do wonders. In the time of emergency, you also can do wonders, right? Let us make all those boats enabled with connections. They can go on the satellite, they go to the flood areas where nothing is accessible. So please think it over, do a churning, brainstorming, and decide where I should put satellite connectivity for telehealth or for health application in a general. Today we are talking of so many epidemiological problems, whether it is corona, whether it is chikungunya, whether it is whatnot, encephalitis, and we are all full of those things in this thing. And you have such a beautiful sensor technologies, remote sensing, and you contribute so much thing. Many doctors may not be knowing because you are doing in the back end. What public health modelings are being done, people don't realize without a remote sensing thing, we cannot do that actually. They don't know. So we need to also educate them. If you want to really work on public health, you should know about this. In fact, there should be courses in that. You just say health GIS. Health GIS, there's a conference going on in Bangkok every year. Health GIS, how many courses are available? I think while you are educating also, please introduce these courses in your universities. You don't have a ISU like in Strasbourg, but we should think about the Trivandrum Center. Let's have a kind of module there for teaching. Let the satellite engineers coming out of them should realize that what are the different satellite technology are useful for health. So it is just not only telemedicine. Think about satellite technology in general, all technology that you have. We don't know actually what you are doing actually. We are in the back seats somewhere. But you are doing tremendous good work, right? Those things, you are selling those kind of knowledge in remote sensing, and in Hyderabad unit is getting so much of fun for that actually. In fact, Antrix, one of the main sources, this beside launching your satellite. So my only appeal to all of you, because you are the core. I think they're from DECU. I know Bikram. I worked with him for quite a long time. Recently, a new in charge has just joined. I think I saw his name there. So I only request them. I don't think I have not used. Let me be very honest. Let me confess. I never used satellite for the last so many years. Yesterday also I confessed for the last 10 years. So why you are paying unnecessarily the rental charges here and the maintenance charges? Gentleman comes here and get a signature from us and go ahead. Out of all due respect to DECU, we just sign it. But that is not really making any purpose actually. Please do an audit of these things and take them and deploy somewhere where it is required. And kindly look at how you can give us internet. Right? Internet is going to make a level playing field all across the application platform. That's my only appeal to all of us, please.
Thank you, sir. Thank you, sir. I think we are running out of time. Before we conclude it, I think there's somebody else who raised this. Venkatramaya, who wanted to speak, sir. Sir, are you there, sir? Yeah, please speak, sir. Please speak. Please speak.
Very much, sir. I hope I have got about 30 seconds. I have only one observation to make. A positive note, welcome sign. Negative note, no professionalism. Suggestion, you need to learn from others. Telvista, it can cover African continent, and our UP hub can do so many thousands of services. I think we are already on. But let us not have a myth or a wrong belief that ISRO should do, government should do. No, I don't agree with that. Because see, we no longer speak of solar water heaters. You don't require subsidy for that. Once the ISRO has launched these technologies, it is getting into corporate level one to community level another. And what I find a big gap, before I conclude, I want to tell you, the indigenous preventive medical knowledge is one very big gap. It can bulldoze all these multinational pharmaceutical curative approaches. Unless we do this, in my presentation, I have given clearly recommendations. I am of a dream that if Mathur Saab and all of us can make one People Science March as it was done in 1987, when Dr. Gavarikar gave 5 crore from National Council for Science and Technology. I was deputed from ISRO, Professor Dhawan and Professor U.R. Rao. So I have 2 decades of experience in Dr. Kasturirangan, Indian Science Congress. We had telemedicine as a focus. That time Narayana Rudayalaya and all these people came. Since 2 decades, I'm finding VRCC is going behind. I talked to my colleagues at ISRO, ISTRAC. VRC, EduSat, and telemedicine is not a priority. The private people have already taken over. It's the right thing to happen. What is required is bridging community to technology and make it socially relevant and scientific. Thank you very much.
Thank you, sir. Thank you. Very wonderfully, you have summarized it. So what type of technology, and then from not only it's the responsibility of the ISRO, it's as well as to the corporate and corporate to the common man. So it has to become a very prevalent. You should not look for some government or any government institutions to be offered any kind of technologies. It should be commonly available. So I think very well said, sir. I think before we conclude it, anybody else from the audience is there? Any IAST, Saiju Mom or somebody? I think.
I think Dr. Ratta is also there. If he is there, you can take his comment also.
Yeah. Dr. Ratta. Sir, are you there, sir?
Dr. Sanjeev Mehta को भी ले सकते हो आप. Sanjeev Mehta, I think, visible on the screen.
Mehta ji, Sanjeev Mehta ji.
Dr. Sanjeev Mehta is there.
I'm here.
Yeah, please.
Please, sir. Please speak, sir.
Yeah, just I think all the suggestions I totally agree, and the initiative taken by Mr. Mathur, Jain Saab and all, it's a real it has infused a new energy, I believe. So all these 2-3 days were very vibrant. So many good learned speakers, they gave their opinion. And everything should move forward. Means telemedicine should develop in this country, and it should take a big momentum. And whatever way everybody can contribute, it should move forward. Whether government helps or not, we have a desire. I think the solution will keep coming. That's it from my side.
Yeah. Thank you, sir. तो सर आप तो गुजरात के हैं, आजकल तो प्रधानमंत्री भी गुजरात के हैं, तो आपको एक बार थोड़ा धक्का देगा तो आग नजरें लगाएगा तो आगे बहुत बढ़ेगा. So anyhow, it's on the lighter side, but very well.
जब below this candle वो चिराग के नीचे अंधेरा होता है ना.
लेकिन वो अंधेरा ज्यादा ही हो रहा है. गुजरात को कुछ करो.
नहीं, बिल्कुल सब इतने सब एक ही प्लेटफॉर्म पे सब लोग हो रहे हैं और enthusiasm है. तो I think now something can be done. We will discuss regarding these things in the very near future.
Gujarat has been a pioneer in many areas, many fronts, many, whichever the area which they took it up. So
forget about pioneership. Should I tell you the secret? The telemedicine evolved only from Gujarat. Telemedicine evolved only from Ahmedabad. And rest of the thing you can find out from your friend in Gujarat.
That was happening till you were here, sir.
No, even vendors were there.
Any other speakers are there?
Sir, may I add one more point? That is as an addendum to the points that have been put by Professor Jagannath and Professor S.K. Mishra. That when Professor Mishra was talking about the inducing or the inclusion of this telemedicine as a practice and its need now to develop it as we should prepare for a marathon race ahead. And then we have to put it into the form of an education. As today we have brought it in the form of a webinar, we must extend it, and it's you can say I am extending it as a proposal to the esteemed panelists who are here, because you are a part of the a few of you are a part of the educational policy making also. There is a very unique platform that's being introduced on the SWAYAM portal or the book, which is National Program on Technology Enhanced Learning, or NPTEL. So my suggestion to the esteemed panelists here all is that you can all sit together and we can have a discussion, and on the lines a proposal can be forwarded for the inclusion of a specific course on telemedicine and its applications, so that even the common man and the people from the field of the science, technology, medicine, clinical practice, the common people, they can come together, sit on that platform and learn and become more and more enriched on that knowledge on the formal lines as well. Thank you.
Thank you, thank you, thank you. I think just we shoot up by another only 5 minutes. It's not much this one, but what in summary, what I would suggest is taking out all the people who has put forward all those points. The conference, the fruits of it has to be brought out and sent it to the appropriate authorities, so that the channel is sometimes it may be delayed. So what somebody said, Netralia 2003, what has happened after 17 years is it's bearing fruit. So maybe the course of it, as is suggested, that it should be brought into the curriculum, or plus the common man use it, law protection to the users as well as to the doctors. So all those things can be, nitty-gritties can be brought out to the kind of policy, or maybe in terms of law, whatever it is required. So these summary can be brought in terms of bullet points, what most of the experts has brought out. These are the people who are eminent in their own field. It's not an easy opinion which normally it will be easily available. So therefore it has got a very substantial values. So I would request the organizers to bring out in a very good format and send it to the maybe Department of Science and Technology, Health Department, or whatever is possible. So those papers cannot go wrong, and maybe delayed, but definitely they have to act on them. So thank you very much for giving an opportunity to moderate this session. So now I hand over to the organizers, please.
Yeah, Amritanshu, last action is, I think, propose vote of thanks.
So thanks a lot, the organizers. At the outset, I thank the organizers for giving me this opportunity to present a formal vote of thanks to this wonderful session. And every beautiful thing has an ending. And so we have come to the, we can say, grand finale, or the final moments of this great, wonderful journey, where we have seen an amalgam of people coming from the different fraternities of science, medicine, clinical practice, technocrats, and students on the different platforms which have been aided by technology on an online virtual mode. I take this as an opportunity at first to extend my wholehearted thanks to all the 18 speakers, the dignitaries who had given their precious time to this, all the organizing partners, by giving and enlightening the entire, not only 1.38 billion people, but in fact, I shall say an entire population that spreads a pan globe, because net has got no boundaries at all. So my wholehearted thanks are to all the panelists who spoke on the different sessions in their times, and they enriched us with their knowledge on telemedicine and its applications for the common man during the COVID pandemic. Now, on this same pattern, I just would extend my wholehearted thanks, as I said in the beginning of the session, कि समुद्र मंथन जब होता है, अमृत तभी निकलता है. और जिन हमारे एस्टीम्ड पैनलिस्ट ने इस मंथन में, इस पैनल डिस्कशन में, इस कंक्लूडिंग सेशन में प्रतिभागिता करके अपने विचारों को व्यक्त किया, especially the honorable moderator, Dr. S. Belshami sir, we are really thankful to you, and the esteemed panelists, Dr. S. K. Mishra, Shri A. K. Sangal sir, Shri Vikram Desai sir, Shri V. K. Jain sir, Shri A. K. Mathur sir. We really are thankful to you, and also Professor Jagannath Venkatramayya and Dr. Sheila John for giving us, and also not to forget Dr. Sanjeev for giving us your valuable inputs that came out on the course of this entire discussion platform. And now I just also would like to thank all the knowledge partners who associated together with Indian Space Industries exhibitors, especially the Broadcast Engineering Society Ahmedabad chapter, Space Education and Research Foundation Ahmedabad, Space Geeks Mumbai, UL Space Club, and IIT Roorkee Alumni Association Ahmedabad, and Sunrise India Samachar, which was the media partner, and also the Ignited Minds Science Club of India, Prasar network of science clubs under DST, Government of India. So also the three people who held the entire program by their anchoring or the moderation, especially Mr. V. K. Jain sir, Hari Tejas Iyer ji, Vaibhav Rawat ji, and also the person who was instrumental behind shaping this entire program technically, Chintamani Pai sir, and the person who was the real brain in bringing up this entire this conference together on this virtual online mode, not to forget a Managing Director of Indian Space Industries Exhibitors, Shri Anil Chand Mathur sir. So we really are wholeheartedly thankful to you, and also not to forget the audience, the students who joined us on the different platforms, cutting across the generations, cutting across the fields to which you belong to. There you may not be essentially the doctors, you may not be essentially the legal practitioners, you may not be essentially the research scholars, but what I saw was a perfect blend of the people joining from the very school level, ripe age of the school level, to the research scholars. We really are thankful to you, because you really are the strength that gives an internal driving energy to this entire organizing partners for bringing new and new programs time and again. And also this entire setup, I always give a thank to the setup of this teleconferencing module, which we used to say, and today we call it as a Zoom meeting, and the YouTube, which have enabled us to connect across the audience all across the globe. With these words, I wholeheartedly thank all the people who were there behind this program, who were there in front of the presenting screen, and who were there supporting in front of us. So all the three layers of the organizers, all the three layers of the participants are really welcome. And we really promise you that this not just an end, it's just the beginning of a new journey. काफी लंबी यात्रा हुई है और काफी लंबी यात्रा अभी बाकी है. इसरो के द्वारा नर्सरी में लगाया हुआ एक पौधा अभी जो है एक पुष्पित और पल्लवित होकर एक वृक्ष बन चुका है. फलदार वृक्ष तो जरूर है, लेकिन उसका वट वृक्ष में बदलना अभी बाकी है, तो इसलिए काफी लंबी यात्रा अभी बाकी है. So yes, we can say the woods are lovely, dark and deep, but I have promises to keep, and miles to go before I sleep, and miles to go before I sleep. With these words of Robert Frost, I just would thank all the people who were there in this entire course of journey for 3 days, all alongside us. We promise you that we shall be returning back on the very same platform with more and more zest and zeal from the love that we have seen for the last 3 days. Thanks all, and I officially declare the official closure of the session, and request Mathur sir to officially declare the closure of the session. Over to Mathur sir.
Yeah, before that, I would like to thank Mr. Amritanshu also. He has not taken his name. He has told about everybody. We got a lot of help from Amritanshu directly or indirectly, and he has got good command over English and Hindi, and nicely covered the total event. Thank you very much to all of you. Thank you, Jain Saab, Mehta ji and Sangal ji, and all the participants who are attending this particular event. Big thanks to all.
Put your thumbs up and take a clap.
Yeah, so I would request all of you, if possible, if you can switch your cameras on so that we can have a parting photograph, because photography is the best.
Okay.
You have to put off the camera?
They put on the camera, sir.
Okay.
So thanks all. I think Chintamani sir, we are done with the photography session of this final part. And so now I would request you to kindly stop the broadcasting, and we bid farewell to the lovable audience. Thanks all.
Thank you very much. Thank you.
Okay.
Bye. Bye.
3 days event is finally being closed.
Yes.
Officially.